welcome you all. First of all, I would like to congratulate the Ferty9 team for organizing this full-day fertility education program. So let us start the session 1 on fertility capsules. It's my pleasure to introduce our first speaker, Dr. Kavya Reddy. She did her MBBS in Sri Devaraj URS Medical College, Kolar. She did her post-graduation DNB OBGY in Narayana Hrudayalaya, Bangalore. She worked as a consultant in Narayana Medical College for 2 years. She obtained her fellowship in reproductive medicine, Craft, Kodangallur, and worked as a fertility specialist in Craft Fertility Center for 1 year. Welcome, Dr. Kavya. She will be talking on female partner evaluation in the next 15 minutes.
Good morning, everyone. Welcome to the session. Let's start the session. The topic is female infertility.
So, infertility is a serious health worldwide issue which accounts for about 8 to 10% of the couple worldwide. According to WHO, in India, the prevalence of infertility is around 4 to 16%. According to NIH, also it is around 8%. Actually, the female factor contributes to infertility for about 40 to 55%. So, we have to know when to evaluate the female infertile woman. If the patient of ours is less than 35 years and married for more than 1 year and they are trying to conceive without any unprotected for more than 1 year, we have to evaluate this patient. If the patient is less than 35 years, 6 months of unprotected intercourse we have to evaluate. If the patient is more than 40 years, even married for only 6 months also, they have to be evaluated as soon as possible. Immediate evaluation is required. There are certain conditions like where early evaluation is required when the patient is coming with irregular menstrual cycles or cycle length, polymenorrhagia, intermenstrual bleeding, oligomenorrhea, we have to evaluate. We know that certain factors like uterine, tubal factors and peritoneal factors does contribute to the infertility. Any patients whom we know the patient is suffering from endometriosis, like we have done any laparoscopy where we find stage 1 and stage 2 endometriosis also, we have to treat the patient as soon as possible. And patients, couple we are having subfertile male infertility has to be treated. Sexual dysfunction has to be taken in the history. Like so many people don't even complain to us regarding ejaculatory dysfunction, erectile dysfunction, vaginismus, dyspareunia. Clear evaluation of these patients is very much important. And few genetic conditions and acquired conditions we have to know. And chemotherapy, radiotherapy patients, we have to go for early evaluation. Basic history is very, very important, and as well as physical examination. In the history comes to marital history, very important. According to ART guidelines now, if the patients are not more than 1 year of proper unprotected intercourse, we can't even treat the patient. So we have to first ask how many years of they are trying for pregnancy, and length of unprotected intercourse, coital frequency has to be asked. And nowadays people are using so many apps and kits like LH kits. We have to ask the questions so that we will understand whether the kit's been used properly or not. There are false positivity and false negativity rates with this LH kits. We have to train them how to use those kits so that the ovulation can be easily ovulation can be easily by them itself. Patient only can appreciate it. And few apps we won't be able to know the ovulation time properly. The menstrual history very, very important. Even the patient is having irregular cycles also, we will have lack of ovulation. We have to take proper history. Dysmenorrhea history is important because sometimes secondary dysmenorrhea itself causes infertility. Coming to obstetric history, past obstetric history plays an important role. Medical and surgical history, proper weight gain and weight loss, and pelvic inflammatory disease, sexual transmitted diseases, hypertension and diabetes history has to be taken. And previous surgical history and chemotherapy has to be taken. Family history is very important because infertility in the family, or like mother is having early menopause less than 40 years, heritable cancer conditions like BRCA1, BRCA2, we have to evaluate these patients, and proper time management in infertility treatment help them save from so many other factors. Occupation hazard has to be ruled out, and treatment of previous like IUI, previous history of IVF has to be taken. Physical examination, as we learned in our PG days, it is very important. BMI plays a role. Thyroid enlargement can be missed in few cases if we don't examine. Breast examination is must because females don't tell us regarding breast secretions or any lump, they'll be shy to tell, so we have to go for breast examination even in the fertility management. Androgen excess symptoms can be easily visualized like hirsutism, acne and acanthosis nigrans. Pelvic examination is very important to rule out cervicitis, any Y discharge. Y discharge indicates like foul smelling discharge, anything indicates cervicitis, which again because of this there are chances of infertility in these patients. So coming to the causes, tubal factors contributes to 40%, ovarian factors contributes to 40%, unexplained infertility and other factors to about 20%. In ovarian factors, mainly we have to evaluate whether the patient is ovulating or not. In history only we will come to know if the patient is having regular cycle, definitely they are having ovulation. Few patients will use LH kits and serum progesterone levels, whether we have to measure the serum progesterone levels. It is not the 21st day of the cycle we have to measure the serum progesterone. It 1 week before the onset of menses, serum progesterone we have to measure. Only the disadvantages of serum progesterone is on a single day there is 7 times fluctuation of serum progesterone seen in our body. So it's not the value of progesterone, like for example we get 10 in one patient or 1 in one patient. It is more than 3 indicates progesterone has been released, that means ovulation has happened in these patients. And transvaginal scan, obviously when we are following up the patient, ovulation in the transvaginal scan we will easily identify. The LH kits, they have to know how to use the LH kits. As you can see, exactly before the ovulation, 2 days before we have to start doing the LH kits. Unlike early morning sample, it's a midday sample and the evening sample will predict the LH kits. Usually LH search starts in the morning hours. So sometimes when we do LH in the morning hours, we won't be able to even find the 2 lines. So in the midday sample and the evening sample, the search can be easily predicted in the LH kits. It identifies the period of infertility. As you can see in this, there is a like dominant follicle, and in the next picture you can see the ovulation, where you can see decreasing in the size of the follicle. And when you see the scan, you can see identify the in POD you can identify the fluid, which together indicates the ovulation has been happened. And other things are ovarian reserve testing. Whether we have to do ovarian reserve testing for every patient. Nowadays people are getting married very late, and we have to identify which patient is having ovarian reserve decreased, because environmental factors and nutritional factors in nowadays, they are going to affect on our ovarian reserve. Not only the number, the quality of the oocytes have also been decreased. So ovarian reserve test mainly identifies the number but not the quality of the oocytes. So there are risk factors of the patient is more than 35 years, history of early menopause in the woman, genetic factors and fragile X permutations, and other conditions like previous history of ovarian surgery. Salpingectomy does contribute to decrease in the ovarian reserve, because if you are there is decreased supply to the ovarian reserve, then the quality of the oocyte and the number might come down. Chemotherapy, radiotherapy patients and autoimmune inflammatory diseases, laparoscopic ovarian drilling in unindicated patients, some stress also decrease, and smoking history, endometriomas. There is a study which is done, this study is called an error study. In this study what they have done is, they have compared an endometrioma patient and in non-endometrioma patients. Only in a patient who is having endometrioma, you can see there is 26% decrease in the serum AMH levels, which is very much faster when compared to a normal woman. So in a patient who is having endometrioma, ovulation induction and IUI has to be done as soon as possible, depending on the age of the patients. So the main purpose of ovarian reserve testing is, it predicts the reserve, and we can also identify the decreased ovarian reserve patients as soon as possible, and we can coordinate the treatment. And the main part is the counseling becomes very easy after doing ovarian reserve testing and planning the treatment options. So the different ovarian reserve testings, one is a biological test, biological methods, biochemical methods, biophysiological methods. Histological methods are not done. In the biological methods, age, female age is the single most predictor for fecundity. As we all know, the maximum number of oocytes are present in our body around 6 to 7 millions when we are fetus, at fetal life. They become to 3 lakh by the time we achieve puberty, and more than 35 years of age, the oocyte number will be gradually decreasing. As you can see this graph, where you can see the green line, where maximum number is present at 18 to 22 weeks. As the age increases, there is further decrease in the fertility rate. And the dotted line which is present below, this particular patient is have reserve at the birth only very less. So these patients will have more decrease in the reserve when compared to a normal patients. This is a slide where you can see the total number of follicles, where total number of follicles are more. So because of which AMH will be normal. When compared to the other patient who is older, the total follicles are less, so AMH is decreased in this patient. So there are other factors like inflammatory aging, which is being identified nowadays, because our body will have chronic inflammatory changes which is going to happen continuously in the body. Because of these changes, there is a difference between anti-inflammatory factors and pro-inflammatory. When there is imbalance, these particular patients will go for premature ovarian insufficiency. Any factors, any treatment is there to treat this patient? No, it is we are way ahead to maintain the treatment, to go ahead with this treatment. There are no particular interventions in this patients. So this slide indicates when there is decreased follicular pool, like decreased in the ovarian reserve. So first of all, what thing we observe is there is decrease in the AMH in this patient, which further causes decrease in the inhibin levels. So AMH and inhibin both cause negative inhibition on the FSH. There is central inhibition. When there is decrease in the central inhibition, there is increase in the FSH, which we can identify on day 2 of your cycle. So because of which when there is increase in the FSH on day 2 of the cycle, what will happen to these patients? There is early development of the follicles. The dominant follicle, which is supposed to be developed around 12 to 13 days or 14 days, the dominant follicle will be developing around 9 to 10 days only. These people will have decrease in the cycle length. So these patients will have decreased cycle length when we are doing basal estradiol level on day 2 of cycle, where they will have increase in the estrogen in them. So anti-Mullerian hormone, it is easily available now. 5 years back, there are different protocols by which AMH is being done. So there is lot of interchangeability in each protocol being used. Because of the second generation techniques what we are using in AMH measurements, AMH is very easy to measure now. The anti-Mullerian hormone is mainly produced from the granulosa cells which is present around the oocytes. So this measurement of this hormone is very easy, and it is the first hormone to come down, and it is very easy to predict the decrease ovarian reserve. So this hormone normal ranges are 2 to 6.8. It is gonadotrophin independent. Intercycle variability is very less in this particular hormone, and there is the constancy is maintained between the cycle. It is more sensitive than FSH, and it is tends to decline even before the FSH. So like few patients, if we can see AMH, like a 26 year, 27 lady will come, and we see AMH of like 2 one time, and only 1 milligram we can see. Like we have to ask history of hormonal contraceptive pills. Continuous usage of hormone contraceptive pills for more than 1 year. It's more than 1 year, not for 1 or 2 months. There is decrease in the AMH about 15 to 55%, which is observed. So this when the AMH is less, we have to take this following history also. So what is the action of anti-Mullerian hormone? Mainly it acts as a gatekeeper, and it protects the follicular recruitment. It suppresses the cyclic recruitment of the primordial follicle, and it maintains the antral follicular pool. So it has inhibitory effect on follicular activation and growth, and it inhibits the FSH stimulated growth, and inhibitory effect on the aromatase. So as we know, low AMH, we are worried. High AMH also we are worried, because high AMH when it is there, it will convert the estrogenic environment into androgenic environment, which is mainly seen in patients like PCOD. This is also little worrisome. So other factors like a follicle stimulating hormone and day 2 hormone, it should be done together for a better success rate. If follicle stimulating hormone, if it is more than 10 milli international units per day on the day 2 of menstrual cycle, there is poor response to the ovarian stimulation, where we can counsel the patient together with the treatment. Inhibin B, and there are few dynamic tests, they are not recommended nowadays. So this is a table where you can see a normal reserve patient and low ovarian reserve patients. So when the AMH AFC is more than 10, their granulosa cell number will be more than 10. So inhibin will be normal for this patient, and AMH normal. The cycle length will be maintained. On FSH, if you see on day 2, their FSH is less than 8. When it comes to a low ovarian reserve patients, where the AFC is less than 5 to 7, the total granulosa cell number around the oocytes are also less, because of which AMH is decreased. There is decrease in the length of the periods. On FSH is more than 8. Biophysical markers are antral follicular count. It is very easy to measure. Antral follicular count has to be done on day 2 or day 3 of the cycle, which is the basal scan, low intercycle variability, and it also predicts the response to the gonadotrophin on that cycle day. And the normal number of AFC are 10 to 18. Anything less than 7, we should be worried, and more than 20 indicates a hyper response, which is mainly seen in PCOD patients. So when you want to go for one test, whether it is AFC, AMH or FSH, all three are good enough. But if you know, like better scan, if you can perform a scan on day 2 properly, AFC is a reasonable alternative to AMH levels, and it will be easily predicting that particular cycle prognosis in the patients. So ovarian volume, lack of sensitivity exists in ovarian volume, because if there is any ovarian cyst, so we can see different volume. The normal ovarian volume is between 3 to 10. More than 10 is observed in PCOD patients, ovarian cyst patient. If the volume is less than 3, it is a low ovarian reserve patient, or it is seen in the perimenopausal and menopausal ladies. So tubal factors are also be equally monitored, because if there is only patency tube, we can go for any normal treatment like IUI and ovulation induction. Most commonly done procedure is the HSG procedure, where we use a ionizing dye and it is done under X-ray. So it can predict the bilateral tubal patency also, and it also have ability to predict the peritubal adhesions like phimosis, and loculated peritoneal deposits also we can find. This is a picture of HSG, and SIS is an alternative to HSG. All the advantages of SIS is intrauterine lesions like intrauterine polyps can be easily identified. The first picture is a normal SIS. The second, you can identify the polyp in the intrauterine cavity. This is the picture of submucosal fibroid. So next, how do you differentiate between a polyp and submucosal fibroid in SIS? If it is a polyp, it is mostly echogenic to the endometrium. Definitely the polyp is arising from the endometrium. When it comes to a submucosal polyp, it is hypoechoic relative to the endometrium, and it is overlying echogenic layer is present, that is called endometrium. There is only one feeding vessel which is seen with a polyp. When it comes to a submucosal fibroid, definitely you can see a circular type of pattern, and in polyp, there is preserved endometrial and myometrial interface. It is distorted in case of submucosal fibroid. This is a procedure called HycoC. It is an alternative to HSG and SIS. Only advantages of this procedure is no need of exposure to ionizing radiations, no need of exposure to X-ray. So in this procedure, what they are going to do is, there is a foam dye solution. So the foam dye is available in a kit. This can be done as an OPD procedure also. The dye along with the intrauterine catheter, which is provided by the kit only, we can directly introduce this foam gel directly into the uterine cavity. As you can see the 3D image which is present in the next picture, you can take a whole picture of uterus and the fallopian tube. It is the same like SIS, but SIS, what is the disadvantage is, you can't differentiate between a unilateral patency and bilateral patency. Like in HycoC, you can identify the bilateral patency along with intrauterine abnormalities also. So uterine factors are also important. In 16.2% of the patients of infertility are suffering from uterine factors. The most common are polyps, submucosal fibroids, and Asherman syndromes. And before going for a treatment, we have to rule out Mullerian abnormalities, fibroid, endometriosis, adenomyosis, endometrial polyps. So whether you have to monitor the cervix also, hostile cervical mucus, stenosis we have to be making sure before going to the treatment, cervical polyps, and chronic cervicitis. Chronic cervicitis has to be treated. Even though there is no role of anti-sperm antibody, when there is infection, definitely the motility of the sperm will be affected in these particular patients. So there are few tests which need not be done for all the patients who are suffering for infertility. That is, laparoscopy for unexplained infertility is not required. DNA fragmentation test is most commonly misused test nowadays, not for all the patients. Postcoital testing is not required. Thrombophilia profile and karyotyping is not required until the patient is having previous history of recurrent pregnancy loss. Endometrial biopsy and prolactin. Prolactin need not be done for all the patients, only if the patient is having irregular cycles and galactorrhea and complaining of severe headache. So as a rule out as a fertility profile, we have to do the prolactin levels. So the summary is, female age is most important factor for the fecundity and the fertility. So we have to categorize the patients into normal fertility women and abnormal fertility irrespective of the age, I say, because nowadays irrespective of the age, the female fecundity is decreasing, and AMH, AFC are most sensitive and specific tests which can be used for the ovarian reserve testing. And markers of ovarian reserve testing are good predictors of oocyte yield, and they are poor independent factors for reproductive potential. Just because AMH is less, we can't tell the patient you can't go for the treatment. We have to give the treatment for this particular couple. HSG and SAS can be done to evaluate tubal patency with equal effectiveness. So every couple deserves bundle of joy. Thank you.
And it's a very nice talk. She stressed upon the importance of history, physical examination, and brought out the differences between the points that need to be brought out in a very nice, clear way. I know that she has a very bright future ahead of her. Congratulate you once again. Let me introduce the next speaker, Dr. Varsha Baste. It's a proud privilege to introduce Madam, for she has been a fertility specialist for the last 30 years. She is a director of Baste Maternity Hospital and Pushpa Fertility Center, and she has to her credit the first ICSI PGD baby born in North Maharashtra in the year 2003. And she was a past president of OBGY Society Nasik in 2014. She was a chairperson of Foxy IAEC between 2019 to 22. And she was a recipient of prestigious Dr. Anandabai Joshi Award amongst V First 3 Puraskar by Honorable Governor of Maharashtra, Foxy Champions of Foxy Award, Foxy Excellence Award for outgoing Foxy chairperson, and she has organized many national international conferences, participated in numerous national and international conferences. With this brief introduction, I present Madam to you all.
Pleased and I'm really happy to be here in Vizag. This is the first visit of mine to Visakhapatnam. The history of Visakhapatnam I have studied in my childhood, and I was really fascinated to visit this first ancient port of India. And I'm really thankful to Dr. Jyothi, Dr. Kavya, and the team, and Vizag, Dr. Niharikan, sir, for inviting me and giving me this opportunity to talk in front of this August gathering. Thank you. I've been greeting from Maharashtra, Nasik. That is the city of winery. My topic given by Jyothi and Kavya is really good. It is pertinent to be discussed, very much important and devastating to the patients also, and concern for the doctor also. So recurrent pregnancy loss. It is when more than two consecutive losses occur prior to 20 weeks of pregnancy and affects 1 to 2% of women. About 2 to 4% of RPL is associated with parental balance, structural chromosomal rearrangement, reciprocal and or Robertsonian translocation, and mosaicisms. The etiology is mainly altered maternal environmental conditions like infection, anatomic, endocrine, genetic, and immunological abnormalities. Embryonic defects like chromosomal abnormalities. The etiology mainly of dear chairpersons, because I have seen they are so well read and educated and highly qualified chairpersons here. Parental chromosomal abnormalities, untreated hypothyroidism, uncontrolled diabetes, uterine anatomic abnormalities, and antiphospholipid antibody syndrome. So this is very important slide. The organization of care. Pregnancy loss is a significant negative life event, and repetitive nature of repeated miscarriage may intensify the grief experience. Studies have mostly focused on women, and there is need for studies on emotional impact even on men. Clinician and clinic should take the psychological needs of couples faced with RPL into account when offering and organizing care for such couples. Now, I am going to talk about this topic into two portions. One is we will be just highlighting the ASHRAE guidelines. They are not laws, but they are guidelines. You may or may not like it, but many people have come together from different countries and they have formed the guidelines. So this is the pictorial summary of recommendations for investigation and treatment of couples with recurrent pregnancy loss according to ASHRAE. You may or may not like it, but they are there. So recommended tests are antiphospholipid antibodies. You have to give low dose aspirin and prophylactic dose of heparin. Then thyroid abnormalities, you have to treat hypothyroidism with levothyroxine. Uterine abnormalities, effect of surgery is inefficient, evidence based. Then few tests which are to be done just as a for record, or like genetic test, genetic counseling and information on PGT to be given. Immunological test, no specific treatments are available. Sperm DNA fragmentation test, the lifestyle advice to men, and antioxidants. Then screen for hereditary thrombophilia. So these are the recommended but not very essential tests. And not recommended tests are other immunological tests or metabolic or hormonal tests also. For all these tests, we have to give lifestyle advice, tender loving care, and prophylactic vitamin D. That's all. That is what ASHRAE says. So what, according to ASHRAE, which therapeutic intervention should be offered to couple with repeated miscarriage? We are not saying RPL nowadays, due to genetic and chromosomal causes to increase live birth. There is a limited evidence for pre-implantation genetic testing in couples with RPL shows no clear benefit of treatment. Couples with results of abnormal fetal and parental karyotype should receive genetic counseling. Then what about thrombophilia? For women with hereditary thrombophilia and history of repeated miscarriages, we suggest not to use antithrombotic prophylaxis unless in the context of research or if indicated for venous thromboembolism prevention. For women who fulfill the lab criteria of antiphospholipid Apla syndrome, have a history of 3 or more pregnancy losses, we suggest administration with low dose aspirin 75 to 100 milligram per day starting before conception. And once she gets pregnant, then we have to add unfractionated heparin or low molecular weight heparin when she gets pregnant. The guideline development group is very important for ESHRE. Suggests offering anticoagulant treatment for women with 2 pregnancy losses and antiphospholipid syndrome only in the context of clinical research. Now, what about immunological background to increase the live birth rate? No immunological biomarker except for high titer antiphospholipid antibodies can be used for selecting couples with RPL for specific immunological treatments. But these are guidelines, these are not the laws. At our center, we do give this immunological and this the immunological treatment, like we segregate lymphocytes from autologous lymphocytes and we give it to patients, getting good results. Also, activated cytokine release serum we are using and it is also giving us good results. Then what about metabolic and hormonal abnormalities to increase live birth rate? Overt hypothyroidism arises before conception and during gestation should be treated with levothyroxine for such patients. There is conflicting evidence regarding treatment of this with levothyroxine with patient with subclinical hypothyroidism and RPL. The treatment of the women with subclinical hypothyroidism may reduce the risk of miscarriage, but the potential benefit of treatment should be balanced against risk. Patient with subclinical hypothyroidism get pregnant again with after miscarriages. THS should be done in early gestation and hypothyroidism should be treated. Patients with thyroid autoimmunity or antibodies, they get pregnant again. Thyroid and TSH levels should be checked in early gestation. Hypothyroidism should be treated with levothyroxine. There is insufficient evidence to support treatment with levothyroxine in euthyroid women with antithyroid antibodies and outside a clinical trial. But at our center, we do use this precursor of L-tyroxine and that along with this L-toxin or levothyroxine, it gives better result because we are adding something extra instead of only giving levothyroxine. Now, what about metabolic and hormonal abnormalities to increase live birth rate? There is insufficient evidence to recommend use of progesterone to improve live birth rate in women with RPL and luteal phase insufficiency. I am not saying this, ASHRE guidelines. There is insufficient evidence to use SCG to improve live birth rate in such patient and luteal phase insufficiency. There is insufficient evidence to recommend metformin supplementation to prevent pregnancy loss with glucose metabolic defects. But bromocriptine treatment should be considered with such patient and hyperprolactemia to increase live birth rate. Preconceptional counseling is a must and prophylactic vitamin D supplementation should be given to all such patients. Now, control ovarian stimulation by HMG could be beneficial for decreasing the chance of next pregnancy loss because we are increasing the quality of oocyte. But there is insufficient evidence for its use in PCO patient according to ESHRE. What about such patients with uterine abnormalities to increase live birth rate, whether histoscopic septum resection as benefit should be evaluated in context of surgical trial in women with RPL and septate uterus. Metroplasty is not recommended for bicorporal uterus with normal cervix. Uterine reconstruction is not recommended for hemiuterus. There is insufficient evidence in favor of metroplasty in women with bicorporal uterus and double cervix. Insufficient evidence supporting histoscopic removal of submucous fibroid or endometrial polyp in women with RPL. Surgical removal of intramural fibroid is not recommended. There is insufficient evidence to recommend removing fibroid that distort uterine cavity according to ESHRE guidelines. Insufficient evidence of benefit for surgical removal of intrauterine adhesions also. After histoscopic removal of intrauterine adhesions, precautions to be taken to prevent recurrence. In second trimester patient with losses, suspected cervical weakness should be offered serial cervical sonographic surveillance. The importance is given on cervix. If women with singleton pregnancy and history of recurrent second trimester loss attribute to cervical weakness, a cerclass should be considered, and there is no evidence that this treatment increases perinatal survival. So now, cervical measurement, short cervical length by TVS between 16 to 24 weeks is a must because it is an accurate predictor of recurrent miscarriages. A threshold of cervical length at 24 weeks is defined as 2.5 centimeter, 2.25 mm with 37% sensitivity and 92% specificity. Knowledge of cervical length has also reduced the risk of preterm birth before 37 weeks. Cervical length less than 15 mm reported as most optimal cutoff with 81% specificity and 83% predictive for true miscarriages. Cervical elastography is also given importance in abroad, but we are not doing it. It is not very well available easily. We all know short cervix, funneling of the cervix, or bulging of the membranes. That tells us about the cervical weakness. Ability to accurately predict and prevent RPL in second trimester remains one of the crucial challenges in modern obstetrics. Recent systematic review has confirmed the accuracy of fetal fibronectin. Also, it is used for preterm predicting the preterm birth. And transvaginal sonography for cervical length is a predictive value of in symptomatic patients for recurrent miscarriages. Adding absence of this is not that much important, but we have to do the cervical weakness evaluation. Now, what are the preventive measures for second trimester miscarriages? Progesterone and cervical cerclage. Progesterone is a magic pill. Natural progesterone offers complementary anti-inflammatory, anti-modulatory, uterine quiescent action. How does it affect? What is the action? It inhibits oxytocin activation, prostaglandin production, inhibits GAD junction, inhibits cervical ripening by down-regulating production of cytokines, inhibits connexin 43, gap junction protein. So what is the optimal dose, base troop and formulation? Available as natural progesterone from soya beans and Mexican yam roots also can be used, but we have to add progesterone. The half-life is increased with metabolite like allopurinol. Micronization decreases the particle size and enhances dissolution of progesterone, also offers greater bioavailability up to 33% and improves the half-life kinetics from 4 to 18 hours following oral injection. Now we are getting patients from remote places. They are not ready or they are not comfortable for vaginal insertion of the tablets or injections. So this is the very good option for them. So better tablet once a day because it has got prolonged action and it is really benefited for the patients coming from remote places. Vaginal progesterone can reduce the risk of spontaneous abortions. A systemic review and meta-analysis in 2016 of randomized trial said that the women with progesterone support with short cervix reduce the frequency of spontaneous RPL less than 24 weeks by 37% and reduce the composite neonatal morbidity and mortality by 41%. So it is really good to use progesterone. Now, cervical stitch or stitch in time. Indicated cerclage in first trimester, history based with questionable indications, benefits and controversial intervention. Prophylactic cerclage history suggests with short cervix on sonography. Rescue cerclage, patient presents with already dilated cervix, bulging membrane but no sign of pain, infection or bleeding. Second trimester, miscarriages. Anatomic abnormality responsible for 10 to 15% of recurrent abortion. The causes may be congenital defects in uterine duct fusion like unicornuate, bicornuate, septate or double uterus, acquired intrauterine adhesions, uterine fibroids, endometriosis or cervical incompetence. Defect of Mullerian fusion like double uterus, septate or bicornuate uterus, about 12% cases suffer from recurrent abortions. Implantation on septum leads to defective placentation. Asherman syndrome, intrauterine adhesion due to previous curettage can lead to early miscarriage because of less vascularization. Transvaginal ultrasound is useful for the diagnostic. Hysteroscopic resection of septum and division of adhesion in Asherman syndrome is indicated. Submucous fibroid managed by myomectomy. So this is the way we diagnose them. Now, cervical insufficiency or incompetence. Painless cervical dilatation with ballooning of amniotic sac into vagina followed by rupture of membrane and expulsion of fetus occurs around 16 to 24 weeks for such patients. What is the cause? Congenital, maybe developmental weakness of cervix or uterine abnormalities, acquired iatrogenic because of DNCs, induced abortions, vaginal operative surgery of undilated cervix, amputation of cervix or cone biopsy, multiple gestations or prior preterm birth. Now, diagnosis. Repeated missed trimester, painless cervical dilatation, escape of liquor amni followed by painless expulsion, that is indicative of cervical weakness. Internal examination, passage of 6 to 8 agar dilatation beyond internal os when she is not pregnant, we have to diagnose it that way. Funneling of internal os seen in HSG. During pregnancy, clinical digital painless cervical shortening and dilatation is indicative. Sonography says us if the short cervix less than 25 mm and funneling of internal os more than 1 centimeter. How will you manage? Surgical management, usually around 12 to 14 weeks. The procedure reinforces the weak cervix by non-absorbable tape. Mind well, friends, don't use simple Prolene or other. You have to use Marceline tape because she is a case of repeated miscarriages. So you have to give good competency to the cervix. So this is the incompetent cervix herniation of the membrane and competency is restored after encirclement operations. So contraindication, infections, rupture membrane, vaginal bleeding, severe uterine irritability or cervical dilatation more than 4 centimeter. Two methods we know, McDonald and modified Chirodkar, also abdominal laparoscopically. Success rate is around 80 to 90% if done properly. Now, types of cerclas, history indicated definite history of 3 previous cerclas losses we have to give irrespective of cervical condition. Ultrasound indicated short-ended cervix or early funneling and also the history. Examination indicated for rescue cerclas performed after cervix is fully dilated, cervix is found dilated or also called emergency cerclage. So, McDonald operation, we do anterior knots, the modified cerclage, we take an incision and subserosal layer and the knot is posteriorly. Transabdominal cerclage, rarely done in cases of repeated failure of vaginal approach. Cerclage is placed at the level of isthmus and we have to take her for C-section. Now, what is the post-operative care? Patient should be in bed for at least 2-3 days. Progesterone supplementation, weekly injection of 70-alpha hydroxyprogesterone caproate, 500 mg intramuscular, do not give 250 mg. Patient is asked to avoid sexual intercourse. Removal of the stitch should be around 37 weeks or earlier if the pain starts or feature of abortion appear. If the stitch is not cut in time, uterine rupture or cervical tear may occur. What are the complications? Slipping or cutting through suture, choriamnitis, rupture of membrane, cervical scarring, dystocia require cesarean section. What is the prognosis of recurrent miscarriage? The overall risk of miscarriage is around 20 to 30, 25 to 30% irrespective of number of previous spontaneous miscarriage. But the overall prognosis is good even without therapy. The chance of successful pregnancy is about 70 to 80% with effective therapy, but we have to be very vigilant. Now, rescue cerclage is bed rest needed, not at all, but you have to be cautious for 1 or 2 days. Recommendation of rescue cerclage, no clear evidence about gestation at which cerclage is most, anytime you can give, but this the cerclage is done before 20 weeks. If it is done emergency cerclage, likely to result into preterm delivery before 28 weeks. Decision to take rescue cerclage beyond 28 weeks is individualized. Age of neonatal survival is and availability of NICU facility. Rescue cerclage is not done in prevent in infection, bleeding, or uterine contraction. Discussion with neonatologists and gestational age should be around 16 to 28 weeks to get better outcomes, and counseling is also very important. So these are the nice guidelines when to give rescue cerclage. If there is a history of preterm birth or miscarriages, repeated miscarriages, cervical length less than 25 between 16 to 24 weeks, go ahead and give do the cerclage. Now, progesterone deficiency in RPL, very important. Luteal phase defect is a condition in which inadequate production of progesterone occurs, consequently results in inadequate development of endometrium. Several studies show less progesterone level seen in patient of RPL named luteal phase defect in recurrent first trimester spontaneous miscarriage. Corpus luteum is needed for maintenance of hormonal support in first trimester until trophoblast is capable of assuming function. So that time you have to give external support with progesterone. So what are the treatment options in recurrent miscarriages? Antibiotic with anticoagulant, supportive care, progestrogens. These are the effects of progesterone in recurrent miscarriage. Progesterone also has large range of effect on uterine blood flow, uterine artery endothelium, and smooth muscles of uterus to promote implantation and pregnancy development. So it is very, very important to add progesterone. Now, choosing the right progesterone, criteria for doctors is different. Patient will say convenience, ease, result, and availability, cost also effect. What are the formulation? We know injectables, vaginal, oral. Oral micronized, and oral dydrogesterone. The which one to use? Now, oral micronized, there is a poor bioavailability, higher dose is required, there are side effects like drowsiness and sedation, and also not approved in pregnancy indication. There are zero publications. It is available only in India, but I will say go ahead and use it because it is needed for certain sector of patients. Oral dydrogesterone backed by evidence. It is approved in pregnancy indication, threatened or recurrent miscarriage, and also progesterone deficiency. More than 600 published articles are there and available in 100 countries all over the world. So better option because it has greater bioavailability, around 28%, effective at low dose 10 milligram. Even Foxy recommends use of dydrogesterone and negligible side effects because it minimizes unwanted effects. Also, detrimental effects of metabolites like adverse effect of pregnancy outcome with oral micronegestrone and low pre-implantation rate is seen with oral, that is what is the study says, but oral dydrogesterone major metabolic support, metabolite supports the pregnancy to conductive of successful pregnancy. Also, the nitric oxide synthesis improves the endometrial receptivity and pregnancy outcomes. So, this is the evidence of comparison of this both. Global guideline recommendation favor dydrogesterone in repeated miscarriages. European Progestin Club guidelines for treatment of recurrent miscarriage 2015 said that for women presenting with clinical diagnosis of recurrent miscarriages 3 or more, there is reduction in rate of miscarriage with the use of dydrogesterone. What does Foxy says? Foxy published the statement in 2015. The use of progesterone. Dydrogesterone to be used 10 milligram twice a day till 20 weeks of pregnancy according to Foxy. What does Asian guidelines say about recurrent pregnancy loss? In 2017 they published that vaginal progesterone during early pregnancy has no beneficial effect in women in unexplained RPL. There is some evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. So these are the guidelines and these are the reports or evaluation and their suggestion. But we have to be practical, we have to see what our patient needs and we have to take a call what our personal practice and our experiences tell us to go ahead and use whatever formulation is you are compatible with. Thank you for your patience here. I am coming from Nasik, from this place, and I am going for the post of Foxy Vice President West Zone. मेरा चेहरा देखना और सिक्का मारना. Thank you.
Not the law, the guidelines, they are not the law, but just the recommendations by a group of experts from different societies.
Yes.
And you have nicely told about even the importance of cervical cerclage, its success rate if it is rightly applied, and also the various routes of progesterone and the types of progesterone that are recommended by various guidelines.
So nicely summarized, madam. And
After an IVF, they are giving oral dydrogesterone, vaginal and injectable, HCG, everything. Is it a protocol to give all the things?
very good question, madam. We ART specialists are very much afraid, and we tend to use masala. कुछ तो भी use होगा. But actually the lotus studies, large lotus studies have told that only duphaston or this dydrogesterone is enough, and you need not use vaginal, injectable and everything. Only little bit means 20 milligram of progesterone, even 10 milligram is also sufficient. That is what are the lotus large studies approved. They were conducted all over the world, even in India.
We being the basic obstetricians, we can also use masala for recurrent pregnancy loss, I think.
Yes, madam.
Then the patient will be
we tend
satisfied.
to over treat the patient than not to giving them treatment. Even the antioxidants, everything.
Sorry, Basde, up till now people were using and relying on lotus trial. But this is the trial that has come only in last 10 years. Since 50 years there were no trials. And the progesterone is considered as very safe. And that is the drug. If you see the recent article, the dydrogesterone causes cardiac malformations in the baby. And if the patient files a SUE, you are nowhere. And that's why please beware of using this drug. If the child gets malformation, then you will not be eligible to say anything in the court of law. And the progesterone is the drug of choice. Always. I'm not against dydrogesterone.
Sir, you are absolutely right.
And what you say is that in India, so many patients refuse for oral tablets. This is my standard statement that if you give the pregnancy, they are ready to do whatever you say. But you have to give with the pregnancy. And vaginal progesterone, I'm using since more than 20 years and I've never failed in it. All my patients are using vaginal progesterone. So you have to insist, because the vaginal progesterone has got an aftercare mechanism and you don't require to go for the serum levels of the progesterone. The uterine levels are quite very high, and that is why the dose is very sufficient. While if you compare the recent two papers which have come, that 10 milligram 3 times a day dydrogesterone is insufficient in causing the in-phase endometrium. That is 23 paper which has already come. So please evaluate the subject very well and then only use the drug.
High level of anti-thyroid antibodies causing pregnancy loss. But as far as treatment is concerned, you only told levothyroxine.
What I said, that only instruction and levothyroxine will not suffice.
Yeah.
You have to add, what we do at our center, we add precursor of thyroxine, that is etiroxine, along with etroxine to improve the results. And we have seen very good results with the combination of these two for anti-thyroid antibody patients.
Decreasing the antibodies.
Yeah, but then no, they just go increasing the dose of etroxine, but you have to give combination that definitely helps reduce these miscarriages because of anti-thyroid antibodies.
Errors in this case.
Yeah, for several cases it is needed.
Methyl prevention and others.
Yes.
Thank you.
So we all are getting fascinated by dydrogesterone because of its immunomodulating reaction. Of course, the progesterone in vaginal repressed form also has immunomodulating reaction, but it is proved that if you really want an immunomodulating reaction, in contrary to the injectable, dydrogesterone can take place of that. But as sir suggested, there is a caveat. That is a problem. So, another product, the vaginal progesterone, using too much high dose of vaginal progesterone are two. One, it has been noticed that if using too much vaginal progesterone, it increases the uterine contractility. So here, it can hamper the implantation. That's the one thing. And second thing, the quick levels are achieved with the vaginal progesterone. So there is a rapid secretory transformation. Probably, theoretically may disturb the window of implantation and because of the rapid transformation. So rationale of usage should be there, and you should use what works well in your opinion.
My question is, what is the single genetic test for parents with recurrent RPL and what is the best test for POC?
Because we as fertility experts, are very careful about luteal phase support. When the patient comes to us with lot of issues, so any outside we go to the country and learn some new things, we try to implement on our patients. Like my own examples, 4 years back, it was spoken so much about only oral and vaginal. We came back and did it in our practice. But for our women, somehow there is breakthrough bleeding, recurrent miscarriages. Last issue, just 3 months back, they highlighted very well that IM is the one which scores most for control of serum in the progesterone in the blood. So whatever said and done, I think, madam, you will be seeing prescriptions of IM progesterone or aqueous injectable also. In our country, the temperature, our race is different. So outside they even speak, but still everywhere IM or aqueous, the IM preparation scores best for a luteal phase control. That should be our take-home message. But of course, withdrawing from IM is also a big task. So we are doing once in 3 days, weekly twice, along with vaginal preparation. So now dihydrogestin has come new. There are so many issues, pros and cons about it. But it will take more time for, something has to come as a game changer. I know it's very painful, but the end of it, after 10 years of struggle, after so much of egg pickup, I think weekly twice is worth it. That's what we practice now. Thank you.
Dr. Kiranmai to honor Dr. Varsha Baste with a memento. I request Dr. Ragasudha ma'am to give a memento to Dr. Kavya. I request Dr. Jyothi to give a memento to Dr. Ragasudha. So, thank you so much. We move on to the former Emeritus Professor of NTR Health University. She's been awarded Visakha Ratna by Rotary Club Ladies Wing Vizag, and Madam has presented papers, posters in different state and national conferences. We welcome you, ma'am. Our next chairperson, Dr. Krishnamma Madam. Madam is the former professor and HOD of Obstetrics and Gynecology, Andhra Medical College. She is the past president of Vizag OG Society. She is a laparoscopic surgeon with proficient in hysteroscopy. She is the member of Visakhapatnam District Maternal Mortality Review Committee. Welcome, ma'am. I next invite Dr. Sita Ram Raju sir. Sir is a senior gynecologist and the current president of Obstetric and Gynecological Society of Vizag. He has an experience of 3 decades and has presented many papers in state, national and international conferences. Welcome, sir. I next invite our next chairperson, Dr. Vidya Rama Madam. Madam is the Associate Professor of Obstetrics and Gynecology, Andhra Medical College. She is the co-editor of Handbook on Obstetric Emergencies and Intrapartum Care. She has published papers in national journals, participated as faculty in national and regional conferences and CMEs. Welcome, ma'am. Yes,
Good morning to all the delegates. Now I am going to present how to evaluate the male fertility. In our routine clinical practice, we often evaluate the female factor extensively, but we fail to evaluate the male factor. In almost 30% of the cases, male factor is only responsible for the infertility. So, almost in 27 million couples in India are suffering from the infertility. On the other hand, infertility is rising in the Indian men. A meta-analysis in 2022 led by Hagi et al. Reported that sperm concentration declined by 53% over the past 40 years. 1 in 20 men currently facing the reduced fertility. The use of ART is increasing at a rate of 5 to 10% per year. Coming to the etiologies of male infertility, it can be pre-testicular, testicular or the post-testicular. In the pre-testicular causes, it can be hypogonadotropic hypogonadism, or in the testicular causes, it's like Klinefelter syndrome or testicular tumors, or in the post-testicular causes, it's like infections of the epididymis or the ejaculatory disorders. So these are the factors that are associated with the male fertility. So in almost 30% of the cases it is idiopathic male infertility. So we don't know the cause of the infertility in 30% of the cases, and mal-descended testes, urogenital infections, hypogonadism, all these are associated with the male infertility. So today our contents or discussion will be, is routine semen analysis is enough? Shall we do DFI for all? When to start our hormonal evaluation, imaging and genetics in the male infertility? Whether we can treat the sperm or we can treat the man. So what the guidelines say? So coming to the components of the evaluation. From the history, physical examination, semen analysis, advanced sperm function test, endocrine, genetic ultrasound and the testicular biopsy. These are the things that we have to evaluate. First is the history. In the history, age is very important factor. Like in the females, in the males also, as the paternal age increases, the sperm chromosomal anomalies will increase, and the trisomy 21 and the achondroplasia, all these will increase. In the sexual history, we should ask about their libido, any erection problems, ejaculatory problems, timing and frequency of the coitus we have to ask. And in the family history, like history of infertility in the female, in the family members, mainly in the male siblings, and cryptorchidism, congenital absence of the vas difference, all this will run in the families. In the past medical history, any history of diabetes, hypertension, all this will ask. Then coming to the any usage of antihypertensive drugs, antidepressants, anti-epileptics and antiviral drugs, and any exposure to the tobacco or excessive usage of the smoking, caffeine consumption, stress or exposure to the pollutants, all we have to ask. A recent study conducted what it shows, excessive usage of the cell phones also, it will affect the sperm quality, and exposure to the pesticides, pollutants and the dyes in the industry, all they will affect the semen quality. So in the physical examination is very important. In the physical examination, we have to see height, weight, secondary sexual characters and gynecomastia, any scars in the abdomen and inguinal area, position of the penis, and a scrotal examination for testicular size, epididymis and vas difference we have to examine, because congenital absence of the vas difference, it can only be diagnosed in the physical examination. Then presence of varicocele or not, because only clinically palpable varicocele is only the important then that we have to evaluate. Then coming to the investigations. First is the semen analysis, hormone test, genetic testing and ultrasound. First is the semen analysis. Semen analysis gives a descriptive picture about the spermatozoa. It does not necessarily confirm whether the man is fertile or infertile. So only based on semen analysis, we should not tell a patient whether he is fertile or infertile. So proper semen collection is very important. For proper semen collection, at least 2 to 5 days optional should be there. The method of collection is masturbation. The laboratory collection is ideal than the home collection, and there should be no spillage of the sample. In the standard semen analysis, we will see for, in the macroscopic, we will see for liquefaction, viscosity, volume and pH. In the microscopic examination, we will see for agglutination, concentration, motility, morphology and pus cells. First is the macroscopic examination. So if there is delayed liquefaction, that is if it is liquefaction more than 1 hour, then it is delayed liquefaction, which indicates infection like prostatitis and seminal vasculitis. If there is increased viscosity, if that is the sample is hyperviscous, then it also indicates the infection like chronic prostatitis and seminal vasculitis. So if the sample is hyperviscous, then it will affect the evaluation of the sperm motility. Then coming to the volume, normal volume is 1.5 to 5 ml. If there is no semen at all, it is aspermia. If there is very less than 1.5 ml of the sample, it is hypospermia. Mainly it is, we have to identify if it is very too short abstinence or any loss during collection or the congenital absence of the vas difference. If it is hyperspermia, then it indicates prolonged abstinence or the accessory gland infection. So, if the low semen volume is associated with azoospermia, it will indicate the congenital absence of the vas difference or the ejaculatory duct obstruction. If the low semen volume is associated with normal sperm concentration, then first thing what we have to ask the patient is any spillage of the sample or the partial retrograde ejaculation. So normal pH is 7.2 to 7.8. If it is elevated pH, we can see in the infections. If there is low acidic low volume sample is there, then it will indicate a obstructive azoospermia. And in the microscopic examination, So if there is no ejaculate, it is called aspermia. Less than 40% motility is there, it is acinospermia. Or if there is no zero sperms are there, it is azoospermia. And based on count, if it is less than 15 million, it is oligospermia. 10 to 15 is the mild, and 5 to 10 million is the moderate. Less than 5 is the severe. And based on morphology, if it is less than 4%, it is teratospermia. So these are the WHO 2021 criteria. So compared to WHO 2000 criteria, only slight little bit change is there. Mainly in the sperm concentration from 15 million to 16 million, and in the progressive motility from 32% to the 30%. And the morphology is same in both the groups. So any abnormal semen analysis report, it must be confirmed by at least two reports in 1 month gap. So routine semen analysis is poorly standardized, it is subjective, it's not a powerful indicator of the fertility. And what we don't know is the functional ability of the sperm. So only semen analysis, based on semen analysis, we should not tell a patient whether he is fertile or infertile. Then coming to sperm DNA fragmentation, mainly men with poor semen parameters having higher chances of the DNA fragmentation. If the DNA fragmentation is less than 15%, it is excellent. 15 to 30 is good, and if it is more than 30, then it is poor factor. Then coming to the when we will do the sperm DNA fragmentation in unexplained infertility, recurrent pregnancy losses, multiple IUI failures, and low implantation rates in IVF, we will do DFI. So in the microscopic examination, we also see for a leukocytes. If it is more than 1 million, we will suggest the leukocytospermia. Then we will advise the semen culture. Then coming to the one important aspect, like when will we do the ultrasound? So there are two things. One is the scrotal ultrasonography, another one is the transrectal ultrasonography. So if we are seeing for any masses in the testis, then we will advise scrotal ultrasonography. For any ejaculatory disorders like post-testicular causes, if you want to examine, then we would advise transrectal ultrasonography, mainly in cases of low semen volume, ejaculatory duct obstruction, congenital absence of vas deferens. We will advise transrectal ultrasonography. So the importance of varicocele. In almost 40% of the men evaluated in the male infertility will have varicocele. The current indications for the treatment of varicocele are only clinically palpable varicocele with deranged sperm parameters should be treated. Ultrasound detected varicocele, there is no need of any treatment. So this is a study based on in infertile men with a clinical varicocele without any treatment. The success rate of IUI is 10 to 16%, and the success rate of IVF is 31 to 47%. And after varicocele correction, in IUI it is 7.7 to 15%, and in IVF it is 30 to 62%. So in couples seeking fertility with ART, varicocele repair, it will offer improvement in the semen parameters. Then when will I evaluate hormones? So hormonal evaluation we should perform if the in abnormal semen analysis, like if the semen count is less than 10 million and impaired sexual function. So the hormones we evaluate are the FSH, LH, testosterone, thyroid and prolactin. So if the FSH, LH and testosterone all are low, it is hypogonadotropic hypogonadism. If the FSH is elevated, testosterone is low, it is hypergonadotropic hypogonadism. If all are normal, it might be a obstructive azoospermia. We have to look for any obstructive causes. Then role of testicular biopsy. So testicular biopsy we have to do only in club with cryopreservation. So if you have a facility of cryopreservation, we have to do testicular biopsy. Then role of genetic testing. In cases of recurrent pregnancy losses, recurrent IVF or ICSI failure, family history of genetic abnormalities, or if there is any azoospermia or severe oligoasthenoceratozoospermia, we advise genetic testing. Mainly one is the karyotyping, Y chromosome microdeletion, and another one is the CFTR mutations. Then coming to the treatment, whether we can treat the man or whether we can treat the sperm. First, optimization of the man. So we have to advise the patient to quit the smoking, to reduce alcohol intake and caffeine intake, and to reduce the weight, to increase the frequency of ejaculation, to reduce sugars, stress and exposure to the pollutants. And in the medical treatment, we advise the patient to take antioxidants, and if there is infection, we advise antibiotics. And in cases of mainly idiopathic male infertility, we advise anti-estrogens like clomiphene citrate and the letrozole. Then coming to the optimization of the sperms, these sperm selection methods will be covered by our embryologist. So finally, if there is azoospermia, we'll see for FSH, LH and testosterone levels. If it is hypogonadotropic hypogonadism, we'll treat with medical management with HMG and HCG. If it is a non-obstructive azoospermia, testicular causes, then we have to advise the patient to go for a karyotyping and Y chromosome microdeletion. For that, there is no medical treatment, and we have to do micro-TISA with ICSI or the donor semen. If it is obstructive azoospermia, then we have to take the sperm from testis, that is testicle, from TISA or PISA with ICSI we have to do. So take home message is, male infertility is a growing concern. Lifestyle factors should be repeatedly stressed upon. We have to do physical examination. Seminal analysis we have to do. We have advised the patient only in a standardized lab, and any abnormal report should be reconfirmed by second report. And the total motile sperm count is a better indicator. Isolated teratospermia should not be stressed upon. If there is pyospermia, it should be treated with antibiotics. And ultrasound is not a replacement for clinical examination. Subclinical varicocele, it is not an indication of treatment even in the presence of infertility. And trial TISA, it should be done only in centers with cryopreservation available, and donor semen is the last option. Thank you.
For a very precise and very beautiful presentation. I will see reports of all the investigations, but when we look at the semen analysis is not there. That is a common practice common observation for all of us. I make it a point to investigate the male factor first before I start investigating the female partner. So one more question. Is CASA is mandatory for every patient?
Male infertility is the semen analysis, ma'am. Yes, we can do CASA. CASA is not routinely indicated, ma'am, basically.
CASA gives a picturesque information.
But if that, basically semen analysis what andrologist will do, madam. If the technical person is efficient, then only it is sufficient, ma'am. Not a computerized testing, ma'am.
Semen analysis, according to WHO standard, done in a very good lab setting. Morphological examination is the gold standard for identification of male infertility. CASA is a luxury. You can do a systematic operative procedure. So basically, gold standard is still WHO semen analysis. So they say 70 to 75% chances of sperm retrieval in C. So whenever we do for a Y chromosome microdeletion, when we get a C, we are a little happy, we can make him a genetic father. In the next session, due to lack of time.
Presentation on sperm preparation method, principle and techniques. So prior to this, sperm evaluation is the most important aspect which depicts the sperm preparation techniques. So now, considering the content right now, it will be why we are separating the sperms and what are the techniques which are involved in the sperm preparation. Okay, so this is simple wash, swim up, density gradient and max. So these are the most prominent methods which we are using right now. Glass wool filtration is a decade-old technique which we are not using as of now. So facts are that a spermatozoa of placental mammals are protected in non-labile state, ejaculated, and it is incapable of capacitating of the fertilization even if they are placed in direct contact with the oocyte. They must undergo subsequent period of final maturation, which is known as capacitation, during which they acquire the capacity to interact with the oocyte cumulus complex and achieve fertilization. Why are we separating the sperm? So seminal plasma contain one or more factors such as prostaglandin, zinc and leukocyte that prevents spontaneous capacitation of spermatozoa upon ejaculation. Prolonged exposure to seminal plasma has adverse effect on sperm function like ability to penetrate cervical mucus, undergo acrosome reaction in vitro, and the fertilization process in general. So consecutively, in order to spermatozoa to have a capacity to fertilize an oocyte, they must be separated from seminal plasma. WHO standard says that it is recommended the sample should be processed within 1 hour of ejaculation in order to prevent permanent damage from the leukocyte and other cell present in the semen. The recommended time is 20 minutes to 30 minutes, which is also the liquefaction time of semen sample. So purpose of sperm preparation is that whatever samples we are processing, the motility should be top-notch, morphologically normal samples, free from debris and germ cells and dead sperms. So efficiency can be the preparation of the method in which we are using the preparations of the sperm samples. So absolute sperm number will be higher, the number of motile sperm will be higher, and the recovery of morphologically motile sperm will be also be higher. So these are the general parameters which we are using right now for sperm preparation, which will be first washing, which includes simple wash. Second will be sperm migration, which is swim up. Adherence, which is the magnetic activated cell sorter, in which the magnetic particle is conjugated with the beads and it is attaching to the sperm. So fourth one is filtration. As I already told you, the glass wool filtration is considered, which is redundant as of now because it is quite old and it is not cost effective as all. So simple wash, we generally take a conical tube in which the sample is taken and 1 ml to 2 ml of sperm wash media which we are using, and we are mixing it. So we are just flushing it with the sperm sample, sperm and washing media, and then centrifuging it at 300 to 500 G for 5 to 10 minutes. After that, a pellet is formed. So that pellet we can resuspend in the media and use it in the IUI and other procedures. Okay, so it is a migration-based method. So traditionally, this is how we are doing. We are using sperm plus the media, and centrifugation of that media is done with a very small amount of RPM, which is known as soft spin. So removal of seminal plasma is done, which is known as in the supernatant, and then at a 45-degree of angle, the test tube is suspended in the test tube stand. So direct swim up is a little bit different in that sense, that in which we are just using the semen sample, liquefied semen sample at the bottom of the conical tube. Then we are overlaying with the media and keeping it at 45-degree angle in the sperm stand. Okay. So the sperm migrates from the bottom level to the upper level, which is rich media, and on that basis we can just remove the sperm on the top layer, and you can use it for the procedures we are using right now. So the procedures I've already told you. So disadvantage of swim up is that it is increases the ROS formation because it is kept in the sample for quite long, and there are several levels of the sperm pellet, which is not very important, because what we have that if the person is not experienced enough, then what happens that it might affect the sperm extraction also, and it takes twice as long as the normal technique which we are using right now for sperm preparation. Now it is a gold standard technique which we are using right now. It is density gradient. So in which, as the name suggests, density. So density means we are using two different densities right now, which can be 40 and 45 as the upper media, and lower media is 50 and 80 density percentage. So what is the major phenomena for this? That normal mature sperm is of 1.10 gram per ml, and abnormal sperm, mature sperm is between 1.06 to 1.09 gram per ml. So difference in this densities, which will give us the separation of non-motile and motile sperms. So this is how it looks like, that in a tube which we are having, that upper media, lower media, and the top is a semen sample. After the centrifugation, the right tube you are seeing is that the post-wash, which is having an interface, which the seminal plasma is the top layer, and the interface you can see white blood cells and debris, and in the green zone you can see abnormal non-motile sperms, and after that the interface is there, and bottom layer you will be seeing the viable sperm pellet. So after that what we get is the pellet. So we'll discard all the top layers which is supernatant, and then we'll overlay the media just to get the proper sperm in that particular media. And now it is a magnetic activated cell sorter. It is also based on adherence, which we have already spoken about. So it separates apoptotic spermatozoa from non-apoptotic spermatozoa. During apoptosis, programmed cell death happens. So the phosphatidyl serine residues are translocated from the inner membrane from the spermatozoa to the outside, which is again bound to the annexin V and has a strong affinity towards phosphatidyl serine but cannot pass through the intact sperm membrane. So the colloidal supermagnetic beads equivalent to 50 nanometer in diameter are conjugated with the highly specific antibodies to annexin V and used as a dead and apoptotic spermatozoa by MAC. So this annexin V along with the antibody, which is very specific to the sperm, so gets bind to the apoptotic cells, apoptotic sperms, and get attached to the border of the tube, and then hence whatever the elute we are getting after the sample procedures is motile sperm. As you can see in this diagram, the tubes which we are using right now, the antibodies is already attached to the apoptotic sperms and it is adherence to the walls of the tube. So now what is happening is that whatever elute we are getting after the procedure is motile sperm. But after this also we are giving some amount of washing which is required to remove the seminal plasma after this procedure happens. Lastly, the glass wool filtration, as I already told you, it's very old and not so cost effective. In this, what happens is that it separates the motile sperm from other content from seminal by filtration through densely packed glass wool fibers. The filtration separates out immotile sperms, leukocyte up to 87% and debris. After filtration, the semen is centrifuged to remove the seminal plasma from viable sperms. So what is the tip for maximizing the yield? Avoiding the overloading. The gradient of the semen sample is caused because the rafting is formed. What is that rafting? You may ask that it is a dispersed or suspended pellet which is not very intact. So while we are connecting with the pipette of this pellet, it is coming out and it disrupting the pellet. So that is what rafting is known as. Use for gradient within 1 hour is optimum. More than 1 hour of using the gradient might disrupt the interface formation. And 3 gradients also can be used in this procedure, but the 3 gradient might give you a lesser yield at the end. Lastly, it is a comparison between these 3, which is most prominent techniques: simple wash, direct swim up, density gradient. So as you can see, time, cost and yield quality. These 4 parameters are there in which we can depict that what is our requirement. If we are using for IUIs, we'll be using the most yield and lesser cost and time. So this is what we are getting right now. In density gradient, highest cost is there, but highest yield is there because the quality of the sperm is much higher and the motility and morphology is also higher. Okay. Lastly, the take-home message is there that centrifugation of pellet for unselected sperm of human spermatozoa causes irreversible damage to the spermatozoa that can impair the sperm's fertilizing ability. The method of choice is dependent on the intended use of prepared sample. Example, IUI needs much higher as compared to the ICSI, which I already spoke. Many practical scenarios on a day-to-day basis may affect the choice of semen preparation method used for learning wisely to choose appropriate method. Thank you all.
Dr. Mohammed Akhtas, I couldn't introduce him prior. He started his talk before I could introduce him. Okay. He's presently the IVF lab manager in Ferty9 Fertility. He worked as a senior embryologist at Gaudium IVF Center in Cloud9 Hospital. And he has given his presentation a very simplified way for all of us to understand. So your success rates with IUI in your centers?
Success rate is 20 to 25%.
Okay, so you are following the density gradient method.
Yeah, density gradient as a gold standard. Yeah.
We can take the questions in the tea time, so we'll move on to the next speaker. Sir has a flight to catch. I request the chairpersons to introduce our next speaker.
Dr. Chaitanya Nagori. He is the director, Dr. Nagori Institute for Infertility and IVF, Ahmedabad, India. Best paper awardee, World Congress Ecology 2008, Chicago. First stem cell pregnancy in India. Give him a clap. First Center of Excellence for Aya Donald School of Ultrasound. He holds regular trainings in infertility, IVF and ultrasound. Holds Gujarat University recognized fellowship programs in infertility. Published several papers in index and journals. Contributed in and authored several books. So I present Dr. Chaitanya now.
Nice introduction. Thankful to Jyothi for inviting me here. I'll be discussing some unusual topic in the era of IVF, and that is the medical management of male infertility. Percent of the laboratories write down 40 or 60 million is a normal count, and that must be the story here also. So the reason I always put forward is that the prescription indicates the year of passing. That pathologist must have passed when there was the 40 million count, must be a normal count. Now, being a regular gynecologist, because my whole focus is how to treat male infertility by a regular gynecologist, and these three hormones are very important, and out of these only one hormone is important to investigate, that is FSH. The permutation combination will be either it will be high, either it will be normal, or it will be low. Now let us consider that if it is high, concentrate. So it indicates AID or adoption only. Only very few cases in the centers where the embryologists are available and you can go for micro TSA. Then you may get few sperm. Remember, micro TSA will be very helpful when the FSH is normal in azoospermia. But when the FSH is high, it is very difficult to get the spermatozoa. So don't stimulate the wife. First get the sperm, freeze it, and then stimulate. Otherwise, what happens that at the time of micro TSA you don't get the sperm and you use the donor sperm. Then the wife should be stimulated. That is why that should be first freeze and then it should be used. Same is when the normal LH, high FSH, here also it is an AID or adoption. Second permutation combination is very low. You very rarely get this patient, hardly one or two in the whole practicing years. But the results are 100%. When you get hypogonadotropic hypogonadism patient, they should be best treated by HCG 5000 every 5th day. So it stimulates the spermatogenesis. Testosterone is required for the stimulation of spermatogenesis. FSH is required for maintenance of spermatogenesis. So either you can give HCG 5000 every 5th day for 5 to 7 injections, and then afterwards once the testosterone level comes normal, you can add FSH to this patient thrice a week and you get a good spermatogenesis in this patient. Now the FSH is normal. These are two permutation combination. Now the FSH is normal. There are two conditions. One is when the FSH is normal, you may get high testosterone, high LH level. There is no need to investigate. The patient enters the OPD and you can make out that this patient has got high testosterone, high LH because gynecomastia is present. Because the gynecomastia is present, these are the patients where testosterone is high, which is converted into estrogen, and that estrogen causes development of the breast. So any patient who enters with gynecomastia, it means FSH is normal, but the LH and testosterone levels are high. But the most common patient in our OPD is normal testosterone, normal LH, normal FSH. All three are normal. Patient is azoospermic or patient is having a very low count, and these are basically what we examine, what we do the test is by ELISA method. We never measure the bioactivity of that particular hormone. So bioactivity is something different, ELISA is something different, immunological levels are something different. So in this case, patients' RIA levels are normal, but there is a loss of bioactivity. And whenever there is a loss of bioactivity, you can give FSH thrice a week from outside, HCG once a week, and duration is almost about 12 to 24 weeks. This is Professor Ishidori's regime. Lot of patients of azoospermia or severe oligoazoospermia were treated by him, and fortunately now I will go through some of the slides that 2023 papers also say that FSH is extremely useful as far as the improvement of the spermatogenesis is concerned. Now when you treat a male infertility, there are specific therapy and empiric therapy. I don't discuss much on the specific therapy because you know the cause and you can treat it very well, like hypogonadotropic hypogonadism. Recently I told you, hyperprolactinemia, infection, ejaculatory disorders, immunological, testosterone deficiency and congenital adrenal hyperplasia. But what is important is an empiric therapy. Majority of the patients in male infertility are treated by empiric therapy. Always take the history of the patient to rule out all these drugs. Electromagnetic field created by mobile phones, particularly in this era, laptop to be kept in the lab, that is very common cause. Mobile phones, this is a very common cause of decreasing the count. I always say on the lighter side that cardiologists don't allow in the upper pocket, gynecologists don't allow in the lower pocket. So you should have somebody to keep your mobile with you. So now empiric therapy. So majority of the therapy is empiric therapy. And more than 25% cases you don't know the cause, and that's why the empiric therapy has come into the existence. I'll be telling you some of the points which are evidence-based. First is clomiphene citrate. If you read the Insler has rightly said that a subgroup is benefited, and because it is cheapest drug, it should be tried to all the patients. So 25 to 50 milligram for 3 to 6 months it is to be given. I'll tell you my experience of my two cousins, because when I started my practice then nothing was available. Only HMG and clomiphene citrate were available at that time. And they improved the count and got both the babies without IUI, without IVF. So these are the wonderful drugs, this should be tried, but if your colleague has already tried for 3 months, there is no need to repeat it. What you should do? You do FSH level of the patient, give clomiphene citrate, clomiphene X on the hypothalamus, increases FSH and LH, and after 1 month, if the FSH increases, means the drug is acting, you continue for 3 to 6 months. If there is no increase in FSH, you can stop the drug and you can switch over to the other therapy. Even before, that is in mild hypogonadotrophic hypogonadism, you can give it, and increase in FSH is very important, particularly when you are giving it. Those patients who are azoospermic, you are going to do ICSI. It has been documented that even prior to ICSI, if the CC is given for 3 months, then your harvest for taking out the sperm will be very good to this patient. Second, very important drug, I think I have used, I am a fan of HCG, I have used in hundreds of ampules. And this is very useful in idiopathic oligoazoospermia. You can give 5,000 units twice a week to the patient for 12 to 24 weeks, will give an excellent sperm count in severe oligoazoospermia. These are the patients where the bioactivity of the LH is very low, and if you supply LH from outside, the improvement will be very good. I have already given the first reported incidence was 60%, and what I have quoted the papers are 63, 82. Doesn't mean that I have not read afterwards, but it means that the companies have stopped financing for the research on the drugs which can improve the count. So there are no trials now available on these drugs which can improve, but believe me, HCG twice a week in a severe oligoazoospermia will give you excellent results, and the patient can have the spontaneous pregnancy or even the pregnancy by IUI. Even HCG prior to TISA, a patient of azoospermia, even if you give it and then if you do the TISA, then also the sperm will be, you will be getting the good quality of the sperm in this patient. Third is FSH-HCG combination. I told you Professor Isidori's regime, that is idiopathic normogonadotropic oligoazoospermia. You can give FSH or HMG thrice a week and HCG once a week. You can get excellent count in some of the papers, even some of the patients. That is the spontaneous sperm count can be found in an ejaculate in this patient. So FSH-HCG combination is very good. Sometimes in testicular biopsy you get the maturation arrest, and maturation arrest is at the spermatid level. Then these are the cases where you give only FSH thrice a week for 3 months, maturity will be attained and you will get the spermatozoa in the ejaculate. Now these are the current paper 2023 that the treatment improves the sperm retrieval from the testes also for ICSI, for IUI also, and also for a natural conception. So if the FSH is given to these patients, the improvement occurs a lot. And particularly the disorders of the testicular function causes decrease in inhibin B and testicular production that may affect the FSH complexity. And that is why any damage to the testes, if you give FSH to the patient, then the improvement can occur to this patient. Now there are a lot of reports that can improve, and what has been said from 91 onwards, that is when the Professor Isidori also gave the paper at the same time, that irrespective of the FSH level, even if the FSH level is slightly on the higher side, which indicates the testicular damage, it means you should give FSH to this patient. FSH to this patient will improve the spermatogenesis. Even the Cochrane review says that it improves the spermatogenesis. And the last ASHRAE also, this was the paper which was read by Ferring company, which came out with folitropin delta, that by giving folitropin delta also to a male patient, that is FSH, when it is given to a male patient, it improves the count to the patient. So, even if the FSH is high, even if there is a testicular damage, then the FSH has got the definite role that is to be given. And there are patients who do not improve with 150 units, then high dose of 300 FSH has been given and the results have found to be very good. So just by carry-home message that whenever the count is low or the patient is azoospermic, then the FSH has got a great role in improving the count to this patient. Now some of the other drugs I would like to mention, androgen, masterolone is not to be used. I think even today people are using masterolone. It has got no effect and should not be used to the patient. One of a very good cheap drug. Why am I emphasizing the medical management? Because a lot of patients cannot afford ART. A lot of patients cannot afford even IUI also. And they have got the low count. And with such simpler methods, you can improve the count to this patient and you can convert into a very simpler cycle. This is recommended by WHO, that is tamoxifen testosterone combination. And here the tamoxifen 10 milligram tablet BD, Temtero tablet by Leica, that can be given. And Andriol, that is testosterone undecanoate, 40 milligram tablet 3 times a day. If it is given for 3 to 6 months, then you can see that the improvement occurs to 34% as compared to 10%. So by using such drugs, you can improve the count to the patient very well. Thanks to COVID, because now the tablets are available to 100 or 200 milligram. Formerly, they were available of only 35 milligram in all the B complex preparations. So you can give 120 to 220 milligram twice a day for 3 months. It is very useful in oligoastenospermia, and particularly those who are the smokers having a low motility, or even after the varicocele ligation. The zinc works very well and improves the motility and count. Now these are some of the drugs, just I am mentioning for the history only. We had used in the past, but no further research are available on this drug. Otherwise, so many analogs or so many other preparations would have come by this time, which would have been very useful. And these are ketotifen anti-serotonin agent, that is an appetizer. I used to have this drug 4 milligram 3 times a day for 90 days, in 90s I think, and it has found to be very good for the improvement of the count. Nucleotides, captopril, that is antihypertensive drugs, these are used. And pancreatic kallikrein, these are not used. The commonest thing that is to be used by all is to rule out the infection. Tetracycline is the drug of choice, and particularly when there is a prostatic infection, then the quinolone group of the drug is to be used. There is no need to find out the infection from the semen. It is better to give. It is much cheaper rather than culture and testing. And many a times the pathologist, if the pathologist is not experienced one, then the premature cells are considered as the pus cells. And I have seen patients taking 10, 15 antibiotic courses for the premature cells, and they were labeled as the pus cells. So that's why don't investigate, just give doxycycline 1 BD. Minimum 14 days are required for the treatment. Indomethacin, a very cheap drug, 25 milligram capsule 3 times a day, is inexpensive, non-toxic, improves the count and motility both. So these are some of the drugs which are very cheap, which can be used to the patient, and that can have an improvement of the count. Testosterone, particularly testosterone is not used, but you can use anastrozole and letrozole. This is a wonderful drug. This is for the patient who are having a low testosterone level. If you consider the testosterone and estradiol ratio is 10:1, if the testosterone level is low, the letrozole will work as an aromatase inhibitor, will improve the androgen level, will decrease the androgen level, and that ratio can be maintained by 10:1. So those patients with a low testosterone estradiol ratio, you can use letrozole, and that will give a wonderful drug. Even in an ejaculate, you will get the spermatozoa in a patient of azoospermia also. Now, ROS, reactive oxygen species, have a lot of attention has been paid nowadays for it. But remember that there is an endogenous source of ROS as well as exogenous source of ROS. And in this, ROS is not all the time nonsense. It has got a physiological role, that is a capacitation, hyperactivation, acrosomal reaction, sperm-oocyte fusion. But when it exceeds in amount, then it is pathological and can cause the DNA damage and apoptosis. So, systemic treatment of man with antioxidants have received the great interest, but still the story is somewhat more confused. Always remember that antioxidants are to be prescribed as a complementary treatment. They cannot do a miracle, but they can be prescribed as a complementary treatment after ligation of varicocele, antibiotic treatment, or when you are giving anti-estrogenic treatment to the patient. High doses have theoretical adverse effects, and vitamins have got no role as far as the therapy is concerned. Now, antioxidants will be very useful, particularly in our clinical practice, diabetic patients or the smokers, alcohol consumption. These are very common patients, and that is why the antioxidants are to be prescribed to these patients. Particularly first degree varicocele, then the antioxidants will be very useful, or after ligation of varicocele also, it will be very useful. There are a lot of antioxidants available to you. There is a long list, and I'll be discussing one by one what is the actual dosage, because whenever you use any antioxidants or any combo preparation, there should be 3 to 4 drugs in a therapeutic dose. Otherwise, there are so many combo preparations available where everything is in a homeopathic dose, and that is why it does not work at all. So there should be 3 to 4 drugs which should be in the therapeutic dose. Out of this, very important are tocopherol, astaxanthin, lycopene, carnitine and coenzyme Q10. These are very important drugs. Now, this reduces the DNA damage, and I never go for the DNA fragmentation test in my practice. If I suspect at all, then I would like to give antioxidants, and that will correct it. Because the DNA damage is more or less a physiological thing. It is a physiological thing, and you can correct it by giving antioxidants. Majority of the patients will improve with this. Vitamin E is very useful, and instead of that now astaxanthin is very useful, and almost all combo preparations are containing astaxanthin. That is very useful drug for the improvement. Vitamin C 1000 milligram. Why I am quoting the dosage is because there are some combo preparation 5 milligram or 10 milligram which is useless and which just increases the cost of the drug. B12 same way, 1000 to 1500 microgram, and majority of a combo has 10 or 15 microgram only. That just simply increases the cost. That's why evaluate the drug properly, whichever combo preparation you are using, and it should have at least 3 to 4 drugs in a therapeutic dose. That will be very useful for any multiplying cells. Folic acid will be useful. Pentoxyphylline is not useful. Selenium, an excellent drug, 225 microgram, and majority of the combo preparations contain 85 microgram. So that can be given 3 times a day, and that 50% of the patients improve by this. So these are some of the drugs which act and give you the improvement in more than 1/3 to 50% of cases, and that is not even the result of IVF. If the count improves, the spontaneous pregnancies are very common. Lycopene is also very useful, and that is added in one of the combo preparations. Don't give glutathione injections because they are very cumbersome, and daily injections are not welcome by the patient. Same way, arginine 500 milligram capsules are available, and 8 capsules no patient will take, and that is why these are not the drugs to be used. But some of the people add arginine few milligram in the combo preparations, which is useless. Now, L-carnitine, L-acetyl-carnitine combination. This is a wonderful drug. A lot of papers have come in human reproduction also. Starting from 2008, there are 4 or 5 papers have come, and it has said that it improves the motility to a great extent, and that is why L-carnitine plus L-acetyl-carnitine sachets are very useful for the improvement of the motility. Particularly idiopathic oligoasthenoteratospermia and the low-grade varicocele, this will be very useful. Now, the only thing to be remembered for this, that L-carnitine and L-acetyl-carnitine, the positive effect does not last for a long time. So you can't give it for 3 months, then call the patient once again, and then you try to evaluate the patient and try to treat the patient. But simultaneously, whenever you are doing IUI or whenever you are doing IVF or ICSI, simultaneously the drug is to be given to the patient. Same way coenzyme Q, excellent drug, 100 milligram BD should be given to the patient. And here also, it does not last for a long time. So whenever you are doing IUI, then and then at the same time, you should give these drugs. Some of the drugs like vitamin D or omega-3 fatty acids are still on the trial, but acupuncture, traditional Chinese medicine, and all these are useless drugs, should not be given to the patient. So just I summarize my talk by 2-3 slides only, that you have a lot of drugs available for asthenoazoospermia and you have a lot of drugs available for oligoazoospermia. If both the defects are there, you find out which are common to this. Otherwise, you can have plenty of drugs for asthenoazoospermia. You can try these drugs and the improvement of the count can occur. Same is for oligoazoospermia, the improvement is possible. I have already discussed the doses, but still you can have it that from clomiphene you can have all these doses. Indomethacin, anastrozole, letrozole, very useful. And these are particularly the doses of the antioxidants that will be very useful to the patient. So what I want to convince you that medical management of oligozoospermia is neglected segment in infertility, and try to convert an ICSI cycle into IVF cycle, IVF into IUI cycle, and IUI into a natural conception. The cost to the patient will be very low. And I will complete my talk with only one slide because it is the tip of the iceberg of one of my patients. A patient of 9 years infertility, semen count 3 million, 7 IVF ICSI. The patient came for ICSI to me, but I would have been stupid if I would have done the 8th ICSI, because all were done by the experts, or rather the pioneers of IVF in India. And they did 4 or 5 ICSIs in Bombay, 3 were in Ahmedabad. The patient did not conceive. So I always tell my students also that try to evaluate the prescription of your colleague and try to find out what they have not done rather than what they have done. Majority of the time we try to see what they have done, but always try to find out what they have not done. And I could see that nobody improved the count. So that is one carry-home message, try to evaluate and try to find out. And second, very important carry-home message, that good conferences always teach you something. What she said, then in ASHRAE we learned this thing. So this was the Professor Isidori's regime I could learn from one of the conferences where he had discussed that FSH-HCG combination, and I immediately applied on the patient when I came back, and that gave me the result. And I presented one paper also in the Madras conference also, the pregnancies of the azoospermia who improved after FSH-HCG combination. So this patient conceived with IUI in the second cycle, and the beauty is that the count was above 15 million. So she got a second spontaneous pregnancy. So we have a lot of such patients where the improvement is possible by the drugs, and think of an alternative management. And particularly oral drugs and HCG can be used to a poor patients where you can improve the count and you can convert into IUI or the spontaneous conception. Thank you very much.
Based on the practical points and the simple points, we are very happy. And even it is useful for the basic gynecologist who is treating infertility, not the infertility specialist, but the basic gynecologist.
You have to advise the treatment for 3 months for a spermatic cycle. Most of them they are not taking. They are jumping one doctor to another doctor. That way they are not taking proper treatment.
So, what is your preferred combi preparation for these patients, sir?
See, normally we give antioxidants 0 to 3-4 billion count, 5 to 10 billion count, and 10 to 15 billion count. 10 to 15 will improve with the oral drugs. 5 to 10 will improve with the HCG and the oral drugs. And 1 to 3-4 will be improving with the FSH-HCG combination. That is a rough calculation how I treat the patient.
Sir, indomethacin, how do you give, sir, for how many months? Indomethacin.
Any drug is always to be given for
Only,
84 days.
How it acts, sir? How does indomethacin act?
Indomethacin, it is an anti-inflammatory agent that works very well.
So just empirically you said for all male infertility patients you give antibiotic therapy for 2 weeks. Similarly, do you also advise indomethacin?
Indomethacin is a very cheap and excellent
yes,
drug.
Yes, that's it. Both
Any
together.
role for probiotics?
25, huh?
Probiotics.
Probiotics have not been confirmed for the improvement.
But one thing with this combination antioxidant drug therapy, as sir was saying, the reactive oxygen species, to some level there are advantages. If there are more, there are disadvantages.
Yes.
So we should create a balance between advantage and disadvantage. They cannot be used endlessly. There's this Fertisure M or whatever, they should be given for 3 months and it has to be given a break. That's one thing I have wanted to tell the audience. Don't use them endlessly, this antioxidant preparations.
Thank you, sir.
As Madam has a flight to catch, Madam will be presenting her talk immediately.
Let us right away start with the subject. The subject is very wide. Okay, before I forget, thank you very much, Jyothi, and thank you very much for the entire team. Thank you very much to the entire team for inviting me here. So ultrasound and infertility is a very, very wide subject, but let us just take an overview of what we can do with ultrasound for an infertile female. So we can diagnose uterine pathologies, ovarian pathologies, tubal pathologies, endometriosis, assess the tubal patency, calculate the stimulation doses, so the ovulation induction doses, to decide the time of trigger, to decide the type of trigger that we want to give for the ovum pickup, for the embryo transfer, it's a guide, and of course for the luteal phase assessment, and moreover even to evaluate and diagnose the complications of infertility. I don't know how much I can cover. The moment my time is over, I'm going to stop, but let me see how much I can cover with this. Ultrasound, especially when you are talking about the uterine abnormalities, remember for the Mullerian abnormalities, 3D is now considered a gold standard because we can see the coronal plane, we can see the outer contour, and we can also see the endometrial contour. So that is why whatever classification you are going to use, it is 3D ultrasound which is now considered a gold standard for differential diagnosis for all duplication abnormalities. Yes, I do agree that whenever you have a unicoordinate uterus and you are suspecting a rudimentary horn and you don't get it, or you cannot see it on ultrasound, or when you are suspecting agenesis of the uterus, these are the two conditions where MRI is required. So that is about the Mullerian abnormalities. Coming to the uterine pathologies, which may be myometrial, which may be endometrial, and starting from the endometrial pathologies very quickly and only the salient and the diagnostic points. We all know polyp is a solid projection inside the endometrial cavity. You are going to always see it as an ecogenic structure, I would say mildly more ecogenic than the myometrium. If they are very small, they may be missed because they have a very subtle ecogenicity. In that case, you have to follow the central line. If it shows an abnormal curvature, it may indicate a polyp underneath. Whenever you suspect the polyp, always use a Doppler, whether it is a single polyp or there are multiple polyps. You are going to see the feeder vessels. A single feeder vessel is what tells you, yes, it is a polyp and nothing else. The closest, yes, of course, you can, because it's an endometrial lesion, you can also put some saline into the endometrial cavity. Sono saline infusion, sono hystero, and that can show you the endometrial lesions beautifully, of course on 2D as well as on the 3D. Even 3D alone may be a good guide to tell you whether that it is a polyp. The closest simile would be if the polyp is large and it's filling up the entire endometrial cavity, would be endometrial hyperplasias. Endometrial hyperplasias, rather than being completely hyperechoic or ecogenic and homogeneous, they usually show tiny anechoic areas, and if you see that the anechoic areas are very tiny and they are there but not variable in size and not multiple, then it is more likely to be a stromal predominance in the hypertrophy. Whereas if you are seeing multiple anechoic areas variable in size filling up almost the entire endometrial cavity, it is more likely to be glandular predominance. In both these conditions, the vascularity is not very abundant, but it is symmetrically distributed, it's regularly distributed, and the endomyojunction is always intact. Instead, yes, if you think that a thickened endometrium and thinking about the malignancy, malignancies usually will, if it is confined to the endometrium may not show disturbance in the endomyojunction. If it is widespread, yes, the endomyojunction will be affected, but if you put on a Doppler, the vascularity is heterogeneously distributed, unlike the regularly distributed vascularity which you see in the hyperplasia. So, and of course it would be a very low resistance flow. If at all, again, if you are seeing this picture and suspecting vesicular mole, of course you have beta HCG to compare with, and moreover, of course, as I told you, in the hyperplasia the vascularity is less, in the moles the vascularity is very, very abundant. Next, endometrial pathology, endometrial synecdoche, persistently thin endometrium in proliferative as well as in the secretory phase, sometimes may show calcification. If there is a calcification, you will see a posterior shadowing. If it is a thin endometrium, you are seeing hyperechoic flex but no posterior shadowing. This is not a calcification. This is usually either fibrotic strands of chronic endometritis, or it is collapsed myometrial cysts of adenomyosis. If at all you are having a persistently thin endometrium, it is always best to put some fluid inside. If the synecdoche are not very strong and tight, then you can see some fluid percolating into, or I would say going into the endometrial cavity, and you can see beautifully the synecdoche there. Even on your 2D, your diagnosis will be confirmed. Sometimes when the synecdoche are very thick and tight, that's when they'll hardly allow any fluid into the endometrial cavity. Remember, a very important sign is that whenever you are seeing a very thin endometrium persistently and you are seeing tiny loculi of fluids inside, this confirms your diagnosis of synecdoche even without putting any fluid inside. Synecdoche we know are very common, or the thin endometrium is very common with chronic endometritis. When we are talking of chronic endometritis, persistently thin endometrium, irregular endomyojunction and scanty vascularity inside the subendometrium and in the endometrium. But tuberculosis is the major concern to many of the people. Apart from this, you may see tiny polyps, so micropolyposis. You will see hyperechoic spots in endometrium, in the junctional zone, in the myometrium sometimes. In the mid-proliferative phase, you will have fluid in the endometrial cavity with hyperechoic central wall, or the inner wall of the endometrium, and no vascularity in the subendometrium. Narrow cavity, we all know, is often seen with the any chronic endometritis, and it's also seen with tuberculosis and along with the scarring. A very important sign that you may see with tuberculosis, most consistent, I would not say it is a specific sign, but most consistently is vertical orientation of the interstitial part of the tube. Instead of the normal direction of the interstitium, which is like that, one of the interstitial parts of the tube may stand up, and that may tell you, yes, it is tuberculosis. Apart from this, you will also see myometrial cysts with hyperechoic margins, very similar to what you would see with adenomyosis. But adenomyosis, when you see the myometrial cysts, will show you peripheral vascularity. Myometrial cysts of adenomyosis will show you peripheral vascularity, but myometrial cysts of tuberculosis will not show you any peripheral vascularity. And this is a very important sign, because in both adenomyosis as well as in the tuberculosis, you will have irregular junctional zone. You will have a thin endometrium in adenomyosis also if it is a wide severe adenomyosis, and you have myometrial cyst. It's the vascularity which will differentiate between the two. If we are talking of adenomyosis, apart from the myometrial cyst that you have, we all know we may also have hyperechoic dots and lines. The junctional zone may be irregular, may be obliterated, or may be interrupted because of hyperechoic strands or anechoic areas in the junctional zone. You also will see abnormal curvature of the endometrium beyond the fundus. So beyond the mid half of the body, the fundal endometrium shows a reverse curvature, which is called a question mark sign, which may be because of asymmetrical involvement of the uterus in adenomyosis, or maybe because of adhesions. If you put on a Doppler, not all adenomyosis are hypervascular. Remember, there are some adenomyosis which are hypervascular, some which are hypovascular. The ones which are hypovascular will respond to the medical line of treatment. The hypovascular ones will not respond to the medical line of treatment. Whether hypo or hypervascular, the vessels that you see in the adenomyosis, they will have larger diameter than the normal spiral vessels, and instead of being arranged parallel to each other and perpendicular to the endometrium, they are chaotically arranged and they disregard the margins of the lesion, run through and through, and that these are the signs of adenomyosis. Fibroids, we all know, it is a well-defined oval, round, lobulated lesion. Maybe if it is degenerated, may show heterogeneous echogenicity. Peripheral vascularity is which is diagnostic even if it is degenerated and will show internal vascularity. The peripheral vascularity is still there, and the vessels that you see inside the degenerated fibroid will be limited by the peripheral vascularity. They will always respect that peripheral vessel, will never go beyond that, and that tells you yes, it is a fibroid and it's not an adenomyoma. As we all know, fibroids may undergo n number of types of degenerations, all lead to heterogeneity, which may be cystic, which may be calcification, which may be just hyperechogenicity because of myxoid, or may be truly heterogeneous hyper in the rate degeneration. Fibroid location is very important, which can again be confirmed especially in relation to the endometrium when it is type 0, 1, 2, 3, and in these cases it is 3D ultrasound, which is going to be very, very helpful to you. So that is about the major lesions that you come across. Of course, there is enhanced myometrial vascularity, RPOsis, which are all fully, always ultrasound is the modality of choice for the diagnosis. Then coming to the adnexal lesions, I'm just talking about the lesions that we very commonly come across and we get confused about. And one is when you are finding a lesion which is in the adnexa, which is completely anechoic, no septa, no internal echogenicities, and then you first have to decide whether it is intra-ovarian or extra-ovarian lesion. Remember, whatever the morphology of the lesion, if you are seeing the lesion and you are seeing the ovary and you push the probe in and out, or your probe is in and you press with the other hand on the abdomen, bellot the abdomen, and you can either separate the two as you are seeing there, or you can slide the two over each other. This tells you it is extra-ovarian. If you cannot do that and you are seeing a rim of ovarian tissue, or you are seeing a beak of ovarian tissue, this tells you it is an intra-ovarian lesion. If both these signs are absent, then it is extra-ovarian and adherent to the ovary. So that tells you surely what is the organ of origin. Now coming to the different types of lesion that we very common come across, and we started with an anechoic lesion, and if that is the lesion which we are seeing and it is intra-ovarian, the only possibility is I would not say only, but the most common possibilities are follicular cyst, and it may be a simple cyst. Remember, any follicle that is larger than 25 millimeters, only then will you call it a follicular cyst. Anything smaller than that at any stage of menstrual cycle is not a follicular cyst, and functional cyst is a very, very loose term. It just tells you a cyst that is arising out of an abnormal function. Please don't use it. You will confuse yourself, you will confuse other people also. So whenever you see it in the follicular phase, you put on a Doppler and you'll see a beautiful ring of color. Why beautiful ring of color? Because a follicle, even when, as soon as the follicle gets dominance, it starts pulling blood vessels towards itself. So if it is an active follicle of that cycle, it's going to show you a nice ring of color, at least covering half of the follicle, 1/3 to half of the follicle. But if you are seeing only scanty vascularity and the lesion is more than 25 millimeters, that's when you may say it is a follicular cyst. If there is no vascularity at all, that means it is either a residual follicle of the previous cycle or it is a simple cyst. Whenever you are seeing such a lesion, there is no risk of malignancy, and therefore always do a follow-up for this lesion after 2 to 3 weeks. Follicle is going to rupture, follicular cyst is going to start regressing, simple cyst is going to remain as it is, and the residual active follicle is going to regress. If instead you are seeing a cystic lesion with multiple and internal echogenicities, which may be hemorrhagic, and if they are hemorrhagic, it is going to be a hemorrhagic cyst or a corpus luteum. When I say corpus luteum, I mean that there is an active flow surrounding. When I say corpus luteum, it is still producing some amount of progesterone, and whatever, of course, if you see for this lesion for the first time in the secretory phase, you always suspect a corpus luteum. First put on a Doppler, excellent flow, low resistance flow, tells you yes, it is a corpus luteum and it is nothing else. But if the flow is scanty, it may be inadequacy of the corpus luteum, which is the first possibility. If you are seeing this lesion for the first time in the proliferative phase, then of course we don't usually suspect an active corpus luteum. If you put on a Doppler and no flow at all, it is a hemorrhagic cyst. Hemorrhagic cyst is the term only to be used for a corpus luteum which has stopped functioning but has not resolved anatomically. So it is a functionally non-active, it's hormonally non-active, therefore it shows no flow at all. But if you see such a lesion in the early proliferative phase, you put on a Doppler and you are seeing flow. If it is a nice flow just like you are seeing in the corpus luteum, then it is a residual active corpus luteum of the previous cycle. Whereas if it is showing a scanty or a high resistance flow, it is a regressing corpus luteum. A regressing corpus luteum doesn't come in the way of stimulation. If it is a residual active corpus luteum and it persists till day 5 of the cycle, then these are the cases where you might have to omit the cycle. Day 2, n number of times you will see this, but whenever you see this, confirm it with the endometrial status. If you are seeing on day 2 a corpus luteum which has flows and you are worried about this corpus luteum affecting the follicle or the endometrium, see the endometrium. Is the endometrium thick? Is that thick endometrium showing flow also? Because even blood will show a thick hyperechoic endometrium. So if it is thick, hyperechoic and is showing flow, yes, you agree that that progesterone is acting on the endometrium, and these are the cases where I will have to re-evaluate this patient. Instead, if you are seeing low level echogenicities only inside the follicle, inside the cystic lesion, and you are seeing hyperechoic walls and you are seeing scanty flow, this is an LUF. LUF shows hyperechoic walls, low level echogenicities, no hemorrhagic echogenicities as a rule, because it is an unruptured follicle, it cannot be any hemorrhage inside. All these lesions are physiological lesions and they are bound to start regressing within 2 to 3 weeks and completely regress in 4 to 6 weeks. If they do not, then they definitely require a further investigation. Apart from this, the common pathologies that we come across, the ground glass echogenicity, everybody knows, but remember, not all endometriomas will show just a ground glass echogenicity. Many a times you will also see a fluid level like that. Sometimes you will also see some fibrin strands and hemorrhagic echogenicities, because it is ultimately blood or blood products. What is then diagnostic of endometrioma? One, you are seeing hyperechoic flecks in the walls. Those flecks in the hyperechoic walls or flecks on the fibrin strands is what tells you are seeing these flecks. That is what tells you it is an endometrioma. This is because of hemosiderin or cholesterol. Or if you rotate the probe, you will see a fluid level. A fluid level is what we call it. You are seeing a high echogenic fluid here and anechoic or a low echogenic fluid here. And this is because of the blood products and the solid blood products in the debris or the whole blood posteriorly, which is showing hyperechogenicity, and the serum anteriorly. At times you may also see tiny particles falling inside. So it looks like because of the gravity, there are tiny particles which are trying to settle down. This is called an acoustic streaming sign. This is also typical of endometriomas. Of course, it may be also seen in any cystic lesion which contains thick fluid. But if I say endometrioma, 1, hyperechoic flecks, 2, pain on probe pressure and possibly adhesions. Pain on probe pressure is something which confirms, yes, it is endometrioma and it is no other lesion containing blood. So that is about endometrioma. Then we may also come across very often with dermoids. Dermoids we all know is a 2D diagnosis, but dermoids also may show a typical fluid level, again very similar to this but opposite. In dermoid, the echogenic fluid is seen anteriorly. Why I am saying anteriorly is because this is a longitudinal scan, and in longitudinal scan this is anterior, this is posterior, this is caudal, and that is cephalic. So you are seeing echogenic fluid anteriorly, which is the sebaceous material, and posteriorly you are seeing the fluid. You may see hair balls, you may see hyperechoic dots and lines, you may see hyperechoic tooth-like projections with posterior shadowing. You may have hyperechoic blades with posterior shadowing, hyperechoic balls with posterior shadowing. Something very typical is tip of the iceberg sign, where you are seeing a snowball-like structure where you cannot identify the posterior margins, which appears very similar to the bowel gas, but it is not bowel gas because you can actually see the beak of the ovarian tissue there. Because you're seeing beak of the ovarian tissue, it is intra-ovarian. You're seeing the ovarian tissue all around. So it is intra-ovarian, and this is typical of a dermoid. So a snowball where you cannot identify the posterior margins. Never painful, never vascular. Now coming to the ovulation disorders, which may be like poor reserve ovary or PCO patients. Now if at all, yes, we all know multiple follicles more than 20, size more than 10 cc, but we don't find these findings are not consistent. They are not seen in every patient. There are n number of papers which have come over the time. You cannot have a same cutoff for all age groups. There are n number of papers which have come. You cannot have the same cutoffs for all ethnicities. What is consistent then? The consistent thing is the stromal abundance. And this is what is you can see on your 2D scans as hyperechogenicity of the stroma 1. It at times you may also be, I mean, if at all you want to, you can measure the ovarian stromal volume. The ovarian stromal volume may be measured by 3D ultrasound, but if you are not going to do a 3D ultrasound, you can also measure the ovarian area on the strict longitudinal axis of the ovary, and you can deduct the follicular areas from the ovarian area, and you can measure the stromal area. And there are very good cutoffs, 5.5 centimeter square for the ovarian area and 4.46 centimeter square for the stromal area, which tells you yes, there is a stromal abundance. Even you can take a ratio of the stromal area to the ovarian area, and if you take a cutoff of 0.32 to 0.34, if the cutoff is beyond that, that means yes, it is a stromal abundance. And these are some very good papers and very good literature evidences which tell us that there is a stromal abundance. I'm not going to discuss more about this. Yes, there are n number of papers which have now agreed upon stromal abundance. Even the ESHRE 2018 amendment, it mentions stromal abundance is one of the major important features. Unfortunately, we are still looking for a more reliable way to calculate the stromal abundance, and therefore it is yet not considered as into the guidelines, but yes, it is definitely an important sign. Not only that, it is this stromal abundance which also correlates with the insulin levels. So if you want to decide this patient is going to, this patient may have insulin resistance or not, of course, blood test is the guideline, but you should also check the stromal abundance, and that will guide you whether a particular patient may be helped with ovarian drilling or not. Ovarian drilling is not to be done for all, as we all know. Not only that, you would also check the vascularity in the ovarian, in the PCO ovaries. It is very interesting to know that all the PCO ovaries, majority of them will have high vascularity. It is this reason that they hyperstimulate, but we also have resistant patients, because when we are talking of PCO, we have 4 different phenotypes, and there is a group which has high LH and there is a group which has high androgen. So the group which has high LH will show high vascularity, because it is LH which is responsible for new vessel formation, new angiogenesis, and it is also responsible for low resistance flow. That means if I am seeing a PCO patient, if I have a stromal abundance, if I put a Doppler and I see a lot of vascularity in the stroma, this means this patient has a high LH. So it also leads you to endocrinological, it guides you towards the endocrinological diagnosis also, and therefore may also help you better manage the patient and monitor up. Coming to the poor reserve, we all know it is an ultrasound. Ultrasound can diagnose, of course, your AMH is there, but ovarian volume and the antral follicle count, we all know, is equally reliable parameter to assess ovarian reserve. Coming to tubal pathologies and the hydrosalpinx, for that matter, I'll just tell you one sentence, and that is any extra ovarian cystic lesion that changes its shape, I don't even say tubular or sausage shape, that changes its shape on rotation of the probe, unless proved otherwise, think of a hydrosalpinx. And this is something very important. So of course, you will see that as you see a cystic lesion, you rotate your probe. You sometimes may just have a beak-like extension. Sometimes you may have a clear longish shape with incomplete septa. If it is an acute inflammation and hydrosalpinx, you will always see thick mucosal folds, as seen here in the long section, and the same on the transverse section, which gives you a cogwheel appearance. Whereas if it is a hydrosalpinx, because of the chronic inflammation, you will have lesser dilatation of the tubes, hyperechoic walls, and adhesions are likely. Coming to the tubal patency testing, we all know saline infusion has been used by a lot of us, of course, though HSG was there. Now, I mean, at least we don't do HSGs anymore, but you can beautifully see here. Let me just start from the beginning. As you inject saline, you're seeing uterus and the ovary in the same section, on the transverse section. You inject saline with either a Follis or a dedicated sonohyster cannula. You're seeing fluid coming there, and then later on it is collecting here. If that is seen, you can definitely say this tube is patent. Most of the times the tube is not placed like that, maybe anterior or posterior to the ovary. You will only see fluid collecting. Disadvantage of using saline is you know that one tube is patent, you don't know which of the two. Instead, if you are just seeing distension of the endometrial cavity and no fluid collection, it tells you yes, both the tubes are absent. If you want to know the site, definitely you can use color Doppler, put the color box around the ovary, and you would again the same image frame where you are seeing the uterus and the ovary, and you would see here as you inject saline, you would see some fluid coming here inside. We will see it in a while. And then you will see the color blush filling up the entire box. That tells you yes, that tells you the tube is patent. Whereas if you don't see that color blush, the tube is not patent. To see the entire tube, you can put air, which is what many people were doing, hyperechoic bubbles, and you can see the bubbles passing there, which tells you the tube is patent. But air is now banned because of the theoretical risk of air embolism. There are some people who are using betadine, there are some people who are using lignocaine also. Of course, it's a off-label use. It is up to your risk whether you want to use it or not. But Sonoview is one dye which can be used very easily. It is an intravascular contrast. If you use contrast mode, you can see the entire tube along with the fimbria. Even on your 2D, see beautifully. Yes, but if at all the entire tube is not in a single 2D frame, then you can use a 3D. And the 3D will give you beautiful demonstration of the tube, entire tubal lumen, fimbria, and spill everything. Let me right away go to the deciding stimulation protocols. If I say deciding stimulation protocols, though we all decide stimulation protocols based on FSH, AMH, AFC, age, but that is all ovarian reserve alone. We have to understand there is something like ovarian response, and the ovarian response depends on the ovarian flow. If the ovarian flow is good, that is when more percentage of total gonadotropins loaded into the patient system is going to flow into the ovary every cardiac cycle, and therefore the FSH threshold is reached faster, and therefore total dose required for the patient is less. But when the ovarian flow is less, you will require more doses to be put into the patient system so that sufficient FSH is delivered to the ovary. So that means good flow in the ovary, patient is a good responder. Poor flow into the ovary, patient is a poor responder. Based on this, we have devised some baseline scoring systems. You can just evaluate the age, BMI, AFC, ovarian volume, stromal RI and stromal PSV. Do the scan on day 2, find out these readings, put them into the score system. And once you find what is the baseline score for a particular patient, there are fixed doses for IUIs, IVF fresh transfer cycles and IVF frozen transfer cycles. If it is only about 20% of the patients who may not respond on the first shot, and if they don't respond, that is the score chart. I'm not going to discuss this more in detail because we don't have time, but yes, we have charts for IUI and IVF patients both, and believe me, this is a zero OHSS method. Even when we didn't have agonist at all, even then it was a zero OHSS method. So this is something very reliable. You can use Doppler 2D ultrasound to evaluate the follicular size, but it is the Doppler evaluation which is very, very important whenever, so that is the Doppler evaluation which decides the follicular functional maturity, and therefore it is a very useful way to decide the time of trigger. If you have multiple follicles, you can do what is called a sono AVC. Depending on the size of the follicles, you will decide what trigger to give, HCG or agonist or a dual trigger. Even for the endometrial assessment, of course, it's not only the thickness, you are also going to evaluate the morphology of the endometrium, which tells you indirectly about the follicular quality, and of course, the endometrial vascularity also. So I think I'm going to stop there, 30 minutes, and that's it. Of course, when you are evaluating the endometrium, uterine artery is also, evaluation is also important. It is Doppler PSV findings of the perifollicular flow, which will tell you you should do single IUI or you should do an earlier IUI for that patient or not. Whenever the PSU is more than 20, we prefer to do 2 IUIs, 12 to 14 and 36 to 38 hours. And of course, the procedures and the complications. Thank you very much for that very patient hearing.
I request Dr. Jyothi to hand over mementos to our respected chairpersons, Dr. Sasi Prabha Madam, Dr. Krishnamma Garu, Dr. Sita Ramaraju Garu, and Dr. Vidya Rama Garu. Thank you so much, dear chairpersons. So, to make this day a better one and invoke divine blessings by kindling the lamp of knowledge and wisdom, we ask the
Now let us have the pleasure of listening to the opening remarks of Dr. Jyothi, founder, medical director, Ferty9 Fertility Chain. Dr. Jyothi is a believer, brilliant team leader, passionate regarding teaching and always compassionate with patients. Welcome, ma'am.
Yeah, so thank you everybody. Such an important day for us. So they always say there is Vidyam Dadati Vinayam. Education leads to wisdom. Education is a single weapon which can create change in the mindset of millions of people and of course then make a world better place to live. So we are all here to know and to learn from each other. In the words of great Henry, from millions of years it's told that anyone who stops learning, whatever its age is, either 20 or 80, is old. And whoever learns, whatever their age is, 20 or 80, they're still young, they're valuable, and they're productive to the society. So here, I see a lot of young people, more than 170 young people here, collective together, who wants to seek knowledge, who wants to make world better place to live. Thank you, each of you, for dedicating your precious time on a Sunday morning and come here to learn from each other. So with that also, with folded hands and with flowers for each of you, I welcome wholeheartedly all of you here, all the delegates especially. And for today, even the nature is supporting us. There is not a single drop of rain today, so I'm so happy. The day started very well. And then I also always have high regards for the teachers whom have learned. So all salute to all the teachers here, what I have learned from, and all the seniors here. So the first lesson, what I learned from my legendary teachers is a tree which wants to touch the sky should extend its root down. So the more we want to go upward, we have to go more downwards. That means to say, we have to be down to earth, humble and grateful. Once we are like this, nature will take care of us and everything happens. And I also want to take the privilege to thank all the national faculty, Dr. Sonal, Dr. Nagori sir, Dr. Varsha Baste and Dr. Rajesh Kuradia, who have really taken all their precious Sunday. It's not so easy. I can understand their life, Every Sunday, somewhere or the other, they have to run. Why are they doing all this? It is just to share their knowledge. We heard such a beautiful lecture from Sir about male infertility. It was kind of even eye-opening for me. So it says that nobody can attain this, topmost of knowledge. We are in a curve. Something I know better, something Sir know better, something so many people know better, and something you know better. The questions what you ask sometimes trigger a yes, we never thought of it. So thanks to our Society of Vizag Obstetric Gynec for giving us this opportunity to learn from each other. And then I would also like to thank Dr. Niharika. So we were thinking of hosting FERTYGNAN in Vizag. When we did this in Hyderabad, to our surprise, our management was like 250 are the delegates who will be most of the time on Sunday. But in my mind, I was thinking 600 should come and they should know what we are. So it was 594 delegates on Sunday from 8:30 in the morning, 5 p.m. in the evening were glued. We were so happy and we thought the same thing we will mimic in Vizag as well. Thank you, madam, for giving us this opportunity. And also, sir, Sita Rama Raju, sir. Sir, I know so much of work you have done in your field, but personally what I want to understand and talk about, sir, is when I see their discharge summary, I just stop listening to everybody. I just go deep and see their discharge summary. Wonderful summary what you give to patients, sir. It is, even morning I was talking about it. This is something other than the academic, something you do to the patient. Thank you for that. Even we have learned many things, to present the summary that way. And of course, Shashi Prabha madam. By just seeing her, she's so pleasant. She has done, I won't be reading the regular degrees what they have. Everybody knows about her. But she is there even before the session started. Look at the timing what they maintain. So we youngsters should pick up each point from seniors and learn our way forward. So one important thing, whatever said and done about her, I also want to use this platform to thank her daughter. I think everybody knows Sunkara. So I am a very fan of Sunkara. I really didn't know she was from Vizag. Always I was like, oh my God, there is one lady in our country who has gone outside the country and made us so proud. So for this I should thank madam. And always, when our flag outside our country is taken, and it's something I always dream of. Yeah, this is what we should be proud of our country. So she has presented this beautiful research paper of 4 lakhs, more than 4 lakhs couples in the study, and it was a game changer for us in the fertility field. I think fertility experts here can connect with me. The number of oocytes required for a live birth, she has put it so well, and it was definitely a game changer in the field of fertility. And of course, we also invite Dr. Shilpa, who is an observer here. Thank you, madam, for coming here and giving honest opinion of what you are observing here. Thank you so much for taking all your time. So about Ferty9, just 2 minutes, bear with me. Ferty9 started as a small baby. We started 10 years back. We started our journey like a baby. We just started as a nursing home practice, nothing, we knew this art of fertility. We wanted to see how, we can treat the patient. So the whole intention of starting of Ferty9 was service oriented, being transparent, and then ethical. These 3 were our basic root of starting Ferty9. And of course, when we started the journey, from elders from my house was just make a good name. Everything else will follow in life. Only remember, you should be called as a good doctor and a good human being. So journey started that way. And then this was our first center in Sikandrabad. And I am also a firm believer of Abdul Kalam ji. I respect him a lot. And at home, I am very proud. I have Abdul Kalam at home, my father-in-law. I learned so much from him. So this is what I always feel. When your intention is very pure and you know that you want to do some service, and any field, it may be a medical field or wherever you are, if there is some kind of service in whatever you do, and if you touch millions of heart, you don't have to run behind success. Nature comes in, it takes the cause, because God can't manifest everywhere, no? He'll be trying to choose the best. So through him, success is there already. So I believe in that. Somewhere, whatever you do extra mile and put little service in your practice. So nature is there to take care of rest. So now we are 10 years from then, we have 7 centers in AP and Telangana. We are very happy about it. And all this could be achieved with the help of my beautiful, wonderful team. We have 16 consultants with us. So journey started with only 2 doctors, me and one of my doctor as well. But now we are 16 doctors. So bird of same feather flock together. We are very happy about our consultants. Each of them came with good knowledge. Some of them got trained in our center. Some of them came with lot of training. And we are very particular. Every Wednesday we have an academic session with all the consultants. SOPs are driven very strongly. And what is the latest update practices and guidelines are followed in my center. And also at this point I would outside for Hyderabad there are good consultants. They follow the same practice. One example I can tell, when beta HCG comes negative for a patient after IVF, I have my consultants coming and sitting and crying in front of me. Why did it happen? Everything is fine. Because we know even in unexplained infertility, everything is fine, still they fail. So I have to initially counsel, we don't know, so many things are not in our control. So in that way, I am very happy, thankful to all my consultants. They are take care of the patient, very holistically. And of course, we have a good embryology team as well, because training clinician was not as difficult as getting a embryologist. It was not so easy because said and done, most of the things are controlled by embryologists. So thankful to our scientific director Charuji and her team for training and also getting the best in hands to maintain the international success rate. And then this is a beautiful video. I think you can't hear the voice, but I will just explain what's happening. This was a movie in, I think, good news. If you hear the voice, you can understand. The doctor calls, fertility center, most of them, what do they think? 2 couples are sitting there. You know what he's telling? I'm sorry, this is the first time this has happened in my life. What has happened? Then he says, there is some gamete mix-up. Means his sperm and his eggs are put to another lady, embryo transfer. This movie was such a disaster for fertility, I think all of you can echo my voice. After this movie, and it became a successful movie as well. Because, they know how to make it popular. I was seeing this movie and I knew the repercussion of it. The very next week, we got all patients. Madam, are you using my gametes? It was, I just don't go about movie and so many other movies like Vicky Donar, hundreds of kids he has. See, this is not we are made for. We are fertility experts. We do know, a patient sitting in ICU has so much of trauma, the relatives outside ICU. But end of the day, after 1 month or 2 months, he either comes out or whatever. In 1 year, they forget about it. But with the fertility, a lady sitting there with you with the maternity, lot of pregnant women. I have seen in my own life, my own relative as well, the way she was before, so charming. She used to go out everywhere. But repeated in our country, it's always like that. How many years you're married? Then next question is, how many kids you have? It is so much tied up in our, so I also pledge and request all the gynecologists here, because you're seeing the number of fertility raising in our country. Prevention is better than cure. All my topics, I'll never end giving the importance of age. So all your ladies, your family, your friends, please give this importance of age. Whatever women empowerment, we all read, we all have, but end of the day, there is a window of fertility. She has to finish her fertility if she doesn't want to run around doctors before 30. In this, I always have great regards for my elders, my grandmothers who are always telling, first you should finish fertility. You should have a baby. So 30 years is something which, at that point we don't know. Oh, we want to learn, we want to do PG, we want to go there. But what about this uterus starts aging? Ovary starts aging. So we need to, have a single voice, and prevention is better than cure. We don't want all patients coming to us and, breaking their, let them conceive naturally. That's the right of every couple also to conceive naturally. So then we also very happy about our management, they are here and they have got a RI witness system in our all 49 centers. What is this RI witness system? A human error of gamete mismatch, 100% it rules out. It rules out, it is a radio frequency tagged to the patient, how we get a barcode, no? All the dishes of the gametes are tagged 24 hours into 7 days into 365 days. So anything wrong, it pops out. Thank you. Thank you. Done. So we in Ferty9 have created more than 10,000 happy couples. Thanks for all my team. And then also we do lot of training programs where more than 200 gynecologists have been trained for level 1 and some of them for level 2 clinic as well. Because we believe that in periphery there should be a satellite doctor who is expert who can take care of patients there. You know, every patient from villages can't come to the city. So training is so important, at least level 1 clinic. So I'm very thankful to, especially Dr. Shravya. She has taken care of our academic wing very well. Thank you for that. And as a team, we are all there to go. So what I would also end is, we are what we do, repeatedly do. Excellence then become a habit. It's, it's an act, it's not a habit. So that's what we are here for. So now, Ferty9, after 10 years, it started like Madam was telling, you are the stem. I don't feel that. See, any tree or any institute which has to grow, it should be a teamwork. And when patient comes to us, 365 days we are not there. It's always better to train people and put the patients in safe hand. So we are very happy that we have all good consultants now. From STEM, slowly we have grown up and we have formed a good tree, a fruitful tree which wants to give fruits to a lot of childless couple. So from AP Telangana, I also thank my management who also have told that, see, when anybody from our states grow outside, we are very proud, like Sunkara madam. She has gone outside and she's making our country popular. So similar way from AP Telangana, even we need all your support and blessings. We want to continue the good work and we want to even go for Pan India. So we need all your support for that. Thank you so much. Thank you.
Thank you, ma'am. We now welcome Dr. Shilpa, our APMC observer, to address the gathering.
Very good morning, respected dignitaries on the dais and off the dais. Since last 2.5 years, I've been attending several conferences on behalf of the AP Medical Council, but it's always a pleasure for me to attend any meeting which is organized by the OGSV. Because it's such a bright, very cheerful and very colorful faces, and it's really very beautiful conference always when I attend an OGSV meeting. So I congratulate the Ferty9 team with the OGSV for such a wonderful conference. And AP Medical Council is pleased to announce 2 creditas for this conference, and I wish many more ahead. Thank you so much.
40 years and lot of technological advances have happened, but we celebrate to commemorate this occasion as the World IVF Day. And thank you, ladies and gentlemen, for your time and patience. We are extremely privileged to have you all here. Moving on to the next session for the Day of Intrapartum Care in 2016. I request the chairpersons to welcome the speaker.
Thank you for those kind words. Thank you, madam, for having me here. Thank you all the audience. And it is very difficult to, talk about the IVF protocol, but it's a whole day session, but it's difficult to cover in 30 minutes. But we will touch upon the, I do not want to go into the too much depth of the protocol, but I want to touch upon the philosophy and how the thought process can help us in taking decision. So before deciding any IVF protocol, we must understand what is the rationale of the ideal protocol. So there will be proper down regulation, LH window should be maintained, there should be maximum follicle output rate, maybe in the tune of 80%. There should be not only a follicle output rate, FOI, oocyte ratio should be also be somewhere around 60-70%. There should be a minimize progesterone per follicle ratio, because that is the ultimate importance. If the progesterone per follicle is high, that creates a lot of problem, changes the endometrial receptivity. There should be coordinated oocyte, cytoplasmic and nuclear maturity. There should be OHSS free protocol, and there should not be any premature LS surge or progesterone elevation, and should not affect the endometrial receptivity. So these are the, in general, the goals of the IVF stimulation. So what factors you must consider before selecting the IVF protocol? You must understand what is the indication, why you are doing IVF, what's the indication, whether it is endometriosis, PCOS, whether it is fertility preservation, for what purpose you are doing. Second, you have to assign the patient into the responder group, whether they fall into a low responder, normal responder or hyper responder, because protocol doses, everything changes with the responder group. Then you must understand what is your aim. Are you going to freeze all, what is your policy, or you want to take a balanced decision, or you want to take a freeze all cycle, or you want have preference to transfer fresh, because everything is going to change the protocol, which we are going to discuss in next couple of minutes. And you must, if you have any history of previous stimulation at somewhere else, then you must know what is the dose and what was the response, and what happened and what trigger was given, and how many number of mature oocytes. All those details you must have. And whether are you going to include the emergency patient. Now, because this is very common, the patient is on 5 days pills coming to you, she wants to do IVF. The patient who has got, say, 8 days of the cycle, she wants IVF to be done immediately. So they do not want to wait for some reason. Either they have come from abroad, or they have a limited span of time for this purpose, whatever reason. So you must decide whether you want to include in emergency any IVF patient or not. So broadly, if we decide the protocol which is based on the onset of gonadotropin stimulation, it's a standard follicular. We start gonadotropin just after the period, then the luteal stimulation, dual stimulation where follicular as well as the luteal stimulation we do, and the fourth is a random start protocol. At any given point of time, the IVF stimulation can be started, because there are multiple follicular waves, and ovaries are always ready, and some follicles are always ready to recruit any point of time. If you divide the protocol based on mode of down regulation, because why you want to down regulate the pituitary? Because you do not want premature LS surge. So based on the mode of down regulation, first is the antagonist protocol, second is agonist protocol. In agonist protocol, there are long agonists, ultra long, short, ultra short, mini flare, ultra short mini flare, interrupted microflare. A lot of variations are there. And there is a mixed agonist and antagonist protocol. There is a progesterone prime protocol, which nowadays a lot of people using very commonly. And last is CC. This is one of my favorite protocol, especially in donor. So this is because when you give CC, the earliest surge of LS surge, which can happen not before 4 days of stopping the CC, clomiphene citrate. That's one wonderful thing about the CC. And second thing, when you are giving CC, there is always a good level of LH, not only FSH. The LH is secreted from the pituitary, so which helps in symmetrical follicular cohort. So we use CC very commonly in when we are stimulating the donor. Not only reduces the dose of the gonadotropin, but it gives a symmetrical cohort. It prevents the LS surge, and the the protocol becomes very economical. Now, if you divide the protocol based on the quantum of stimulation, it's a standard stimulation where you aim for maybe more than 13, 14 eggs. There is a natural cycle, then you don't give anything. Modified natural cycle, you give trigger. In mild stimulation protocol, you use oral ovulogens and reduce the dose of the gonadotropin. Your aim is somewhere around getting 6 to 10 oocytes. And minimal stimulation of protocol where only trigger and antagonist and some 1 or 2 doses of gonadotropin is used. And no other drugs are used, where you aim 2 to 3 or 4 oocytes. So based on the requirement, these protocols are divided. So briefly about the agonist action. We all know there is an initial flare,
which lasts for 3 to 6 days, and then there is a down regulation. Down regulation may last for 9 days up to 6 weeks. Agonist has got very high affinity and can easily replace the antagonist, and that's how we give agonist trigger in antagonist protocol. The one thing about the agonist is agonist has got direct positive stimulatory action on the ovarian follicle granulosa cells. That's why when suppose we are giving in any protocol agonist plus gonadotropin, if we stop both, there is a fall in E2. But if we continue agonist and we stop gonadotropin, still there is no fall of the E2 and E2 keep rising or maintain the level. That itself proves that gonadotropin has got direct action, stimulatory action on the granulosa cells. So there is an initial flare. Whenever you are using any low-pride depot, never manipulate the cycle, never do anything before 14 days. Because the FSH and LH level will bring down within maybe 1 week. But estrogen and progesterone will take 14 days time. So never stimulate when you are using depot, never stimulate before 14 days of agonist injection. So agonist depot injection can be given on second day of the period, wait for 14 days, confirm the down regulation and start stimulation. There is no problem. The only problem with this is there are chances of cyst formation because there is an initial flare. And this cyst keep disturbing you. Although after 14 days, if you measure, even if in the presence of cyst, if you measure the E2 and LH level, it is always down regulated. But still that creates a disturbance in your mind. So this is a standard long agonist protocol where luteal, mid-luteal agonist is given on day 21. And then after menses, the normally agonist dose is halved or reduced, and then the gonadotropin is started. Always SCG trigger when we use agonist protocol. Now what are the criteria of down regulation? Quickly, E2 it should be less than 30 picogram, but if it is antagonist protocol, even up to 75 is okay, because there is no pituitary down regulation at the beginning of the cycle. The LS should be less than 2 international unit. If it is antagonist, up to 8 is okay. P4 should be less than 1.2 nanogram. There should not be any follicle larger than 10 millimeter, and endometrial thickness should be less than 5 millimeter. So, if you really know the physiology well, you can manipulate everything. Whatever happens, you can manipulate. Suppose E2 is high, you can always give antagonist and or continue agonist and wait for some days. Suppose there is a rise, basal LH level is high. That quite often happens in the PCOS. You antagonist or you start progesterone, then bring down the LH. So you can manipulate. If you have basic knowledge of endocrinology, you can manipulate the cycle the way you want. The P4 is less than 1.2. Now P4 is really difficult to manage because early follicular P4 secretion, you never know, it may be adrenal origin or maybe rescue corpus luteal cyst. You do not know. We can give antagonists which will bring down the progesterone level, but ultimately when you measure the progesterone on the day of trigger, it is always raised. It is high. So there is no a perfect solution for early follicular progesterone elevation. Now, benefit of long protocol. The main benefit of long protocol is it takes care of asymmetry of the follicle. When you start stimulation, you get a plain ground. No estrogen, progesterone, androgens are elevated. That's another advantage. The third advantage of you can afford to have costing. You can afford to have 1 or 2 days delay in the trigger. You can, that is absorbed well, which is not absorbed well by the antagonist cycle. So costing, the batching is more easier. So these are the salient features of the, benefits of the long protocol. And as I said, agonist has got direct action on the follicle. The peak E2 and endometrial thickness is better. Now, lot of studies have come, lot of conclusions have come, but you show me a paper which says that antagonist protocol is better than agonist protocol, long agonist protocol, or long agonist protocol is inferior to antagonist protocol. Everybody will talk about the chances of OHSS, but as far as the results are concerned, as far as the peak E2 is concerned, as far as the endometrial thickness is concerned, the agonist protocol, long agonist protocol is the best protocol minus you have to be careful about the OHSS because you cannot use agonist trigger. There are certain drawbacks. One is chances of OHS because you cannot use agonist trigger, and second, there may be, it's a long protocol, the uses of gonadotropin increase maybe by, I would say, 700, 800 units of gonadotropin are used more. The stimulation is lasting 1 or 2 days at least more. So if you are ready for this, it's fine. This is a diagrammatic representation. Then what about the antagonist administration? Antagonist is very popular protocol amongst all youngster because they just understand when to start antagonist, start stimulation, when to start antagonist, and then matter ends. But it is not that simple as it looks, because there are certain problems which we are going to discuss. So how is the antagonist action? The quick reversible suppression of the pituitary which happens in 8 hours. The effect is more on LH. The half-life is 20 hours. So you need to repeat at least every 24 hours. Cetrolix commonly we use. So if the OM pickup is in the morning, it's better to administer antagonist in the morning because there should be at least 8 hours gap between the last antagonist and agonist trigger. So you have to do that like that. There are two protocols, fixed protocol and flexible protocol. If it is a flexible protocol, then when the lead follicle reaches more or equal to 14 millimeter or E2 more than 400 picogram or stimulation day 7, whichever comes earlier in standard antagonist protocol, that is a flexible protocol, and in fixed protocol, stimulation day 6. Nowadays, a lot of studies, they have come up. According to the recent study, the results are better when they started late, when E2 level is between 500 and 1000 picogram. The late start when mild protocol or when CC is used. If the protocol is mild, where lower dose of gonadotropin is used, or the oral ovulation in the form of clomiphene is used, you can afford to delay antagonist administration even up to 16 millimeter when the size of the follicle reaches up to 16 millimeter. This is about the antagonist administration. Minimum 8 hours and maximum 20 hours gap between the antagonist and agonist trigger. The advantage of the antagonist protocol is single most is the OHS prevention and less consumption of the gonadotropin. These are the two very, very important advantages of antagonist protocol. The agonist trigger can be used with all its advantages, and if you notice, all the soft protocol or mild protocol are possible only with the antagonist protocol. It's not possible with the agonist protocol. And antagonist has got direct action on the lutein cell, reducing the VEGF, which helps in reduction in the OHSS. So what are the drawbacks of the antagonist protocol? The biggest drawback is the asymmetry of the follicle. That's the biggest problem. The batching is really difficult as compared to the long agonist protocol. Antagonist affects the endometrial receptivity. It has got negative effect. The unrecognized, you don't get plain ground when you start stimulation. There may be progesterone elevated, maybe estrogen elevated, maybe, see, if unrecognized estrogen is elevated, your results are going to be disturbed. If FSH, unrecognized FSH at the beginning of the antagonist cycle is more than 9, then your results are going to be affected. So we are not measuring, at least in my center, I do not measure all the time all the basal levels and all those things, because sometimes it is, if wrong reports, it's more confusing and more creating anxiety. But then if it is unrecognized, then sometimes problem can be there. And the batching is another problem which we already discussed. There is no universal acceptance or consensus, you can say, when to start the antagonist protocol. Because earlier we all used to believe, please listen carefully, we all used to believe that when there is a rise of estradiol beyond 200 and that sustains for some hours, maybe 50 hours, then the LS surge is initiated. This is old thinking. This is old thinking. Newer concept is, it's not estradiol. Estrogen primed follicle, when progesterone is elevated, that initiates the trigger. Not the estradiol is initiating the trigger. The progesterone which is coming from follicle, when the oocyte is ready to liberate or ready to convert into M2, mature oocytes, near mature oocytes, that gives a signal. So the progesterone is secreted and that initiates, that changes the pulsability of the GnRH, and that's how the LS surge happens. So, ideally you should not worry about the LS surge if the follicle size is less than 15-16 millimeter, because we all know after 15 millimeter there are chances of getting mature oocytes and ovulation. So till 15 millimeter I think you should not worry, and especially when you are using oral ovulation, you are protected because next 4 days the LS surge is not going to happen. The drawback of antagonist is costing is not possible. So if you do costing, then you have to freeze the cycle. Chances of premature LS surge is higher as compared to long agonist. Early follicular progesterone elevation is difficult, to manage. There sometimes estradiol level may plateau or fall after antagonist is started. It's different. Sometimes it is elevated, sometimes it is dropped. So it is not clearly understood. Antagonist action is not very clearly understood. So that's many times we are hesitant to use antagonist protocol unless it is hyper responder. SORT agonist protocol very rarely used. The purpose of using SORT agonist protocol is you initially you want flare, so which takes help of the natural hormone secreted from the progesterone, which is different from the artificially introduced hormones. So they give a better recruitment. But practically very few people are using a SORT agonist protocol. Now progesterone. Progesterone inhibits the transmission of E2 signal and decreases the GnRH pulse frequency and increases the amplitude, but net effect is reduction in the LH level. Medroxyprogesterone we commonly use, dose is 4 to 10 milligram. Once you start medroxyprogesterone, the downregulation of the pituitary starts after 5 days and washout period is 5 days. So once you stop progesterone, after 5 days the pituitary is recovered. To be precisely, after 5 days of washout period, the hormonal level, FSH level, is similar to day 3 of your natural cycle. Right? When progesterone should be started after ovulation, documented ovulation ideally. And if it is OC pills pre-treated cycle, you can start the day 2 also. The usage in long agonist protocol overlapping 1 to 3 days is sufficient. Many people they overlap by 5 days, some overlap 3 days, some overlap even 1 day is also sufficient, because next 5 days you are protected and the flare action only remains for 3 to 6 days. So safety margin is there. In PPOS it is commonly used. Severe PCOS from the starting along with the gonadotropin is another uses we commonly do. If patient cannot afford to have antagonist right from the beginning and patient is severe PCOS, the AMH level is more than 8, 9, 10, raised basal LH level, severe PCOS, difficult to stimulate, poor responder PCOS, where the progesterone should be, medroxyprogesterone should be started along with the gonadotropin or antagonist. Then the adjuvants regarding the OC pill, it should be started from the second day, always minimum 15 days for long agonist protocol and 7 to 10 days for agonist flare or antagonist protocol. The prolonged OCP causes profound downregulation, which leads to an increased gonadotropin consumption and agonist trigger failure. The empty follicle, it is the main reason for empty follicle syndrome in donors, because they use OC pills like peanuts. Similarly, downregulation starts after 5 days of OC pills, washout period is 5 days, the overlap is 1 day is sufficient. OC pills are used in all spectrum of the patient, whether you hate, whether you like, but you cannot neglect OC pills. Can be used with the agonist in long downregulated protocol, must with flare protocol to dilute the effect of flare, agonist flare on androgen and progesterone. OCP pills pre-treatment is good. Then the adjuvant estradiol, commonly many people have the habit. The estradiol 4 milligram from the mid-luteal phase can be continued up to 18 days. Irrespective of the onset of the menses. Even if the menses is there is onset, you can continue with the estradiol. The gonadotropin stimulation to be started after stopping 1 day estradiol free level. If you are starting estradiol in the early follicular phase, the recruitment phase is little widened and you have a better recruitment of the follicle. It increases the sensitivity of the follicle towards FSH. So indirectly it helps. A lot of people can continuing estradiol till trigger along with the gonadotropin. No harm, you can do that. So after stopping estradiol, there is a rebound rise of endogenous FSH which can act together with the exogenous administered gonadotropin. What are addition which you can use in down regulation? You can use, especially in young poor responder, luteal E2 antagonist protocol. You can add small activity of the SCG, which helps in the maturity of the oocytes. And other expected poor responder, you can add gonadotropin, growth hormone, just 0.5 units. In long agonist down-regulated protocol, if you use growth hormone, just 0.5 units is just sufficient. Testosterone gel in poor responder you can use. Change in the dose of agonist 25%, you can make it 25% of the initial dose. Then the modification of the follicular phase agonist cycle. Nutshell, sometimes in an unexpected poor responder, suppose on stimulation day 7, you want to take a decision whether you want to increase the dose, it is going to be useful or not. So if you measure the serum FSH level, and if FSH level is more than 20, that means all the gonadotropin receptors are occupied and there is no point in increasing the dose. But if it is less than 20, then still there is a scope that bioavailability of the gonadotropin is not reaching to the granulosa cell receptor, and you can increase the dose of the gonadotropin. Then modification of the antagonist protocol, estradiol we discussed, estradiol with antagonist in luteal into antagonist, small dose of LH can be added, post OCP estradiol can be given. This is another good thing, I tell you. Many times what happens, when you are giving OCP pills and after 5 days of washout period, when you start stimulation, one follicle is recruited. So if you do not want that, what you should do, after finishing the OCP pills, estradiol should be continued till the patient gets the menses, because this estradiol will keep check on the FSH and which will prevent the recruitment of the follicle. So that's a very good thing to be implemented in your practice. So this is standard antagonist protocol, nothing much to say. This is basically for poor responder we charted out, where we use pyridostigmine also during the follicular phase. Now what are the factors which decide the starting dose of the gonadotropin? Age, baseline FSH, E2, LH, AFC, BMI, whether there is a presence of PCOS. We all know, it is very well known how the dose is decided. So starting dose, how it is to be decided? Starter dose is 150. If age is more than 37, add 75. If milder PCOS, minus 75. If PCO bad, no deduction in the dose, because ultimately we will have to increase the dose. Bad PCOS, characteristic of the bad PCOS, they are resistant to stimulate. They need higher dose of gonadotropin and very thin margin of safety. Suddenly there will be blast, multiple follicles. So you have to be very careful. Always try to bring down the basal LH level, because AMH, LH and androgens all go hand in hand. So whenever there is severe PCOS, always make sure that you start when the LH level is on lower side. That can be achieved with the progesterone or antagonist. There is a history of OHSS, you can decrease 75. If there was a previous poor response, you can increase 75, maximum 450. And endometriosis, pelvic adhesion, peritoneal disorder, you have to increase by 75. Side effects of extraordinary high dose, resistant oocytes, progesterone elevation. And very important point I want to highlight. Many times, all youngsters, they think that, okay, Sankara has said that if you want to increase the cumulative pregnancy, then you can start with the stimulation with the 450, 600, whatever you want. Because ultimately, you are concerned with the cumulative pregnancy out of one stimulation. But that's not correct. Why not correct? Because there are papers which says that even if there is a progesterone elevation more than 2.25 or maybe 2.5 after the stimulation on the day of trigger, these oocytes, even if you freeze the embryos with these oocytes, they are not going to give the pregnancy. These are not normal embryos, these are aneuploid embryos. So you should have you should be little rational on increasing the dose of the gonadotropin. You should not increase the dose beyond 450. 450 is upper limit, you should not go beyond that. Because there are very high chance of progesterone elevation, there are very high chance of escape of suppression of the pituitary, so maybe premature LS surge, endometrial receptivity disturbed. Blastocyst rate is same whether you use a milder dose or higher dose. LH activity is useful in posidone group 1, 3 and 4, mainly elderly patient. In elderly patient, more than 34 years, the recombinant LH is inferior to small dose of SCG. You must understand. Small dose of SCG is better in elderly patient. This is very important. The monitoring of the stimulation. So these always should be registered in your mind. The E2 doubles in 2 days. The Play2 more than 3 days associated with the poor outcome. Mature follicle contribute 200 picogram each. The lead follicle grows 2 millimeter per day. The follicle more than 8 to 10 millimeter acquires LH receptor. The E2 continue increasing for 1 day after stopping the gonadotropin, and follicle continue to grow for 4 days after stopping the gonadotropin. Effect of gonadotropin only be judged after 4 days. See, many youngsters, they are habit. 2 दिन gonadotropin, 2 days they give gonadotropin, then call the patient and see the follicular scan. No, never do that. If you want to judge the effect of gonadotropin, you have to wait for 4 days. After 4 days only call the patient and see the effect. And if it is insufficient, you can increase the dose at that time. Follicle growth was considered to be asynchronous when one or two follicles, leading follicles were more than 4 millimeter larger than the rest of the cohort. That's the definition of the asymmetry. Now, what is the optimum stimulation? On day 6, if you get 10 to 12 millimeter follicle, it's good. You're going good job. On day 8, 14 to 16 millimeter, and on day 10, at least 3 follicles should be more than 17 millimeter. Costing, nowadays we don't do. Costing more than 3 days is not advisable. If there is a severe fall of estradiol, that's not good. Cycle cancellation on stimulation day 7. If the estradiol is found less, there is no follicle more than 10 millimeter cycle, this cycle requires to be cancelled. Trigger criteria, we follow majority of the follicle should be between 17 to 22 millimeter. If it is long agonist protocol, we can give 1 or 2 days extra. It increases the oocyte yield, but does not translate into increasing the live birth rate. Agonist trigger, when E2 is less than 4,000, dual trigger with SCG can be given. If it is more than that, then better not to give SCG. Then regarding the trigger, dual trigger is best except hyperresponder. Double trigger when there is a lesser follicle output rate or empty follicle syndrome, or I think I will quickly rush. This is very important. When we should expect suboptimal response to the trigger. So at the starting of the stimulation cycle, if the LH level was less than 1 international unit, there are 15% chances. And if it is more than 2 international unit, less than 2% chances. So it is good to measure serum LH level, especially in donor at the beginning of the cycle. On the day of trigger, it is not so important, because on the day of trigger, even if it is less than 0.5 international unit, only 5% chances. And if it is less than 0.1, 25% chances. But it rarely happens less than 0.1 on trigger day LH level. It rarely happens. So better to scrutinize at the beginning of the cycle only. Risk factors were present, use SCG at the same time only. But if there was absent, then repeat serum LH level and 12 hours after the trigger. Serum LH level, 12 hours after the trigger. So LH level on the day of trigger, if you do not measure, that's fine. But after agonist trigger, measure 12 hours after the trigger LH level. If it is less than 15, then you have to pre-trigger, do serum progesterone level. And serum progesterone doubling is not there. Then you can give SHG 10,000 unit at the 24 hours and pick up at 60 hours, 36 hours after the trigger. But if it is more than 30 LH level, then there is no extra measures are required. And if it is in between, then you have to look into a progesterone level. Progesterone prime protocol commonly used. Doses requirement is more. If you want to emergency include, there are a lot of Madam, can I stop? Because it's not possible to finish the presentation. I'm really sorry.
Thank you, Dr. Rajesh Kadia. You made it very concise, though it's a very, very difficult topic to concise it. And we too feel your problem here. Yeah, thank you.
Thank you. Really sorry I couldn't finish my presentation, but I'm here to answer your queries regarding the protocols.
Over to the next session. The most heart-throbbing situation for the IVF team and even more to the couple is the unexplained infertility. And now I invite Dr. Suma Varsha to explain the situation. Dr. Suma Varsha had earlier worked at, she's from the Vijayawada Center. She has earlier worked as an assistant professor in SWIMS Tirupati. She had done fellowship in reproductive medicine and course in OBG ultrasound, in gynae endoscopy, had presented many papers and contributed to textbooks. Dr. Suma Varsha, please continue.
Thank you so much, dear Chairperson. So good afternoon, all of you. So greetings to all of you from Vijayawada, and all of us definitely come across this situation where, the couple comes to us saying that we've been to so many doctors before this, we've had so many tests, always the tests are turning out to be normal, everything is normal, but we are not getting our pregnancy. We have spent lakhs of rupees, but we don't have an answer. And they come to you with that $1 million question of, why are we failing? So today I'm going to talk about this enigma of unexplained infertility. Now, why is this important? Why is this topic important? Firstly, because it is as common as 30% of all infertile couples that we are looking at. So 30% of infertile couples, they try for, they have unprotected intercourse for 12 months or for 6 months if the female is more than 35 years, and they get their investigations done, they are normal, and they come to us. And the second thing is, when we are fighting an invisible enemy, it is always better that we have some guidance, right? So that is the importance of this particular topic. So coming to the definition, so different, the RCOG guidelines are there, we had the ICMERT guidelines, we had the ASRM in 2020 and the ISHRE in 2023 with different giving us a guidance of how do we label a patient as unexplained infertility. So the most recent was the ISHRE guideline in 2023, where they say that we have to document ovulation. This could be with either a positive LH, LH kit test, or an ultrasound monitoring, or a mid-luteal progesterone. We should document patent tubes with a HSG or a HyCoSy. You need not do a laparoscopy for all your patients. A simple HSG or a HyCoSy is sufficient. And a standard semen analysis. 2020-21 guidelines followed WHO lab standard semen analysis. If these three are normal, then you can probably label the patient as unexplained infertility. But the question is, are we excluding enough? Okay, by doing a scan, a tubal patency test, and a semen analysis, are we actually excluding enough? If we are, then why is the patient not conceiving? So what are we actually missing at? So are there anything else that we can be looking into, which could probably be the reason for her infertility? So there are so many things that we actually don't test. When we are doing these standard 3 tests, we do not know about the oocyte quality. We do not know about the sperm function. We measure the count, we measure the motility, we look at the morphology, but we do not know the functionality of the sperm. There are so many tests that we can do to know the function. It could be a DNA fragmentation, it could be a vitality test, it could be, as Chaitanya sir was mentioning, the ROS levels. So there are so many such tests which are available. Functioning of the tubes is not tested. The tubes being open does not necessarily mean that they are functioning. Now we have the chlamydia antibody tests that are available, and if the chlamydia antibody test is positive, it is suggested that the patient go through a laparoscopy to find out the functionality of the tube as well. Sperm cervical mucus interaction, endocrine problems like thyroid or prolactin disorders, autoimmune, there is a whole spectrum of autoimmune diseases which we are actually not testing. Endometrial receptivity, a lot of work has been done in this area where, we do the endometrial receptivity array to find out if the endometrium is receptive, pre-receptive, non-receptive. Hysteroscopy to rule out uterine abnormalities which are not otherwise picked up on scan. Laparoscopy probably to diagnose a stage of endometriosis which cannot be picked up on scan, or adhesions in the adnexa, which you don't normally see on scan. So there are so many such things which we are actually not looking at before we label the patient with unexplained infertility and go for a treatment. So does this mean that we have to do all of these tests and actually find out what the reason is and treat? Because if you don't know what to treat, what are you going to do with the patient? So this is a never-ending debate, and there are some people who say that there is, it's a bogus diagnosis. You have to go into the depths of all these things that we are missing, find out the reason and then treat. And there are some who says that, it is pretty reasonable to label the patient as unexplained and go ahead with the treatment, because finding out the reason with so many investigations may not actually change what you are going to do with the patient. So looking from the patient's point of view, are so many investigations justified? Basically, what does the patient want? The patient wants a faster success with a reasonable cost, a lesser treatment burden, probably lesser time to pregnancy and lesser cost to the patient. So the recent ISHRAE guidelines 2023 have said that a 3D ultrasound could reasonably rule out uterine abnormalities, and a laparoscopy is indicated only in patients where you have an abnormal HSG or a history of PID, previous ectopic pregnancy or a known endometriosis. Apart from this, laparoscopy is not required. Now what about the male partner? So I told you we have so many tests available for the male partner, but ISHRAE 2023 guidelines have re-emphasized that if the standard semen analysis is normal, you don't have to further evaluate the patient. So having said that, we are now convinced again that it is only 3 tests that we need to do. That is, diagnose ovulation, look for tubal patency, and a standard semen analysis. And if these are normal, we can label the patient as unexplained and probably proceed for the treatment. So what are the options that we have? So we can go for an expectant management. See, everything is normal. You just reassure the patient, convince them that they can try for some more time and go for an expectant management. Or you can go for a simple ovulation induction and timed intercourse, or intrauterine insemination with or without drugs with oral ovulogens or gonadotropins, or the last option would be IVF or ICSI. So because we don't find a cause, expectant management has a lot of weightage in unexplained infertility. There are a lot of studies, there are a lot of guidelines which actually say that, expectant management is the way forward, because in the first year after you diagnose unexplained infertility, 15 to 20% patients conceive. In the second year, almost 35 patients conceive. And in the third year, by the end of the third year, by expectant management, a few old studies have said that almost 80% of the patients conceive. But can you convince the patient to wait for that long? So it's not easy. You tell the patient who has already been trying for 1.5, 2 years comes to you and you say that, hey, everything is normal, you wait for 1 more year. So it's not easy to convince that particular patient. So what does the evidence say? So when it comes to unexplained infertility, we have various guidelines. We have the NICE guidelines in 2013. We have the ASRM guidelines in 2020. And we have the ISHRAE guidelines which were recently published in 2023. So they're all guidelines which are almost 80-100 pages. I'm just giving you a brief summary of it. So the NICE 2013 guidelines says that you have to try for 2 years with expectant management, and if it doesn't work, go ahead with IVF. So 2 years of expectant management means if the patient comes to you with 2 years of unprotected intercourse already, you don't wait for 2 more years, you go ahead with IVF. If the patient comes to you with 1 year of unprotected intercourse, you'll ask the patient to wait for 1 more year, and if she doesn't conceive, go ahead with IVF. No role of oral ovulogens, no role of gonadotropins, no role of IUI, no role of timed intercourse, directly IVF. Easy to convince your patients. It then later on a survey in the UK itself, it revealed that many in UK itself were not able to follow this protocol. So now what about the ASRM 2020 guidelines? So ASRM 2020 guidelines says that ovulation induction and timed intercourse is no better than an expectant management. So you're not doing anything great by just giving ovulation induction and timed intercourse. IUI with oral ovulogens should be tried for 3 to 4 cycles. IUI with gonadotropins, they said no because of the increased chance of OHSS and multiple pregnancy. And then 3 to 4 cycles after oral ovulogens and IUI, they don't conceive, go ahead with IVF or ICSI. So this was ASRM 2020 guidelines where they are very cautious about using gonadotropins for the simple reason that they don't want OHSS and multiple pregnancy. See, in our country, people are very happy with a multiple pregnancy. But definitely, as an obstetrician, we know what it is to have a multiple pregnancy, what is the treatment burden that the patient may have to go through, and what are the complications the patient has to go through. Now, the recent ISHRAE guidelines 2023 says, oral ovulation and timed intercourse is not going to help us better than an expectant management, but IUI with ovarian stimulation has to be done for 3 to 6 cycles, which includes even gonadotropins with low doses with adequate monitoring. You should have strict cancellation criteria, so that you avoid the complications, but you get the benefit as well. And if this doesn't work, go ahead for IVF, or directly go ahead for IVF based on the patient's profile, based on how many years she's been married, her age. So if she has anything else which says that, okay, she can go ahead for an IVF, go ahead. So now, these are the 3 guidelines for you. I think I've created enough controversy to all of you. But one thing I want to highlight, getting back to the guidelines, is all the 3 guidelines tell us that giving only oral ovulations to the patient is not going to do any more benefit to the patient. So if a patient comes to you today with all the 3 standard tests being normal, by putting her again on oral ovulations for 3 cycles or 6 cycles and just waiting, you're just going to waste her precious time. And it's been proven beyond doubt by all the 3 guidelines that we have. So what are the options that we are actually left with? Either we go for an IUI or we go for an IVF, and that you can stratify based on your patient's profile. Now, if I have not confused you enough, I have 2 more papers or 2 more trials to be discussed. One is the FAST trial and one is the FORT trial. Now, the FAST trial, the study population is between 21 years to 35 years. So they divided their patients into 2 arms. The first arm, they had CC with IUI for 3 cycles, followed by gonadotropins with IUI for 3 cycles, followed by IVF for 6 cycles. The accelerated arm, they used CC IUI for 3 cycles and then went to IVF 6 cycles. Now the results show that there is a decreased time to pregnancy and decreased average cost, cumulative cost in the accelerated arm. Now all this is possible in UK where everything is funded, but I'm just putting it for your reference. Now the 4th trial is where, now this was, the FAST trial was for 21 to 38 years, and now this is for 40-year-old females. So now again they have divided into 3 arms where you have cycles to CC with IUI followed by IVF in the first arm, FSH IUI followed by IVF in the second arm, and immediate IVF in the third arm. And here again they say that immediate IVF demonstrated superior pregnancy rate with fewer treatment cycles. So with all these guidelines and these 2 trials, what are you actually going to do? Again, coming back, the patient wants fast success and lesser treatment burden. And I would like to emphasize on this particular line, which we have been discussing since morning, that actually evidence is not meant to define your practice, that you do only this. It is only meant to refine your practice. So ultimately, you have to figure out a practical option which you can follow with your set of patients in your scenario, in your place, right? So what we normally follow is, if the patient is more than 38 years, convince the patient for IVF, that should be the best option. If the patient is less than 30 years, probably think of 2-3 cycles of, we do a combined oral ovulation gonadotropin cycle. We don't do only gonadotropins, keeping the cost in mind, keeping the success rate of IUI in mind, and if it doesn't work, go for an IVF. So 2 options, one is IUI, one is IVF. Now, is there something better we can do in these 2 in patients with unexplained infertility? So you're anyway shooting arrows in the dark. You don't know what you're treating, but you're treating. So can we do something better in these patients? So coming to IUI, there are a few strategies which can probably help you improve your success rates in patients, especially with unexplained infertility. So try and go for a superovulation. So normally when you want to induce a patient, you want monofollicular development. But in patients with unexplained, probably aim at getting 2 follicles. So studies have shown that as the number of follicle increases, 2nd follicle or the 3rd follicle, the pregnancy rates increase. And beyond that, actually it doesn't make much of a difference. But the chance of multiple pregnancy increases. So try and get 2 follicles and probably it will increase your success rate. But in the process, you should have a strict cancellation criteria as well. So if you have more than 3 follicles of 18 mm or more than 5 follicles of 12 mm, definitely you have to cancel that cycle. So keeping this in mind, with strict ultrasound monitoring, go ahead with gonadotropin IUI cycles, try and get 2 follicles and do an IUI. Now, what about the sperm preparation techniques? So, my embryologist had discussed about the sperm preparation techniques. We have evidence that when the patient is normozoospermic, going for a simple swim up will give you decreased chances of having DNA fragmented sperms, and it gives you a better outcome. So when you're doing a density gradient method of sample preparation, you're subjecting the sperm to centrifugation, which could probably increase the DNA fragmentation. So consider just simple swim up, because these patients have a normal sample. You know, the semen analysis shows normal count, normal motility, normal morphology. You just want to filter out the motile sperms and do an IUI. So go ahead with a simple swim up. Now, is there a role of a double IUI? So in unexplained infertility, because you want to give more gametes, probably get more follicles, put in more sperms, does it help? So evidence has shown that doing a double IUI actually does not have much of a benefit even in unexplained infertility, and this has been reaffirmed even in the recent ISHRAE guidelines, that a single well-timed IUI is more than enough for your patients with unexplained infertility. Now, what about in IVF? Can we do anything different? So we were talking about ROS levels, probably they could be high in unexplained infertility. So can we use some adjuvants? Will antioxidants work in these patients? So should we give our patients 2-3 months of antioxidants before we proceed for an IVF? So evidence says that there is no role of giving oral antioxidants to these patients with unexplained infertility, and it is not improving the live birth rate or the outcome. Now, what about sample preparation? So can we use a microfluidic chip to select the least DNA fragmented sperm for your patients with unexplained infertility? Yes, a few studies have proven that if you use a microfluidic chip, you get better quality embryos, better chances of getting top quality embryos, but there is not a significant increase in the live birth rate. So again, you have to take it with a pinch of salt. Now, do we have to go for ICSI for all? So in unexplained infertility, we could probably think of fertilization failure as a cause for infertility and think of going ahead with ICSI for all. But again, time and again, all the studies have proven, and even the ISHRAE guidelines, ASRM guidelines have told us that there is no difference whether you go ahead with IVF or ICSI. So you don't have to do ICSI for all in your patients with unexplained infertility. So putting all this in a nutshell, the diagnosis is important. So doing a simple scan, a semen analysis and a tubal patency, you should be diagnosing an unexplained infertility. But make sure that your tests are done in a standardized way. Okay, so see that your semen analysis is done in a proper standard lab who follows the guidelines. So as I was telling Chaitanya sir, he said that, so many reports he still sees where they say the normal count is 40 to 60 million. And we also come across so many reports which say, normal forms are 80% and 90%. So how reliable are these tests? So think about the reliability of where you're getting your semen analysis done. Tubal patency. So we had a patient where we had normal tubes, we did 3 IUIs, everything was looking normal. She didn't conceive, then we did a laparoscopy, we found out that the tubo-ovarian relation is altered. The tubes are not actually sitting on the ovary is somewhere, the tube is somewhere. So that has to be looked into. Coming to scan, antral follicle count measurement is extremely important. So we should not be missing out on our poor ovarian reserve patients. So now having a normal reserve and seeing all that and labeling the patient unexplained infertility is extremely important. So these simple things should be done to make sure that you are actually diagnosing the patient correctly and putting that patient into the right pocket. So ultimately, IUI with ovarian stimulation is recommended. Aim at 2 follicles. IUI with simple wash, single IUI at 36 hours should do. Decision for IVF should depend on number of factors. We normally with a patient with unexplained infertility, as I have pointed out, if the age is slightly lesser, we try 2-3 cycles of IUI and it doesn't work out, we go ahead with IVF. And your ultimate trump card should be that in this process, anytime you can conceive normally. So you advise an IVF, the patient comes to you with a pregnancy, the next month she'll think that, you're doing unnecessary treatment. So you counseling the patient and telling her that expectant management actually has a role. Even if the patient is in treatment, during the treatment also you should be encouraging her that any month you can conceive naturally, you keep trying. So thank you so much for your patient listening. Though I was the only one between you and your lunch, you were very attentive. Thank you so much.
Thank you, Dr. Suma. You explained, unexplained infertility very well. And I think, I don't know, I'm not an expert in this. Before declaring unexplained infertility, I think you need to do at least histolab. You said some points now.
Diagnosis, actually, the evidence says it's not required, madam. But yes, in certain situations where you're suspecting a PID or suspecting an endometriosis from the history, or something which points out that you could probably be missing on something, you can go ahead. But doing a diagnostic histrolab for all patients who have a normal tube, a normal semen analysis and a normal scan, I don't think it's recommended. Stage 1, stage 2, yes sir, you cannot detect it. But stage 1, stage 2, you can still go for ovarian stimulation and IUI even without doing a diagnostic histrolab.
So rightly pointed out, unexplained infertility is enigma. We don't know where we are shooting. But will laparoscopy add value to the treatment? Example, you do laparoscopy for everybody. Afterwards, what do? You either release adhesions, but after releasing adhesions, again in a couple of months it can go back to the same form. So end of the day, cost-benefit ratio, if you see, doing laparoscopy for all, again they will come back to you for IUI. Why don't you do IUI instead of doing laparoscopy for all? Especially in scan, if you pick up somewhere, there is adhesions, ovary is somewhere stuck. So certain conditions definitely it adds values, especially if women coming with history of endometriosis, subtle endometriosis, where she has dysmenorrhea, dyspareunia, where you have to rule off. So laparoscopy has a value in a younger woman if you don't go for an advanced treatment. All said and done, we have to weigh and balance. IVF is also like after 2 IUI, 3 IUI failure, let us see if something is there. Some of them even do laparoscopy to find out any subtle reason before going for IVF. But end of the day, what they want is a baby. Even laparoscopy is not a treatment, you're just diagnosing. After diagnosing, what are you going to do? So this is always a debate.
And versus compared with gonadotropins and IUI, success rate is better with gonadotropins.
Surgeons are always vote for laparoscopy. Fertility expert usually plan to give a take-home baby. So it's always, we have to individualize the patient. One protocol doesn't fit all. So we have to see the patient condition, their age, duration of infertility, symptoms. Together we have to take a decision.
So 3 IUI, no laparoscopy, then 3 more.
No, I'd also encourage the patient to tell naturally. Most of the time it so happens 3 IVF failed also. They conceive naturally. We have seen many patients. So I'd always tell unexplained infertility, we don't know. Body is a auto healer. Body regenerate itself. Always you try your natural way here to decrease the time to pregnancy.
What is your experience of counseling patients for expectant management? Have you got some patients?
See, what I usually do now after ASRM and so many research, I just give them a true example. See, science says that you trying with oral ovulation tablets gives the same percentage of success you trying at home. What do you want? You want to come here, sit in front of me, take tablets for 6 months, or results are same. But whatever said and done, it's very tough. There are people, it all depends again. We try to explain them, but end of the day, gonadotropin, whatever study says, some papers don't support, but we do use superovulation, try to put some gonadotropins with oral ovulation to cut down the cost, and then we also tell them IUI may increase the chance of pregnancy compared to stimulation.
Of lean PCO, those patients who are not willing to come to us for follow-up for gonadotropin cycles, yeah, and high androgen features unte, maybe other features, hirsutism, then yes.
Thank you, sir. I think we have opened a tin of worms, so it's a never-ending debate. I request our chairpersons to present a memento to Dr. Rajesh Koradia, sir. I request Dr. Jyothi to present a memento to our chairpersons. Dr. Subbaraju sir, Dr. Padmavati ma'am, and Dr. Sandhya Devi.
Hello. Good morning, my teachers and friends. Today I am privileged to introduce Dr. Kavya Reddy. She is an expert fertility consultant in FERTY9 Center, Visakhapatnam. Dr. Kavya Reddy did her MBBS in Sri Devarajar's Medical College, Kolar, and she did post-graduation in DNB OBGYN in Narayana Hridayalaya, Bangalore, and worked as a consultant in Narayana Medical College for 2 years. And Madam did fellowship in reproductive medicine, Craft, Konda, Gallur, and worked as a fertility specialist in Craft Fertility Center for 1 year in Cochin. Madam is going to enlighten you for ovulation induction and follicular monitoring.
Thank you for the kind introduction, madam. Welcome to the session. We have protocols, which is very difficult to understand, but now present practice, as an infertility patient walks into our OPD, definitely if we tell IVF, they will run away from us. So depending on the patient and previous history of the patient criteria, we have to choose them what treatment to be given. Most common treatment what we give as a gynecologist is ovulation induction for most of the patients. First, regarding the ovulation induction, we have to know the physiology of ovulation induction when we are treating the patient. I'd like to more concentrate on the physiology and the mechanism of action of drugs, how does they work. So our main aim is development of one or more ovarian follicles so that they reach the stage of maturation for them to become fertilized. And the target is only singleton pregnancy, not the multiple pregnancy, and decreasing the risk of OHSS. So as Suma ma'am already told, the ovulation induction, we talk about whether we want monofollicular development or multifollicular development. Definitely it is monofollicular development, but in a patient who is having PCOD, who is having anovulation, where you can see the first slide, when the patient is having anovulation, our target is single dominant follicle. But patient who is having regular cycles with no anovulation, like in patients like unexplained infertility, if we are treating patient for the case of male factor and stage 1 and 2 endometriosis, where we are giving ovulation induction, the target will be super ovulation, that is multiple dominant follicles, which have to be less than 3. If it is more than 3, we have to cancel the cycle and we have to go for the next cycle. So the important concept for folliculogenesis we have to know is FSH threshold. Like what is FSH threshold and what is FSH window? Threshold is nothing but the concentration of FSH required to initiate the secondary recruitment of the follicles. First, till the small antral follicle, they are all FSH independent. They are growing without any dependence on FSH. Then we have to intervene from day 2 or day 3 of cycle. The FSH will act on this follicle and the follicle will become a dominant follicle. That is a natural procedure. So what is FSH window? The duration of the FSH for which FSH will be above the threshold. That is called FSH window. So the duration of FSH remains above the window, number of follicle will increase. So if you can see this, there are different follicles. In number 7, there are only 3 receptors for this follicle. Every follicle will have different threshold. For example, if a follicle which is having a minimum number of receptors, for 50 international units of FSH, it will increase. For other follicle, the receptors are very less and it will require 150 international units of FSH for recruitment of this particular follicle. So when the threshold is attained, first thing what will happen is the follicle will be rescued from the atresia and the follicle will become selected. That is called selection of follicle, which further become dominant follicle and further it will ovulate. So other follicles which are not meeting the threshold, which are not in the window, they slowly will become atretic. So at the beginning of the cycle, only if the serum concentration exceeds the FSH threshold, follicular development will happen. If the follicles are not, the threshold is not reached, no follicle will be developed. Unlike in PCOD, it is totally different. So this is a spontaneous menstrual cycle where you can see the FSH window. The window is small between the luteofollicular transition. You can see only one dominant follicle being selected. So when we are giving ovulation induction, our target is to increase the window. So in increasing the window, what we are doing by increasing the window, the number of follicles which are selected to become dominant will be increased. In this slide, you can see the 3 follicles are becoming selected and further they become dominant. Other follicles will become atretic. This is a stimulated cycles. So this is a normal physiology of any cycle. Like 3 months, follicles will be there inside the ovary and they'll be waiting for them to be recruited. Okay, after 3 months, when they become small antral follicle and when FSH is above the threshold, they will become recruited. So what are the changes you see in a follicle from day 2, day 6? What are the changes? Slowly the follicle will be increasing in size. This is a natural cycle or ovulation induction cycle. The size of the follicle will be increased, which is around 1.2 to 2 millimeters per day. So when a dominant follicle, when we call it as a dominant follicle, any follicle which is around 18 to 22 mm, we call it as a dominant follicle. It also depends upon the which ovulation induction agent what we are giving. So when the dominance is reached, even the vascularity of the follicle, as Sonal ma'am said, it is fully vascular follicle. So what are the ovulation induction presently available? Selective estrogen receptor modulator, clomiphene citrate and tamoxifen, aromatase inhibitors, letrozole and anastrozole. Anastrozole is mostly used in male factor infertility, and gonadotrophins like FSH and HMG. So the next question is what drug to be chosen and what dose to be chosen for this treatment. So mainly individualizing of the treatment is very, very important when we are doing IVF or ovulation induction, anything. So we have to see the age of the patient, what is her ovarian reserve, AMH and AFC, what are the primary cause of infertility and prior response. For example, patient is already been treated and it was found to be clomiphene resistant. We can't give again clomiphene in this cycle also and we want the ovulation to happen. So we have to change the protocols. So years of infertility also matter because more than 3 years of infertility, we have to treat them very carefully. Obese patients will respond less with the ovulation induction agents. So how do we select the patient and which patient will have better success rate? Younger patients who are having acceptable AFC and patent tubes with no adhesion, the function of the tube should be maintained with the patency, and male TC, total motile sperm count should be 1 to 5 million for them to have a better success rate. If they are having less success, like it is seen in mostly patients who are having more than 35 years of age, less AFC and patent tube with adhesions. HSG, by doing HSG, we can sometimes even identify the peritubular adhesions, which we can see the loculated form. So these patients, we can, even though the tubes are patent, we can think there is some tubo-ovarian abnormality which is inside their body. This also we have to check. And male, total male TMSC is less than 1 million. So when should be the first scan be done? So when do we do the day 2 scan? We call it as a basic scan. Why we call it as a basic scan? Because all the follicles will be between less than 9 mm. Any follicle which is more than 10 mm on day 2, what should we do that? We call them as cyst, or we should treat this patient, or we should postpone this patient to next cycle. So on day 2, you can see this picture where there are so many small follicles, antral follicular count. So when a patient who is having cyst, what do we do? On a day 2, there are 2 types of cysts, as they are inert cyst or active cyst. How to identify them? If you are following the patient in the previous cycle also, you will definitely know whether it is an inert cyst or it is an active cyst. So for the first time the patient is coming and she wants to, like in Vizag, most of the patient will be army patients or Navy. They will want to do treatment only in this month. Next month the husband is not available. What to do for these patients? So we have to have previous history, whether she has taken any treatment in the previous cycle, history of scans in the previous cycle, and go ahead with ovulation induction only when it is inert cyst. How will we know? So for these patients, we can do day 2 estradiol and progesterone. The cutoff what we are supposed to take is less than 70 to 80 picogram per ml of estradiol, less than 1 of progesterone. So for these patients, if the values are met, we can go ahead with ovulation induction in the same cycle. If they are active cyst, definitely you have to postpone the cycle. The ovulation induction don't help in these patients. So what can we do? We can give oral contraceptive pills for this month for 18 to 21 days, and we call the patient for the next month for ovulation induction. In case the patient husband says, I am not there next month, what else you can do? Semen freezing, we can definitely offer to this patient 2 samples, and with that semen freezing, we can go ahead with IUI in the coming next month for this particular patient. So there is a case scenario, a 25-year-old married woman to a 27-year-old man. For past 2 years, they are having regular cycles, patent tubes, and there is normal male factor, semen analysis is normal. So can you offer ovulation induction in her, or should we wait? 2 years of infertility, and it is an unexplained infertility. We have to go for ovulation induction in these particular patients. So most commonly used drug is unexplained infertility. We are targeting at multifollicular development. I would like to go for clomiphene citrate, depending on again age and BMI of the patient. We would like to start 50 milligrams. Or from day 2 to day 7, we are giving 50 milligrams. The follicle again I am checking on day 9 of cycle. There is no dominant follicle. What to do? We have to wait for next month. We convince the patient for gonadotrophins. There is no money. Patient is not agreeing. What to do for this patient? We can increase the dose in the same cycle. That means we have to double the dose of clomiphene citrate. That is 100 mg. We have to give 5 more days, and we again check the scan after 2 days. So in the same cycle, if the dominant follicle is not there, again we can increase the dose to 150 milligrams of clomiphene citrate. We wait for 5 days again. So this is called as stair-step protocol. So what is the difference between a single clomiphene citrate and stair-step protocol? There is no difference between ovulation in this particular patient, and pregnancy rates are similar to a normal protocol. In stair-step protocol, we are only decreasing the time period for ovulation and the pregnancy rate. So we will help the patient to conceive in the same, to get treated in the same particular month. So there are few patients where we call as clomiphene citrate resistance. So what is resistance? We are giving 150 milligrams of clomiphene citrate. 3 months we had given for this patient. She is not responding. She is not ovulating. She is not ovulating means it is clomiphene resistant. If the patient is ovulating and not conceiving after 3 months of clomiphene citrate, that call is as clomiphene citrate failure. So what are the other modalities of treatment for these patients? Definitely gonadotrophins, but if she is not agreeing for gonadotrophins, we have to go for extended clomiphene citrate protocol. So where we give 100 milligrams of clomiphene citrate from day 2 for 10 days of the cycle. So sometimes multifollicular development definitely will happen with this clomiphene citrate. There is one advantage with this in this is you can't see premature LH surge. In all these protocols, because estradiol level is more than 200 for more than 48 hours, you can definitely see LH surge. And we won't be knowing how to talk to the patients. If a patient is coming with ovulation, they'll ask, why didn't you monitor us? So how do we do, what is the advantage of this is, so selective estrogen receptor modulator, it is actually blocking the estrogen receptors in our hypothalamus and pituitary. When receptors are blocked, even the elevated levels of estradiol is not perceived by the hypothalamus pituitary, because of which there won't be any premature LH surge. So you can actually plan for IUI cycle or ovulation induction in this particular patients. So what is the other selective estrogen receptor modulator? That is tamoxifen. We can give to 20 to 40 milligrams per day. The cost of there is only 5 tablets kit. It is around 300. What are the advantages of tamoxifen over clomiphene citrate? It is not having any anti-estrogenic effect on endometrium. So endometrium will be good. And even on the cervical mucus, tamoxifen is not having any anti-estrogenic side effects. So when you compare clomiphene citrate and tamoxifen, what is there? This is a Cochrane review 2016 says there is no difference in clinical pregnancy rate, miscarriage rate or live birth rate when you are using clomiphene citrate or tamoxifen. So both you can use to the patient. So next scenario, 22-year-old girl married to a 30-year-old man. Couple are trying to conceive for the past 2 years. She is having irregular cycles, patent tubes and normal male factor. Her AFC is 12 in one ovary and 14 in one ovary, and AMH is done 8.8 milli-international units per ml. So diagnosis is PCOD. Which ovulation agent is better? Whether you go for clomiphene citrate or you go for letrozole. Definitely letrozole is much better in PCOD patient when compared to clomiphene citrate. Live birth rate is higher with letrozole. So when I was doing my PG around 8 to 9 years back, letrozole was banned. FDA banned letrozole. So the reason for banning letrozole is there are few studies which showed letrozole is causing congenital cardiac malformations in the babies. That's why they banned. So later what happened? After actually letrozole is not causing any malformation. There is a comparable study that how much natural conception patients are having risk. Same percentage of risk is seen in the patient who are using letrozole for ovulation induction. So again, letrozole had become gold standard for treating PCOD patients. Letrozole chances of clinical pregnancy rate will be around 20 to 27%. It causes better endometrium, even the cervical mucus. It has lesser complication because the target is only monofollicular development. Now we have to know what is the mechanism of action. It is definitely aromatase inhibitor. Aromatase inhibitor, it will decrease the estrogen levels in the body. When there is decreased estrogen level, the hypothalamus pituitary negative inhibition is lost. So there is increasing in the FSH and LH hormones from the hypopituitary axis. So, but when the follicle starts developing, when the estradiol start producing around the follicle, it's not the receptor blocks. Unlike clomiphene citrate and tamoxifen, which blocks the receptors, it is only the aromatase inhibition. So the estradiol level will be positive. It causes negative feedback mechanism, and there is decrease in the FSH and LH levels, because of which monofollicular development is seen in this particular patients. So the dose is, so the standard protocol is 2.5 milligrams. We have to give 5 days, and ultrasound will be monitored on day 8 and day 9 of the cycle. Higher ovulation rate and high pregnancy rate is seen, and monofollicular development is much better in letrozole cycle. And again, this is the case scenario. 26-year-old female married to 29-year. Couple are trying to conceive for the past 3 years, irregular cycles. And ovulation induction is done with letrozole for 3 to 4 cycles. There is no dominant follicle for ovulation. And can you give ovulation induction for her with gonadotropin directly? Patient, instead of gonadotropin cycle, we can do letrozole cycle. Extended letrozole cycle can be done. Extended letrozole cycle is same like what I have told about clomiphene citrate cycle. You can use letrozole from day 2 to day 10 of cycle for a period of 10 days. Okay, only at disadvantages, sometimes you will feel decrease in the endometrial thickness, but letrozole will act on the endometrium or in our body. Its T-half is only 48 hours. So after 48 hours, after stopping the letrozole, definitely there is a procedure called ubiquitinization where the receptors are more. So when the estrogen will act on the endometrium, and endometrial thickness will increase in these patients. There is also protocol where you give high dose protocol. High dose protocol can be directly given in patients who are obese. Definitely 2.5 milligrams won't work for them. 7.5 to 10 milligrams for them from day 2 to day 5 of cycle. It is very good enough in the starting on a first cycle itself. No need of waiting for the next cycle. So again, this like letrozole and clomiphene can be given together. So both the mechanism of action act together, will increase the FSH LH in the body. So how should we give this? Clomiphene citrate 100 milligrams and letrozole 5 milligrams from day 2 to day 7 of cycle, that is a 5 days. So in this study, there is increase in the ovulation rate to about 92%. And clinical pregnancy rate to 31% and live birth rate increased to 25%. So are there any adjuvants, or we have to give only ovulation induction agents? Definitely adjuvants have a role in ovulation induction, like metformin, glucocorticoids in ovulation induction, and oral contraceptive pills. I am focusing on mechanism of action because we should know why we are giving also. So metformin, what is causing it? It decreases the glucose levels. By decreasing the glucose levels, it also decreases the fasting insulin. Or these PCOD patients are having hyperinsulinic state. This insulin will decrease sex hormone binding globulin. So when the decrease in the sex hormone binding globulin is there, definitely androgens will increase. So by giving metformin, we are decreasing the insulin and we are increasing the sex hormone binding globulin, and it also reduces androgens in the ovary, and hence it is very, very easy to do ovulation induction. By giving this, we also change from the androgenic environment to estrogenic environment and better ovulation induction. So whether there are studies which shows, even RCOG and SOCG says metformin should be combined with clomiphene resistant patient who are older and having a visceral obesity. That means the patient is BMI more than 30. We need not wait for the patient to be clomiphene resistant and give metformin. We can directly add to this patient who are having visceral obesity and BMI is more than 30. So clomiphene plus dexamethasone. So androgens, actually, when we all know when there is high androgenic environment, the dominant follicle don't develop. So by giving dexamethasone, how do we give this dexamethasone? We start from day 2 of the cycle till day 14 of the cycle we give along with the ovulation induction agents. So how does it act again? So definitely we are giving steroid from outside, CRF will be decreased, and there is increasing in the FSH and LH. That is one factor. When we are giving androgens from outside, it reduces the circulating adrenal androgens, and it also releases the inhibition from aromatase. Release of aromatase inhibition. So that's how the dexamethasone acts. So there is one more adjuvant where patient is continuously having no dominant follicle, anovulation. So these kind of patients will be having increased LH levels if we are doing LH and FSH on the day 2 of cycle. These particular patients will definitely benefit by giving oral contraceptive pills for a period of 2 months, that is followed by ovulation inductions. So when we are giving oral contraceptive pills, because these PCOD patients are only mostly resistant patients. So we have to very be sure the patient the patients are not having any metabolic syndrome components. We have to rule out hypertension, hyperlipidemia, diabetes and obesity, and we have to always ask the history of deep venous thrombosis in these patients when we are giving continuously oral contraceptive pills for a period of 2 months. So coming to gonadotropin in ovulation induction, directly gonadotrophins can be given in a patient who is more than 35 years of age. If the patient is clomiphene resistant or letrozole resistant, hypogonadotrophic hypogonadism patient and unexplained infertility patients. So gonadotrophins, we have to use these gonadotrophins very carefully because of the increased risk of multiple pregnancy and OHSS. Significantly, intense ovarian response monitoring is very much required, and we have to have a proper cancellation criteria so that we will stop the treatment. Disadvantages are it will add cost to the patients. So what are the dilemmas when we are giving gonadotrophins? Again, what is a basic dose to be given? What is whether FSH or HMG to be given, or recombinant or urinary products we should give, or what are the different regimens and dose changes we have to go to direct gonadotrophin patients? So when we are comparing FSH versus HMG, there is no difference in clinical pregnancy rate according to Cochrane 2011. So we can give both FSH and HMG for ovulation induction. FSH or urinary gonadotrophins, there is no difference in clinical pregnancy rate. So either we can use. So the one more thing, when you're using gonadotrophin, there are standard gonadotrophin protocols where we should give daily gonadotrophins or alternate day gonadotrophins. Definitely, when daily gonadotrophins is given instead of alternate day gonadotrophin, there is increase in the clinical pregnancy rate which is observed. So there are different types of protocols like gonadotrophin protocol, step-up protocol, step-down protocol, and sequential step-up and step-down protocol. Most commonly used protocol by all of us is oral ovulation plus gonadotrophin protocol. So in this protocol, we start from day 2 of cycle for 5 days of letrozole or clomiphene citrate. After that, from the next day, we will be giving FSH or HMG from 37.5 to 75 international unit depending on the weight of the patient and her antral follicular count. So we give trigger only when the follicle is around 18 to 20 mm. HCG trigger can be given, and after 36 hours we go for IUI. This is most commonly followed protocol in PCOS. This is a standard step-up protocol. The target of this standard step-up protocol is to find out what is the freezing dose. What do you mean by freezing dose? That's the dose, that means freezing dose is nothing but the FSH threshold for which the follicle started reacting. So we give 75 international units per day. We give it for a period of 7 days. Then you do the scan. In the scan, the dominant follicle, what you should observe is more than 10 mm. If there is no 10 mm dominant follicle, we increase the dose to either we can increase 50% of the dose or you can double the dose. So that you can, on doing scan, we can identify, if not even a single follicle, every follicle is less than 8 mm, you can double the dose. If you are finding any 9 mm follicle which is ready to be crossing the threshold, we can increase only 50% of the dose. That means we are already giving 75, we can increase it to 37.5. And on day 12 also I had seen there is no dominant follicle. We can increase up to 225 international units per day. So when the follicle of more than 10 mm you found, we have to freeze the dose and we have to continue the same dose. So with this protocol, there is high incidence of OHSS which is seen in around 7 to 14% of cases, and multiple pregnancy rate is more. So unless, in this protocol, unless the FSH threshold is crossed, folliculogenesis doesn't begin. So continue to give gonadotrophins till the dominance is achieved. So this is a low dose, chronic low dose protocol. The only target of this protocol is monofollicular development, because we are persistently giving the low dose. We are not going to give 225 like that. We are giving 37.5 or 75 international units. So depending on the patient, the low dose protocol can be tried from 7 to 14 days. Like 7 days you give the same medicine, or sometimes we give, in hypo patients we can at least give this 14 days also to see the dominance. So after this we have to increase the dose by 50 to 100%. Disadvantage is it will longer duration of gonadotrophin. They have to come to the hospital multiple times. The cost of the treatment is more, longer treatment duration. So all these protocols we are mainly targeting at fixing the threshold dose. Once the threshold dose is met in this particular cycle, for example, patient has come in July, we have a target dose has been found. Next time when she is coming, next month in August day 2 when she is coming, we have to start with the particular dose where the freezing has been reached. Standard step-down protocol, it is like there are many disadvantages of this protocol. Directly we are going to target many follicles. We are increasing the FSH threshold of many follicle by giving high dose of gonadotrophins. 225 international units of gonadotrophin we have to give. Like instead of measuring 7 days, it is for controlling the ovulation stimulation. We can call the patient on day 4 of cycle. to see how many follicles are becoming dominant. And for the same, like we have to freeze the dose on particular day where the dominant follicle has been reached. So we have to also monitor in this protocol. Estradiol monitoring also is very good, and serial ultrasound monitoring has to be done so that we avoid multifollicular growth development, and we also decrease the cost to the patient, because we give 225 and we can't say the patient so many follicles have come. So depending on the weight, as I said, the patient should be, we have to choose the patient and we have to choose particular doses this patient so that the chances of cancellation are less. So after all this protocol, which is better, whether you go ovulation induction or you go only gonadotrophins, or you want to mix the protocols with ovulation induction oral agents plus gonadotropin protocol? By giving only oral and agents like clomiphene citrate and letrozole, sometimes we may not be reaching dominant follicles. Patient won't be waiting months together for dominant follicle appear. So combined protocol, we have better clinical pregnancy rate. In letrozole and HMG protocol, the clinical pregnancy rates are 20.5% when compared to clomiphene citrate and HMG protocol, which is only 12%. So cycle cancellation, the target of cycle cancellation should be 15 mm follicle. If it is more than 3 follicle, 15 mm, cancel the protocol. We ask the patient to come next month. And we should always tell them to use contraception when to prevent a multiple pregnancy rate. So the monitoring of the follicular monitoring has to be done depending on the growth of the follicle every 3rd day or every 2nd day. The growth of the follicle is around 1.5 or 1.2 to 2 mm. Depending on that, we call the patient alternate days or 3 days once. And when to trigger this patient? A dominant follicle, clomiphene citrate or gonadotrophins, it is totally different. It will be told later. Endometrial thickness is also important when we are doing ovulation induction and IUI protocols. If the endometrial thickness is less than 7 mm, the clinical pregnancy rate does drop because the implantation will change in this particular patient. So what kind of trigger? You give only urinary HCG or recombinant HCG or recombinant LH, gonadotropin agonist or dual trigger. So most of the times HCG 5000 to 10,000 international units does work. In case patient is not having ovulation or unruptured follicle syndrome is found in this particular patient, we can go for GnRH agonist trigger and dual trigger also. Only disadvantage of GnRH agonist trigger is, what will happen with this trigger? It will cause luteolysis. The corpus luteum has to be maintained for about 14 days for the placenta, for the pregnancy to form, and later the placenta has to take over and start producing the progesterone. This gonadotropin agonist, which causes early luteolysis. When there is early luteolysis, there is no support of progesterone. So when you are giving gonadotropin agonist as a trigger for ovulation induction, we have to supplement progesterone like luteal phase support, either vaginal progesterone or duphaston from outside. Dual trigger is mainly given in patients who are having LU of luteinized unruptured follicle. This can be given 0.1 milligrams of decapeptyl or 0.1 milligrams of buserelin along with HCG 5000 and 10,000 we can add to these patients. Poor endometrial development, we have to keep in our brain not only the follicle, we should always see the endometrium for when we want to go for a better pregnancy rate. So endometrial thickness target is more than 7 mm, less than 7 mm, there are less chances of pregnancy. So if the patient is having less than 7 mm, when to start estradiol valrate, whether we should start from day 2 of cycle or mid of the cycle, we have to start. It is very, very important. You can't start estradiol together on day 2. So as I said, the mechanism of action what we are targeting is increasing in the FSH. So for example, this is letrozole and progenova given on the same day. Like day 2 patient had come, we had given letrozole. We have also started estrabet on the same day. So we are not, the proper mechanism is not happening inside. You are giving letrozole to increase FSH. You are also giving estradiol to decrease the FSH. So letrozole should not be given with progenova together from the day 2. So first you give letrozole, you see the dominant follicle. If the endometrial thickness is less than, your target endometrial thickness is not coming, when the dominant follicle is more than 14 mm, that's when the estrogen should be supplemented, because the threshold of this particular dominant follicle is already met. So this dominant follicle which is already been recruited, it won't decrease in size or it won't slow down. Okay. So once the dominance will happen, the threshold FSH will act on this particular dominant follicle. The estrogen has to be supplemented that time, whether you give estradiol valerate 2 milligrams BD or you can use TID depending on the endometrial thickness. Sildenafil don't have much role. Sildenafil causes giddiness. So if we want to give sildenafil 25 milligrams per day, we can give vaginal sildenafil so that the patient won't have any giddiness. So thin ET does decrease, it's the follicle what I spoke only. So if, as I told already, if you are using letrozole, wait for 48 hours for the endometrial thickness to increase. Coming to the success success rate, whether you give clomiphene IUI, there are 8 to 10% of the success rate. We are giving letrozole with IUI 10 to 12%, and clomiphene citrate with HMG 10 to 14%. If you are using only gonadotropin with IUI, the success rate is definitely more when compared to the previous 3. But definitely it will be associated with multiple pregnancy rate and OHSS rate as well. So we should only choose the protocol for our patients. Thank you, everyone.
Thank you, Kavya, for the elaborate, extensive ovulation induction. It made my head go round and round. Because I'm basically an obstetrician, more interested in obstetrics than inducing pregnancy. At the most, I treat the patients with clomiphene citrate and letrozole. If they don't conceive within 3 to 6 months, I'll send them away. I'm a marshal of population control.
Oh.
Okay, thank you.
Okay.
I have a question, Kavya.
Yes, ma'am.
We are not able to keep up with your speed. And another one is, clomiphene citrate has anti-estrogenic effect on endometrium and cervical mucus.
Yes.
Previously, we used to give estrogen for that. Now, are you giving routinely tamoxifen with clomiphene citrate?
No, madam, no need of giving tamoxifen.
For an anti-estrogenic effect, anything you are giving?
Madam, we are giving clomiphene only for 5 days. Okay.
Tamoxifen you mentioned, no, that you are giving along with clomiphene or separately?
Separately. Tamoxifen given separately. No need of clubbing with clomiphene citrate.
And follicular study, I thought we will be doing only during 10th to 16th day. Day 2 follicular study, is it necessary for all patients?
Yes, day 2 is must and should for all the patients, because if you don't evaluate the patient on day 2, you don't even know the ovulation induction is going to work or not. If already cyst is there on day 2, on day 10 or day 14 she is coming, we will think it is a dominant follicle and we will give ovulation. And most of the time ovulation scans also we won't do. We will ask the patient if ovulation will happen, we will send the patient. So ovulation scan is also must to at least to ourselves and patient also. We have to know whether she is ovulating or not.
Thank you.
Yeah, I think about GCSF and luteal unruptured syndrome we are covering detailing in the panel discussion. But since Madam has raised the point as well, most of the studies when endometrium is thin, we always feel something we have to do because we can't go ahead with the thin endometrium. All the studies, if you say, there is nothing significantly which can increase the endometrium.
As she told, estrogen has a role after the follicle has become dominant. Once the follicle has ideally what exactly happens is, if you go in a deeper way, if a follicle is secreting 250 picograms of estrogen, compulsory endometrium should be 7 mm, ideally. That much of estrogen, normally, forget about giving any medication, in natural folliculogenesis also, follicle which is 18 mm has 250 picograms of estrogen secreted. This estrogen is good enough for the endometrium to catch up for 7 mm. So, in a way, if you want to see who is the culprit, is it the follicle or the endometrium? This is one single test. Most of the time, I am not a fan of doing more tests. But before putting a woman to hysteroscopy, thinking about any intrinsic factor of endometrium, this one single test will tell us. Because what she's told was day 2 scan, I can understand as a gynecological perspective when you're so busy, patient comes on day 5, we start. But ideally what can happen is on day 2, there is already a cyst sitting there, which is secreting hormones. It may be 14-15 mm. We start medication, we don't do scan. She comes on 8th day or 9th day. We see that follicle which was already on day 2. And we get confused. We think, okay, this follicle is, it is dominant and we give gonadotropins. Again, this follicle is very culprit. It even grows actually. It becomes 18 mm. But it doesn't have a receptor. FSH receptor, LH receptor is not there because on day 2 itself it's a cyst. So any follicle which has LH receptors only can trigger. If you give HCG, this doesn't ovulate. Then what do we think? It will become a follicle unruptured syndrome, we call it as. So ideally, if there is a luxury of scan, doing day 2 scan is good. You can rule out many things because as she said, every cycle it's a new cycle. cyst can come anytime. This happens especially in a POR. You know, lady with very few follicles, you see on day 2 already there is a recruitment. So, having said and done, aspirin, ecosprin, there are all roles for estrogen. About GCSF, when we see many studies, some of the latest studies support role of GCSF for endometrial thickness as well. So, if we have tried everything and if it has failed, before going for a hysteroscopy, we can try a method doing a GCSF and also doing an estrogen level, just to see where we are. What about the aspirin? Yeah. Madam, once endometrium, because these are all cost-effective treatments. What is there? Why don't you give aspirin? Give aspirin. We do give aspirin if there is endometrium.
Sometimes
it helps. Yeah, definitely. It's a vasodilator and it gets increases the circulation as well.
Can you tell us protocol in PCOD, induction of ovulation, in PCOD, severe PCOD?
Severe PCOD, first, if patient, I have to see the history, whether she is coming first time to me or previously she is already been treated somewhere, what is the age of the patient. So for the first time she is coming, I'll definitely put her directly on ovulation induction. I would like to do, sir, I won't do 2.5. Seeing the patient, I'll go for 5 milligrams to 7.5.
Next speaker is Kirti.
So after ovulation induction, I am presenting how to optimize our IUI outcomes. So what is IUI? IUI is very basic procedure performed in the field of infertility. So there are 3 unique qualities about IUI. It's a very easy procedure. It can be easily performed by gynecologists. And affordability. IUI saves the cost. It is almost 3 to 4 times lesser costlier than the IVF. And it can be easily affordable by the patients. And with good success rate, mainly in cases of mild to moderate endometriosis and unexplained infertility, compared to the expected management, IUI will give good results. So basically what is IUI is, it is direct transfer of the processed semen into the uterine cavity around the time of ovulation to increase the sperm density. So how IUI works? We are basically bypassing the cervix, better quality and more number of sperms are entering into the uterine cavity, and we are deliberately doing the IUI around the time of ovulation. So then semen washing, it will remove the detrimental contents like WBC and dead sperms. So if we perform all these steps correctly, then we can optimize our IUI results. First thing is the pre-treatment workup, then proper couple selection, then ovulation induction protocol, then careful monitoring of the follicular growth and endometrial development, then trigger, then comes sperm preparation, insemination and luteal phase support. So first coming to the history, in the pre-treatment workup, the basic investigation what we have to do is the ultrasound in the female. So we have to check her ovarian reserve. So if we are doing IUI for a younger patient is different and for older patient it is different. So we have to check her ovarian reserve. Then ovarian reserve test like AMH, and for our success of the IUI tube should be patent. Then the semen analysis, the count should be at least 10 million on thyroid and prolactin. So in a female, ideally it should be less than 40 years. She is capable of spontaneous or induced ovulation. At least one fallopian tube should be patent, and then total sperm count should be 10 million with 30% of motility, or in the post-wash 3 to 5 million with 40% of motility, and there should be easy access into the uterine cavity with a negotiable cervical canal. So proper couple selection is important for success of the IUI. So in the male factor, males with ejaculatory dysfunction, erectile dysfunction and mild oligoasthenoteratozoospermia, that is around 10 million count, and if we are going for a donor insemination like azoospermia, or if the husband is not available, we will cryopreserve the semen and later will do IUI. And in the female factor like hostile cervical mucus, vaginismus or anovulatory cycles like PCOD. So, and after that mild to moderate endometriosis and unexplained infertility. So, in these two cases, so better to do ovulation induction with IUI rather than expected management. Treating younger women with good ovarian reserve with patent tubes, it has good success rate. In older women with less AFC and patent tubes with adhesions, it has less success rate. So then if we are treating anovulatory disorders like PCO and male infertility or the unexplained infertility, IUI gives better success rate than if we are treating a patient of poor ovarian reserve, because in poor ovarian reserve, because of the poor oocyte quality, the success rate in IUI is only 8%. So these are the contraindications. We should not do IUI in these cases, like if there is active infection, cervicitis, cervical stenosis, blocked fallopian tubes, or the semen parameters are very much less, or in cases of stage 3, stage 4 endometriosis, poor ovarian reserve, age more than 40 years, in all these cases it's not like we should not do IUI. So if we do IUI in these cases, because of the poor oocyte quality, the success rate of IUI is very much less. Then in male factor, like if the count is less than 5 million with morphology less than 2.5% and the motility less than 10%, that is in cases of severe male factor, will directly go for IUI, will directly go for IVF rather than IUI. Then coming to the counseling part. Counseling is very, very important in the treatment part. It also should be individualized. Why we are doing IUI procedure, what is the success rate, what is the cost and the complications, everything we have to explain. Like if you take a PCO patient, first thing what we have to tell her is, we don't know your ovarian response. In PCOD patients, sometimes the ovulation may not occur. In sometimes they may be delayed ovulation. So the daily patient has to come to the hospital, daily she has to take injection. So the cost of the IUI will be increased. And after that, the risk of OHSS, multiple pregnancies, everything we have to explain in the counseling part. So this part has been already been covered. Then coming to the ultrasound monitoring. So ultrasound along with Doppler, if we use, we can increase our IUI success rates. So what is the importance of day 2? On day 2, we will see antral follicle count, we will rule out any cyst, and we see the endometrium, and we rule out any pelvic pathology. Then follicular size, how we measure is, we will take the mean of the 2 largest perpendicular diameters in each follicle. Then we start the ovulation induction. On day 7 or day 8, again we will see the scan for dominant follicle. In case if we are using gonadotropin cycles, then we start from 6th day onwards. So these are B mode features of the mature follicle. A mature follicle is 16 to 18 mm in size, which has thin walls, regular round in shape, and it has no echogenicity in the lumen. A thin hypoechoic rim can be seen. Usually it develops 36 hours before the rupture. So these are the pre-trigger parameters. So follicle shows ideally 3/4 of the blood vessels covering at least 3/4 of the follicular circumference. The RH is 0.4 and the peak systolic velocity is greater than 10 centimeters per second. And ideally endometrium should grow up to 8 to 10 mm in thickness with vascularity in the zone 3 and zone 4, that is in the inner layers of the endometrium. And the resistance index is less than 0.5. So on ultrasound, if we see the dominant follicle of 18 to 20 mm with the endometrial thickness of more than 8 mm, we administer the trigger. So with pregnancy rates with 3 follicles is 37%, with 2 follicles is 26%, and more with 1 follicle is 7.6%. Beyond 3 follicles, there is no substantial increase in the success rate, and we rather cancel the cycle. So this is the study showing optimal lead follicle size for HCG trigger in CC cycles. So HCG administration at a lead follicle size of 21 to 20 m is associated with higher chances of pregnancy, and in gonadotropin cycles it is 18 to 20 mm. Then coming to how we detect the ovulation. There is sudden collapse of the pre-ovulatory follicle, increasing the PODs, increase in the fluid in the POD, then luteinization. Then coming to the what is the timing of the IUI. There are 2 things that we have to remember. One is the sperm may remain viable for a period of 48 to 72 hours, and oocyte may remain capable of fertilization only up to 48 hours. So if we are going for a natural cycle IUI, we can perform IUI after 24 hours after the LH kit tested positive. Then in stimulated cycles, these are the ESHRE guidelines 2018 showing if a HCG injection is used, we can perform single IUI anytime between 24 to 40 hours. Then coming to the lab part. So proper semen collection is important for IUI success rate. Coming to the prerequisites. So at least 2 to 5 days optionals should be there. Laboratory collection is ideal. Then there should be no spillage of the sample, and we should not use any soap or lubricants. Then semen collection to the IUI interval. From semen collection to the sperm wash is maximum 30 minutes. And from sperm wash to the IUI, ideally immediately we have to do IUI. So from the semen collection to the IUI time is maximum 90 minutes. So these are the semen preparation methods. One is the sperm wash, sperm up and density gradient method. So among them, what we have to remember is the choice of semen preparation technique, it is based on the nature of the semen sample. So if you have a normospermic patient, you can use either swim up or density gradient. But if the patient is oligoasthenoteratospermia, you can use only density gradient. So although density gradient showed to be superior to wash technique or the swim up technique, there is insufficient evidence to recommend any specific method when we are speaking in terms of clinical outcomes after IUI. So the volume of the sample to be loaded is the 0.3 ml. If we inseminate more than this volume, it would lead to reflex of the sample from the uterus. So ideal volume of the inseminate would be 0.3 ml. And before IUI only, we have to note the position of the uterus. Uterocervical length and angle must be observed. In cases of acutely anteverted uterus, what we have to do is a partial filling of the bladder because it will correct the uterocervical angle. Then coming to the one of the important aspect of IUI is technique of the IUI. So for IUI success, so for a simple IUI, what we need is the cusco-speculum, powder-free surgical gloves, sterile syringe, Alice forceps, gauze pieces, sponge holder, saline and IUI cannula. So first we put the patient in the dorsal lithotomy position. We should not use any antiseptic solutions. We introduce the cusco-speculum. We clean the cervix and vagina with the saline cotton swabs. Then the cervical mucus is removed with the cotton swabs. Then as gently as possible, we will introduce the IUI cannula just beyond the internal os and slowly and steadily we will push the inseminate for a period of 1 minute. And we will stay there. We should not touch the fundus and we have to slowly and steadily remove the cannula. So is ultrasound needed? Routine use of ultrasound in IUI is not recommended. But if it is a difficult IUI, we can use ultrasound. So in cases of a difficult IUI, be patient and then we have to use Alice forceps just to pull the cervix gently, and if the bladder is empty, we have to fill the bladder. And if we want, we can take ultrasound guidance, and then we can use with if we are not able to enter into the uterine cavity, we can go for a intracervical insemination. Then what is the role of single IUI or double IUI? So these are the ESHRE 2018 guidelines. Women undergoing IUI should be offered a single insemination per cycle. There is no role of double IUI even in cases of unexplained infertility or the male infertility. Then what is the role of bed rest after IUI? Women undergoing IUI should have at least 10 to 15 minutes of bed rest after insemination. Then how many IUI cycles? In couples with an indication of IUI, at least 3 consecutive IUI cycles should be performed. After 3 cycles, there is no substantial increase in the pregnancy rates, but there is insufficient evidence also to recommend maximum number of IUI cycles. Then there is no difference between soft catheter or rigid catheter. And then our cycle cancellation criteria. So if there are more than 3 follicles of 16 mm in size or more than 5 follicles of 12 mm in size or the estradiol level of more than 1500 picogram per ml are present, we should cancel the cycle to reduce the multiple pregnancy rates and the OHSS risk. So post IUI, the role of intercourse. Patients, we advise the patient to have the intercourse after IUI if they want to. If the patients, if they feel pelvic discomfort due to ovarian enlargement from clomiphene or gonadotropins, we'll tell to avoid the intercourse. Then role of luteal phase support. So particularly if we are using gonadotropin cycles for IUI, we should use progesterone in the form of vaginal progesterone or vodal dydrogesterone or vaginal gels. All are equally effective. So finally, IUI can be considered to be cost effective and a non-invasive first-line fertility enhancing technique with fairly acceptable pregnancy rates. So stringent patient selection criteria and tailor-made stimulation protocols with a sound semen preparation techniques all will form the main pillars for the successful outcomes in IUI. Thank you.
Very excellent. Very nice talk, IUI.
It will induce contractions, ma'am. Basically what we'll do, we have to see the uterocervical angle, ma'am. If there is acute angulation, we'll partially fill the bladder, or under ultrasound guidance we have to manipulate.
Swim up or
If the sample is based on the nature of the sample, ma'am. If it is an Armaju's permic sample, we can use either swim up or density gradient we can use. If it is oligoacinoteratojuice permia, better to use density gradient, ma'am, because it is based on density of the sample.
Okay, very good.
When we cannot enter the uterine cavity with this sound, sometimes the patient may bleed. What to do? You are saying just cervical insemination. Is it a failure or just proceed like that?
Yes, ma'am, we can do intracervical insemination.
Yeah. So what ideally is this can happen practically. It's very true. We are ready. We have got the sperm. We have got the follicle, endometrium. We have got. But when difficult entry slides, I have it in my panel as well. But for completion, first thing is if you are using a cusco speculum, just smooth the speculum, and ideally you loosen the speculum. Ask the patient to cough. What happens is cervix comes exactly and stands in the center. You know, because of too much of expansion of the speculum also, the deviation, cervico-uterine axis get deviated. Make it a normal way, like just loosen the cuspo-speculum and ask her to cough. It comes back and stands in the normal linear position. Even after maneuvering the cuscos, if it doesn't work, if you are going with a syn speculum, what you can do is, in our center we have a ET catheter, embryo transfer catheter, which is a stiff catheter. We have that luxury because we do a lot of embryo transfer. So if it fails, we put a little stiffer catheter and try to transfer. That is the second thing what we do. Third thing, even with that, if it doesn't, we don't try to manipulate too much and cause a blood feed. We try and avoid that. So better than that is, next with the syn speculum, if it is a anteverted uterus, gently anterior lip of the cervix, you hold a little pull, so it straightens once the bladder is full. If it is a retroverted uterus, use the posterior lip of the cervix. Little if you pull again, you get the linear way. So even this fails, then last, pray to God, just do intracervical. You know now. And remember and make a note in your case sheet so that in next time we should not encounter the similar situation. So next time when she comes doing a thorough examination for her, what is the reason for cervical stenosis? Simply it won't happen. There should be a valid reason. Most of the time in our country it's infection. So rule out infection, do a day 2, call her on day 2, because day 2 normally it expands because of the menstrual fluid. If it is open on day 2, it's still okay, make a note of it. Even on day 2, if it's stenosed, then you will have to do a cervical dilatation for her. Go back to add a value to this, go back and see her case sheet. If she had a thin endometrium, stenosis with thin endometrium is something where there is cervical infection which has gone inside the uterus and it's caused endometritis as well. So your both cervix and endometrium having issue. So instead of doing just day 2 dilatation, put her in hysteroscopy itself. So this is the way we learn from each patient.
Even the HSG will give some.
HSG was done because IUI most of the time we do a tubal evaluation. If they have told it is HSG is patent, most of the time we won't encounter such situation.
Immediately after IUI, we can start the progesterone.
The day itself. Usually we do IUI at 38 to 40 hours after the rupture, so we start progesterone.
Thank you, dear chairperson. So we move on to the next session. So next I invite Dr. Savita Vandana Garu. Madam is Professor of OBG in Andhra Medical College, Vizag, working also as Senior OBG Consultant in Medicover Women and Child Hospital, Vizag. Good evening, everybody. It's my privilege to introduce Ferty9 consultant for the next talk. Dr. Shravya Kallapureddy. She is a Senior Fertility Consultant, Ferty9 Fertility Center, Secondary. She has done FNP Reproductive Medicine, Milan, Bangalore, MS OBG Government Medical College, Vijayawada, and MBBS from Osmania Medical College, Hyderabad. She is an academic in charge in IMA, short-term and fellowship courses Ferty9, member of ISAR, IFS and POXI. Dr. Purnima Nandakarni Best Paper Award she received it.
For the kind introduction. So after a exciting session on ovulation induction and optimizing IUI outcomes, we come to a relatively boring topic. Probably all of us feel that law, okay, we are doctors. What do we need to learn much about law? We just need something to learn, guide our practice, that's it, right? So, but with the current era of medical litigation, law has somehow become an indispensable part of our practice, especially fertility practice. So let us look at law. Basically, infertility has become a global burden. So India alone, there are around 27 to 28 million couples affected with fertility issues. So this law took some time in our country. We have been struggling over this to regularize our practice for the past 20 years, almost 2 decades. So 2-decade-long effort became fruitful in 2021 when the government could finally bring out an ART Act. So we started from ICMR guidelines in 2005. We finally moved on to an ART Act. It is an act which regulates our practice. So what is the difference between a guideline and a law? Guidelines are just as earlier told that they are there to refine our practice, to regulate our practice. But law is different. If we don't follow law, we are punishable for the offense. So law, what are the things? I think post-COVID, many sessions would have been planned and you would have heard many sessions on this ART Act, Surrogacy Act. So we'll simplify it, we'll break it down. So government has released 4 notifications. So one was the first ART Act. It was in 20th December 2021. This act, what does it tell? It tells us about what are the rules, in general, how our practice should be. And then they released Surrogacy Regulation Act on 25th December, 1 week later. So then to guide this act, they released rules, that is regarding the consent forms, regarding certain rules for our practice. The rules were released in 7th June 2022 for ART and surrogacy rules on 21st June. So we will understand law based on few case scenarios. So here's our first case scenario. Mrs. X, she is 25-year-old, married to Mr. Y, 27 years old, and couple are trying for the past 2 years. So she is diagnosed with PCOS. So she has polycystic ovaries, she has anovulatory cycles. Now we are planning ovulation induction for her. So all of us have a doubt in our mind. Does our clinic require ART registration? So what does the law say? So law says that ART clinics should be registered, but the clinics where you process the gametes, either the sperm or the oocyte outside the body. So it is either an IUI or an IVF procedure, or you transfer the gametes or the embryo back into the human body. So that is again a clinic where you do IUI or IVF. So for plain ovulation induction, you do not need any registration. So from this case, we just understand that for plain ovulation induction, you need not have any level of registration. So if you are planning an IUI or an IVF, you definitely need registration. So any technology which uses the procedure of handling gametes outside the body or transferring gametes outside the body is coming under ART. So what are the authorities that regulate ART? So we have a national ART board, state ART board, and also national ART and surrogacy registry, and also appropriate authority. So how do we register for our clinics? So all of us know that we have to register. So how do we register? So we have a website called artsurrogacy.gov.in. So you just have to go to the website. There is an application form. You download it, apply online, and also submit a hard copy to your local ART board. So once you submit an application, they will come for inspection, on-site inspection. So your application should be accompanied by a fee. So for a level 1 clinic, you will be paying a 50,000 fee. For a level 2 clinic, you will be paying 2 lakhs fee. And this application, once submitted, the ART board will approach your clinic for inspection. Once you pass through the inspection, you will be given a registration. This registration comes in the form of a Form 3. So this registration is valid for a duration of 5 years. So, and this registration should be displayed in your clinic in a visible area. Now let us look at another case scenario. So we have a lady who is a known case of PCOS. She was given drugs, ovulation induction, which we have discussed earlier. Gonadotropins were given. She unfortunately hyperstimulated. But we plan to convert it into an IVF cycle, and the doctor also has an IVF setup, but he has only level 1 registration. So can we do IVF for this patient? So to understand this scenario, we need to understand what are the levels of ART clinics. So there are 2 levels of ART clinics mentioned in the law. One is level 1 clinic where you can do only IUI. Level 2 clinic where you can handle gametes outside the body, that is you surgically retrieve oocytes or sperms and handle oocyte outside the body, do IVF, embryo transfer, and also cryopreserve the gametes. So in level 1 clinic, you can do only a plain IUI. For level 2, to simplify, you can do an IVF procedure. So what are the minimum requirements or mandatory staff requirements for a level 1 clinic? Mandatory staff requirements for level 1 clinic is 1 minimum gynecologist who has a postgraduate degree or diploma in gynecology and obstetrics, and minimum equipment are also simple, only 3. That is equipment essentially for your sperm preparation, that is microscope, centrifuge, and a refrigerator. So then what about level 2 clinics? Level 2 clinics, you have to have a multidisciplinary team, that is a gynecologist, andrologist, embryologist, counselor, anesthetist, and a director. So I would not go much into the level 2 clinics. Let's move on to another case study. Here we have a couple, 40-year-old lady and a 56-year-old gentleman. They approach you for fertility treatment. So they quote regarding a 70-year-old lady who delivered a few years back. So what do you say? Can you treat the couple? So what are the age limits as per the current ART Act? Now it is not a bill, it is an act. So according to the act, a woman between 21 to 50 years and a man between 21 to 55 years can avail ART services. So someone younger or someone older, we cannot offer ART services to them. So what are the duties of our ART clinics or banks? So we need to understand that for ART clinics, 1, we should have a facility to provide professional counseling. We should maintain confidentiality, maintain grievance cell. Actually, grievance cell has been specifically mentioned in the current ART Act, where you should show a grievance cell and also provide services to the age mentioned. And one final thing is you should be able to issue a discharge certificate. Most of us do procedures, but somehow we fail to give a discharge certificate. Discharge certificate has been made mandatory according to the current ART Act. Moving on to another case study. So here we have a couple, both O positive blood group. They took treatment at your clinic 5 years ago. You did an IUI, husband's sperm. She conceived. They are very happy. 5 years later, the child got into an accident. They needed O negative group. Suddenly, the couple were worried. They put a case on you, asking, and the immediate thing, if a case comes up against you, the government or the authorities request for the case history. So what are the regulations with respect to maintenance of the records? So record maintenance, you should be able to maintain the records regarding all the cases that you deal with for a duration of 10 years. The record should be related to the enrollment of couple, donors, procedure undertaken, outcome, complications. Because soon a national registry would be coming into place and we should be able to upload all the details of the case. And also if the clinic stops functioning before 10 years, we should be submitting all the records to a national database before closing of the clinic. So record maintenance is very important. Most of the times patient comes and asks, why don't you give back our files to us? So we often tell the patients that we are maintaining 2 records, 1 record to the patient, 1 for the clinic. So our clinic, the file which is there in the clinic should be maintained because this is according to the ART Act. The file given to the patient is another copy which is given to the patient. And when we are running an ART clinic, we should be able to give, for that matter, any clinic, it need not be ART, any procedure that we do, we should be able to give clear, transparent information to the patient regarding what is the procedure that you are doing, what is the success rate, what are the limitations, complications, charges, side effects, and what are the rights of the unborn child. So information and also consents and documentation is very important because consent should be informed and written consent in a language understandable to the couple. And each consent should have these 4 things. 1, what is the procedure being undertaken? What are the alternate procedures available? What are the risks of the procedure? What are the complications? What is the success rates? And when we are talking about level 1 IUI clinics, what are the consents that we need to maintain are these two. I think they are not clearly visible, but you need to understand two forms, Form 7, Form 8. So according to the ART Act, you need to maintain these two forms. For IUI with husband sperm, we need to take consent in Form 7. And for IUI with donor sperm, you need to take consent on Form 8 and maintain these records in your case files. Let us look at another case scenario. Mrs. Sonu, she is para 2 life 2, 2 previous LSCS with both female children. They approach your ART clinic, desire to get a male child. So she argues that all the celebrities have male child to ART, why not for me? What do you say? See, ART Act is, all the ART clinics are subject to provisions of PCPNDT. So sex selective ART is prohibited by the ART Act. So, and it is punishable with a serious crime like 5 to 10 years imprisonment or 10 to 25 lakhs fine. So sex selective ART is prohibited. Little off the topic, we'll be looking at third party reproduction. So we have a case scenario wherein Miss Ria, she is 21-year-old. She wants to donate eggs to her sister because her sister has premature ovarian failure. So Ria is unmarried, she wants to donate eggs before marriage and ready to sign any documentation to avoid legal implications. So what do you say? Can you take her as an oocyte donor? What you need to understand is, earlier ART, before the ART Act, earlier ICMR guidelines have maintained that we should have an anonymous clause. But now that anonymous clause has been removed. But sadly, in this case, still we cannot take because the age limit for a female donor of oocyte is 23 to 35 years. For male, it is 21 to 55 years. And it is one gamete to one couple. So either you take one sperm donor and one couple, or one oocyte donor, one couple. So it is 1-to-1 to avoid any genetic transmission of diseases. And these donors should be registered through an ART bank. So oocyte donor also, they can donate only once in a lifetime, and we can take only 7 eggs, up to 7 oocytes in her lifetime. So now moving on to the another case, we have Sonia and Rakesh, married for 5 years. She has primary ovarian insufficiency and also Mullerian agenesis. To simplify, there are no oocytes, there is no uterus. So what do you advise? Normally, we have heard about surrogacy, womb on rent. So the government has brought up a surrogacy act. So what does the surrogacy act? Is surrogacy banned in our country right now? No, surrogacy is not banned, but it has been made altruistic. That is, you can do surrogacy for only couples with proper eligibility criteria. So what are the eligibility criteria? One, they should be an Indian citizen. Married for at least 5 years clause has been removed right now. So women between 23 to 50 years, husband between 26 to 55 years, and they should not have any surviving child, whether adopted, whether through earlier surrogacy, or except they could have a child who has life-threatening disease. And the couple also should take a certificate of essentiality. That is, they should have a proven cause of infertility wherein she cannot conceive on her own, through her own uterus. And the insurance coverage for the surrogate and all the clauses related to the court procedures have been mentioned. And what are the requirements for a surrogate mother? Surrogate mother, again, as we told, altruistic. That is, known willing woman, a married woman with a child of her own, and the women between 25 to 35 years of age, and the women should also get a certificate of medical and psychological fitness. So essentially, a couple requiring surrogacy will probably require 4 documents from the government. One, certificate of essentiality, certificate of eligibility for the couple, and similarly certificate of eligibility for the surrogate mother, and also for the transfer of gametes. So apart from that, the government brought in a new legislation on March 14th. The Surrogacy Act was given on 25th December 2021, but recently, just March 14, 2023, government brought a new legislation that for a surrogate, both the gametes, that is the egg and the sperm, should be from the parents. So in this case where we have discussed, the woman has no eggs and no uterus. Ideally, earlier, for people who wanted, we used to do with a donor egg, husband sperm and a surrogate, but now we cannot do it. So in case you have to do with, for a surrogacy, the egg and sperm both should be from the own couple. So right now many couples have approached the judiciary, Indian judiciary, regarding this problem, and we have no solution in the near future. Probably few years down the line, we might come up with a solution. But as of now, yes, we can do only surrogacy for a couple whose own egg and sperm can be used. So now that we have understood the law, see, the law has been dealt with in multiple portions. One, what are the registrations, what are the legal responsibilities of the clinic, what are the rights of the patients. Then we should also understand what are the offenses and penalties. For the first contravention, the fine is 5 to 10 lakhs. For the subsequent contravention, the fine and also imprisonment clause is there. So I would end my talk with saying from Plato, who says that laws are no use because good people do not need laws and bad people will find a way around laws. So we should be true to our own conscience and take the right decision. Thank you.
In different case scenarios, and this law of the earth is very important, and ignorance of law cannot be an excuse. All should know. And I have a question. Some people may be running into all of our doing infertility practice. Sometimes we send the patient to the IVF center advanced infertility clinic to get the IUI sample. We send the husband to get the processed IUI sample so that we can give IUI in our clinic. Is it acceptable?
Sir, in the current law, it is not acceptable. Also, it is ideal that probably you can send the patient to the center and you only go and do at the center, because record should be maintained, and as far as the processing of the semen sample and regarding the records, it will be easier if it is done at the center.
Okay.
And clinically also it is ideal to do it at the center, because for the success rate, the semen preparation time to insemination time should be less. Ideally, once the sample is ready, we should inseminate less than 20 minutes. Otherwise, the motility is lost.
Yes, yes.
So, for both purposes, it is practical to do it at that center.
So legally, you should better go there and do it, or ask them to do it.
Yes.
Thank you.
Premature ovarian failure with Turner's, she can go with donor oocyte.
Turner's, like if, let's say she has, there is no problem with pregnancy. Let's say some Turners have cardiac problems wherein we cannot advise pregnancy in their own. Then adoption is the only thing. No surrogacy. If they have some amount reserve left, partial Turners, we can try their own eggs. But or if she is a Turner's but only ovarian failure, but the uterus is normal. Let's say many of the times with women with POI, we see small uterus, hypoplastic uterus. It is because their uterus has not been primed. So if we give 2 to 3 cycles HRT, we will understand whether their uterus has the capacity to grow or not. So after HRT, if her uterus responds, we can try donor oocyte, husband sperm in her own uterus. Donor oocytes in the couple's own uterus.
Yeah, that is allowed.
Donor oocytes is allowed because there are a lot of women with premature ovarian insufficiency, premature ovarian failure and poor reserve.
Yeah, exactly, madam. What you are all asking is, we do have a lot of patients. We have 15 patients who don't have oocytes and who don't have uterus. So they come and sit and they have waited for almost 5 years, because for 5 years we never took up their case. Surrogacy was grey then. But after this law, they are very clear that oocyte and it should be both the parents for the surrogacy. But we are encouraging these couples to put a strong, take an advocate and fight for it. And our government is also sensible. Like initially when they started the law, there were some grey areas. You have to pick up only 7 eggs. It is something which was there before as a guidelines we used to follow. But in law, they have taken that. But what is law? Law can't include all physiological ethical practices. It is a law which says, if you don't do, I'll punish you. It doesn't mean that you anonymous is not there, I will start doing whatever I want. We should have some ethical code of practice. Ideally, in our practice, we don't encourage known donors. She wants her sister to go and give gametes, because in longer run, the mother is seeing the child and she feels it's my own. So ideally, laws are there where we have to stick to some rules. But just because they have taken some things out, it's not like that is the way of practice forward. We have to strike a balance between ethics. Law is we have to follow it. There is no second go. Right now about, she can do that. Delivery, there is no way where they, only law has made the transfer of gamete from, say suppose my center, the patient wants to go to another center next door. I have to go to state board, put an application, I have to transfer her gametes. So that strict they have made about transfer of gametes now.
Thank you, Dr. Jyothi, for alerting all our regular gynecologists who are doing basic infertility practice. We don't know all these ART laws and all. Thank you.
In reproductive medicine, sometimes there is no one perfect solution. Linking theory and practice, we move on to our next session for the day, a panel discussion on case-based scenarios in fertility practice, to be moderated by Dr. Jyothi.
A very good afternoon. I know post-lunch you're all here, but I won't be going very elaborate on the panel discussion because most of the point have been covered from the previous speakers. So we'll make it a rapid fire panel session, only quick take home message. So to do the panel, I'll be moderating. So I have my four wonderful doctors as panelists. We can make it more interactive. So this is first case scenario. This is a lady. She is 36-year-old. This is regular day in and out what happens in our gynecopedy. She is married for 2 years. She is wanting to become mother since 1 year. Everything is fine. Her cycles are regular. Only problem is husband is not there with her. He is a frequent traveler. Now she is like, I'm already 36 years, 2 years married since. What do I do now? So if this, I think, common case, right? In everywhere you get, especially sometimes they say my husband is in Dubai, he comes only for a month. And then again he goes back for 2 years. What do? We do come across such conditions. So I will ask my panelist here, what are the first investigation, what you advise for her? And what do you counsel for her? So we'll start with Dr. Kavya. So she is keeping in mind her age. Most significant is she is 36 years. Other than that, everything is fine.
She is 36-year-old, ma'am, and husband is also not staying far. First, I would like to evaluate her ovarian reserve and tubal patency. And only if her ovarian reserve is good and male factor evaluation is also normal, only 1 year of married for 2 years, trying since only 1 year, I would like to directly go for IUI. In case her reserve is, if I find any decreased ovarian reserve or anything, any problem with male factor, and I would directly counsel for ICSI.
Okay. So now Dr. Kavya has brought a very significant point. 36 years old, husband is not there. He comes only like ovulation, rupture is there. You call him, he's there. So now, any other panelist, do you differ this opinion, or you are agree with this opinion?
I would mostly go for an IUI itself because I understand that they're probably not having regular intercourse.
Okay.
So just doing an IUI probably could help her. So I'll do an AMH definitely, but tubal patency and go ahead with an IUI.
So anybody in the delegates who are differing this opinion?
They can freeze the sperm in case.
Sir has gone to another level. Definitely, sir, we'll take your advice. It's a part of it. Yeah. So now, anybody, people coming from far, they just want to become pregnant, and increasing of fecundity. Natural pregnancy is possible, but fecundity at 36 is lesser compared to younger age. So I agree with my panelists. So we are planning for IUI for her because she is 36. End of the day, she has to give a child of her own genetic materials, very important. Now we started preparation. She has come on day 2. We have done a scan and then we have started stimulation. So now directly I have called her on. We have a dominant follicle is there now, 18 mm, very beautiful, 12th, it's almost 12th day, nice 18 mm follicle, and I have told I am triggering now, make sure your husband is there 36 hours from here. So trigger is taken. Now she comes back on the day of IUI with her husband, she is here ready. I do a scan, the follicle is still there. It's not ruptured. So what do I do now? The follicle is not ruptured. So Dr. Suma, what do you do at this particular time?
Yeah, so ideally, it's not a definitive cutoff that the follicle has to rupture at 36 hours. It's not a hard and fast rule. There are studies which shows that the follicle can rupture even at 48 hours. So checking at 36 hours and labeling the patient as unruptured follicle is not correct. Repeating the trigger has no value. So the studies have shown that by repeating the trigger, when you've already given one trigger and you still see the follicle, repeating the trigger has no value. So I would just go ahead and do an IUI and also advise timed intercourse on that day and probably the next day, and follow up the patient to see what happens to that follicle.
Okay, yeah. So very important. No, most of the time this really happens in our day-to-day practice. We give a trigger more so in this lady where she has called husband. You know, we have to do what evidence is said, all said and apart. Give a trigger, and then if there is no rupture in the follicle, still go ahead. That is the mantra for that day. Yeah, no, exactly. So we are only thinking about follicle, but endometrium, of course, in this lady, it's normal. So wherever I have not put extra information, take it granted, it's normal. So in this lady, important is to go ahead and do IUI. So there are options. Most of them may think I'll trigger again. I'll give an agonist trigger. This is what common practice everybody thinks of. But for that time, for that condition, go ahead and do IUI is the first answer to the patient. Now you have done IUI. And then she doesn't like, how do we prevent such problems in her case? Like this is one case we really didn't feel good about it. You know, it didn't rupture. Something is going in the mind. So in the same case, giving an antag or postponing trigger for next day, ideally no. All papers suggest that you are given a trigger HCG, go ahead and do IUI. That should be the take-home message for today's session. But we should not get this chance again next time. So what are those things which we can prepare her for, is there anything you can say like, you know, I'll do something, some test, and I know this follicle is good. Even if it's not ruptured, it has a capacity to have a good mature oocyte. Is there any test, Dr. Shravya, you'll add on?
One thing is, ma'am, first thing, her age is 36 years. So elderly age, yes, they are at risk for luteinized unruptured follicle. But LUF is a diagnosis, is not a very common entity. Most often what happens, as Dr. Suma has mentioned, the follicle ruptures. Probably I would call her for a scan 3 or 4 days later to check if the follicle has ruptured. Because rupture of follicle need not necessarily be absence of follicle or shrinkage of the follicle. Sometimes it forms a cyst, corpus luteal cyst, and this corpus luteal cyst is essential for pregnancy support. So we'll see her 3-4 days later. So if the corpus luteal cyst has formed, it means it was not an unruptured follicle. We took the right decision to do an IUI. But let's say it looks like an LUF, like there are thick walls, there is high resistance flows, then probably since it's an LUF, next cycle I would plan for a dual trigger at the time of trigger rather than only a
will come
HCG.
now, on that day, before doing IUI, just put a Doppler if you have a luxury of Doppler. What exactly happens if a follicle is going to rupture? You know, peak systolic velocity increases when the follicle is rupturing. That means to say PSV more than 10, you are like, okay, this follicle has not ruptured, maybe it will rupture. It may have a good oocyte. Still go ahead, do IUI. And even resistant insects decreases. Means the follicle is becoming less resistant and more flow. So most of the time it's a mature follicle. This one tip we can use in our practice. So, yeah.
You are doing a scanning at 36 hours.
Yeah.
And you expect it to rupture in 48 hours.
Yeah.
And even if ruptured or not ruptured, 36 you are doing the IUI.
Yeah.
So what's the need of doing a scanning at 36?
Yeah, exactly, sir. Very good point. Sir, now IUI success rate is 15%.
No, you give the IUI and then do.
No, I mean to say, whenever we do something extra to the patient, it means to say, to know what she is. Next tomorrow when she comes without being a pregnant, I should not land up in the same way, right? We should monitor and document.
About scanning at 48 hours.
So, sir,
Not
actually,
exactly.
we do a scan at around 36 to 38 hours, basically because we time our IUI at around 36 to 38 hours. Because studies have shown that IUI, single IUI, when you're doing it, 38 to 40 hours should give you the best result.
I am talking about scanning.
Yeah.
Okay,
So
okay,
when
sir,
we call,
I agree. Point noted.
Because we
it is not mandatory to do scan. You know, you're calling the patient again. But as a good practice, if patient next month, anyway you are calling her, the follicle didn't rupture, something is in your mind. What else you will do so that next month her follicle ruptures? You have to call her. You have to call her, see her thyroids are okay, her prolactin levels are okay. Is she a PCOS? See, what are the conditions where we get follicle unruptured is what I am planning to.
Sir, answering your question,
Yeah,
sir.
anyway,
Since the patient comes for IUI at 36 to 38 hours, we do the scan and do the IUI. Let's say follicle has ruptured in 50 to 60% patients, we need not call them again for a repeat scan. In the patients where the follicle rupture was not noted, we will call them for a repeat scan.
If you follow 48 hours, only one scan for everybody.
But she has to come for
Here
an
I will
IUI
differ from sir. Ideally, success of IUI matters a lot. 20 to 40 hours is the, like if you see 1 lakh couple, you do IUI at 24 to 40 hours, your success is better. Why do you want to wait for 48 hours? These are.
I do IUI at 36 and scan at 48.
We are here to talk about what the science says. So we'll stick on to what science says. So ideally, everywhere in the history it is you give a trigger 36 hours, you do IUI. So we'll take this question. So now we have done IUI, but then next month again she comes back. It's failed. Now what are those things you should be careful of for in her next cycle? Idea is to do a day 2 scan for her always, because day 2 scan is so important. If there is already a cyst there which is 14 mm and it's what we are thinking, it's a follicle. So it's important to rule out whether it's a secretory or a non-secretory cyst. I think Dr. Kavya has already spoken about it. I won't be wasting much of the time. So whenever the follicle has not ruptured previous cycle, call her the next when she comes on day 2, do a scan, rule out a cyst. Very important. So if there is a cyst, you again want to do an IUI this month because you have planned for an IUI, do a hormone, estrogen and progesterone. See whether this is a secretory cyst or a non-secretory cyst. If it is a non-secretory cyst, hormones are normal. Estrogen is less than 50, progesterone is less than 1.5. Then you mark it as a non-secretory cyst. So once you call her on 10th day, you should see another follicle next to this cyst, because that is a real follicle. This is a cyst. So that one thing we need to adapt in our practice. Day 2 scan and also hormone evaluation thoroughly. Usually luteal unruptured follicle can commonly happen in a woman with endometriosis, subtle endometriosis, or PCOS when IH is very high, LH is very high. So these are the women. So, and then third, it can be hyperprolactinemia and any thyroid issues. So generally these are the things which you have to rule out in this women. Yeah. So next what you are ready is, now you are starting a stimulation for her. Yeah, one of the panelists can take this question. How do you start stimulating her now in this cycle? What, is there any change in your protocol?
Yes, in the next cycle, madam, we can use letros rather than clomiphene citrate cycles. And then in the trigger we can use is dual trigger rather than HCG to prevent unruptured follicle.
Yeah, so starting now she has come back again, day 2. So even I am worried now she comes back, I don't want her to have LUF. I have worked up very nicely on her. So starting stimulation, research says that changing the medication, letrozole in combination with gonadotropin prevents LUEF, better medication. So something we have to add on to her treatment. So we can start her stimulation with the, letrozole with HMG, and trigger also very important as she pointed out. Changing the trigger. Now we all know for a morning everybody has spoken. See, if you have given a clomiphene citrate, ideally the follicle ruptures at 22 mm. When the follicle is 17, if you give HCG trigger, it won't rupture. So you should know which medication you have used and when you are going to trigger. If you are going with gonadotropin, it's fine. 17 to 18 mm, almost 98% of the follicle will rupture. And also changing the type of trigger. Sometime what happens, previously HCG has not worked. Most importantly, also make sure whether somebody has given the trigger rightly. The cold chain, all that is the technical aspect. But you can also combine agonist trigger, dual trigger you can plan for her in this cycle. Yeah, so this is a brief. There is again a role of GCSF which is proven for follicle compared to others. They say no, you can even add 1 dose of GCSF when you're triggering. Previously she didn't have a follicle which is ruptured. This cycle you can use along with the trigger GCSF as well. Okay. Now this is a second case. So she is a 30 years old lady. Her husband is 32 years. They come to a clinic with primary infertility of 4 years duration. Now directly I'll tell you the diagnosis is unexplained. Everything is fine. We won't talk in depth because Dr. Suma has covered vastly about unexplained. I will just stick on to the of what exactly happened in her. So IUI, we all know that expected management and ovulation induction has same role. You don't have to wait, like you diagnose it's an unexplained infertility, we have seen prescription for 8-9 months ovulation induction. There should be a way forward now. So all studies, all ASRM, ISHRE guidelines says ovulation induction patient coming to your clinic, they're trying naturally at home is the same success rate. So, of course, when it comes to our patients, we can't directly take them for IUI because even they are worried. Convincing and counseling patients is very, very important in unexplained infertility. For this women, we have planned for a IUI. So, we started letrozole and gonadotropins. Now, follicle is 18 mm. So, but endometrium is 5.6 now. So, this is also another common scenario what you see in your regular practice. So, Dr. Kavya, can you tell me what are you going to do? And a follicle is ready, endometrium is lagging behind.
Madam, because 5.6 is the endometrial thickness, I would like to add estradiol, Valrate, 2 milligrams. I will give for 2 more days. It is only 18 mm. I will do scan tomorrow also. Tomorrow I will repeat the scan to check the dominant follicle.
Okay, so she wants to wait for another day. Let the follicle becomes 20 mm. Maybe endometrium from 5.6 without doing anything, it can become 7 because once estrogen is secreted from the follicle, endometrium has to catch up. That's a very good point what she has told. So here estrogen, anyway the follicle is ready here. Follicle is ready. It's 18 mm. It's doing its job already. Estrogen usually in a follicle which is 18 mm, 200 estrogen is already there. You give or you don't give in 200 hours, you know they say estrogen of 200 picograms per deciliter sustainedly maintained for 50 hours, LH surge happen. That is in all our textbook it's there. It is a MCQ question also. So already LH surge will happen. Now adding estrogen is taking an advantage of giving benefit to the endometrium. So now,
ma'am, ideally in this patient there are 2 follicles already. One is 18, one is 17. It's a gonadotropin cycle. Waiting now is actually risky. I would actually add antagonist also for 2-3 days.
So antagonist with IUI is a big debatable topic. We'll come to it next. So ideally what happens is you can start estrogen, no harm, one day, call her next day. If it's catched up, it is 8 mm. Ideally try and wait for one day. Second, and estrogen. Third, also monitor her. Now, once question is you start estrogen, when do you stop it is always, you know, people will think, okay, when endometrium become 18 mm, should I stop? Or continue in the luteal phase support. See, I have also gone through a lot of studies when to stop estrogen. So there are some school of thought who believe once endometrium is 18, when I'm giving trigger, I'll stop estrogen. There are some people will continue in the luteal phase support also. I respect both of their views. So there is no cutoff like you have to stop estrogen. Once the endometrium is good, it has taken over. If it is strong, triple line, you can also stop estrogen when you trigger. That is also a possibility. So now in this case, endometrium is thin, you have started estrogen. What does the study says? Yeah, so which is the medication of choice, which we all know about CC. I don't talk too much about CC because we have all changed most to letrozole. And end of the day, all studies says that the stimulation with gonadotropin having endometrium thin is less compared to oral ovulogens. So this thin endometrium we have as CC means you have to lower the dose. That is okay. Now what are the role of others? Aspirin, sildenafil. Do you add all these in your protocol?
Yes, ma'am. We add aspirin. I add low dose aspirin. I give sildenafil also. 25 milligram QID vaginal.
Yeah. So this is all the things we all follow regularly. Whenever there's an thin endometrium, start estrogen, then you give aspirin, then there's no ecosprin. If you have to see, even this was a study which was published in the Cochrane as well. What is the dose? You start estrogen. Ideally make sure follicle is selected and it's dominant. It's already 15 mm, 14 to 15 mm. Now giving estrogen at this juncture won't suppress the follicle. If you give a estrogen when the follicle is more than, earlier phase, it suppresses the follicle itself. So, sildenafil, this is the dose, 25 mg vaginal 4 times a day. Vitamin E, pentoxifylline can be tried. Aspirin, all these can be tried to increase the endometrium. So, after said and done, after all that, so still there is an issue, then intrinsic problem of endometrium, we have to rule out hysteroscopy. That will be the last resort. If doing everything still it fails to catch up, then there is a problem with the endometrium itself. Here is the only time when I do hormone test. If estrogen I do blood, I take the blood sample and see estrogen. If it's 250 estrogen, then follicle is not the culprit. It is giving good estrogen, but endometrium is the culprit. It's not able to act with such good estrogen. Say suppose estrogen value is 50 or 100, then that is a cyst. It's not a follicle. It's not secreting so much estrogen. That's why endometrium has a problem. This is one thing which we can adapt, and before putting a hysteroscope we can think about. Now this is a third case where 28 years old, she has come married for 3 years. So she has irregular cycles. Very common, no, in our practice, every 2.5 months she has her cycle, and she's 90 kgs obese. So she has already seen, once they are weight, every doctors, talk only about weight to her. They don't even bother to talk about treatment. So she goes to Google, let me seek help from somewhere at least. So then they say, okay, she wants an IUI. So what are your advice, Dr. Shravya? Can you take this question?
From the history, it looks like she's an obese lady with irregular menstrual cycles, so anovulatory cycles. So one thing, a day 2 scan to see if she's a case of PCOS. And first thing I would advise is lifestyle modification, because even 5% reduction in weight causes significant improvement in her hormonal status. And second, I would not wait for weight loss. I would start ovulation induction simultaneously along with lifestyle modification.
Yeah, exactly. So lifestyle modification, it's very important, giving her the understanding that 5% of her weight matters a lot. Most of the time 60% without any medication they have, every month they get a cycle, and 30% spontaneous pregnancy can happen. But all said and done, it's not an easy task you do to reduce weight. We all know about it. And then what does the guideline says for PCOS? First is lifestyle modification. Then now if she is coming for induction, what is the drug of choice? Dr. Suma, you can take this.
I'll go with letrozole and gonadotropins combination.
Okay. So letrozole is the choice. All the guidelines has said in PCOS, letrozole is the first line of treatment for ovulation induction. If now she has, now she has come to you on day 9, you have started letrozole. What is the dose you start with ideally?
5 mg.
She is 90 kgs.
90 kgs. 7.5 mg can also start.
So here is another tip. A 90 kg lady, 2.5, please don't even think. You don't even have to call her on 9th day. The threshold dose is not met for her. So selecting the threshold dose is very important. Weight, BMI, age, previous response, everything. You go back to the case sheet and see whether previous cycle with what dose she has ovulated. Say suppose 7.5 mg is her threshold dose. With 7.5 mg letrozole, on 9th day she is getting one 12 mm follicle, then that is the threshold dose, mark it. So next month start with the same dose. So in her case, since she has come for the first time, 5 mg is, okay, we can start. Now she has come to you on 9th day, you have started 5 mg. She's sitting in front of you. She is 9th day, you do a scan, there is no dominant follicle.
Increase the dose to 7.5 and continue.
Yeah. So most of the time what happens is, in our busy practice, on 9th day, there is no dominant follicle. We have some delivery waiting. That's also very important. Here, what do we do? No, there is this for this month, it's not okay, come next month. What happens now? Once in 3 months she ovulates. She'll see you only after 3 months. So at least go little extra mile and give her some progesterone support so that her time to pregnancy, or as she told, time to pregnancy is very important in PCOS. Increase the dose. She will never have OHSS. She has come on 9th day, 5 mg is not her threshold dose, make it 7.5 mg. After 3-4 days call her. Most of the time one follicle will become dominant. You are saving her 3 to 6 months now. So this is also very important. All the protocols, stair-step protocol, You don't have to wait for day 2 of next month. There and then itself increase the dose. You're crossing your threshold dose. And in PCOS, the window period is prolonged. They have a very long window period. So go ahead and increase the dose. So of course, weight loss, metformin, myonisitol, all has their own glory and it has a positivity. And then about glucocorticoid, already Dr. Shravya has, Dr. Kirti has spoken about. One quick word we can add. Before starting glucocorticoid, do a sugar test because very important, no? They are more prone for insulin. So next do a sugar test, and also you can start glucocorticoid if her adrenal values, DHEA more than 200 is the cutoff which helps her. You can start dexamethasone 0.5 mg from the day 2 itself and continue. That also helps her in resistant PCOS. Okay, so next, so PCOS has come. So a rapid one answer I want. What are the other tests what you do so that in resistant PCOS, when you see, what are 2 important tests you do to rule out other hormone conditions? So in a resistant PCOS, also sometime in a hypogonadism, the follicles are all like that, same like PCOS. But hypogonadotropic hypogonadism, we can't start with oral ovulogins. We have to directly go with HMG preparation. So that you need to rule out. Persistently for 4-5 cycles, she is not ovulating at all. Is there something else I am missing on? Do a day 2 FSH and LH. FSH less than 1.2, LH less than 1.2, 1.5. It means their hypothalamo-pituitary ovarian axis is having issues. So then you have to change the whole treatment protocol itself.
Hyperprolactinemia also.
Yeah, even prolactin. Once prolactin is very high, whatever medication you give, it won't act. So make sure prolactin test is also done. So now this is third, the same lady, now continuation. Now, sir, I want to ask this for you. So when do you want to consider ovarian drilling for her, sir? Yes, of course, it's a part of management. Whenever oral ovulation fails, second in PCOS Krinos guidelines 2018 is beautifully elaborated. Second, whenever comes second management, it's gonadotropin or ovarian drilling. So when do we debate which is better for our kind of women? So, sir, can you normally or
if they could not respond to the go for doctor.
Yeah, suggestion taken, sir, definitely. There are various.
Lean with high LH.
Yeah, agreed. So we have certain conditions only when we have to drill ovary. We should be very careful about
PCOS with high LH.
Exactly.
More than 10.
Yeah.
Precisely.
So there are certain conditions where we have to when we should not drill. As a gynecologist, we should know when not to drill and when it is important to drill.
The ovarian volume is less than 10, we don't do
Exactly.
it.
So all the studies have shown that there are only advantages of drilling. Say suppose, disadvantage is adhesion formation is there. Premature ovarian follicular, what happens, ovary fails if you drill so much. So all these problems are there. Then never drill the ovary, we should know. When we should not drill the ovary? When the ovarian volume is less than 10. Volume, it's a very small ovary. Why do we want to drill? And also FSH more than 9. It's already failing ovary. And then even previous already ovarian drilling is there, please don't drill. So only women where we drill is resistant PCOS. All ovulation induction method has failed in her. And we give little dose of letrozole, she'll go for OHSS. There are some patients, we see for PCOS, what happens is the threshold dose is very cranky. You give 5 mg, you don't get follicle. You make 7.5 mg, you get 6 follicles. They are lean. These are the women where we feel, lean PCOS who may help in drilling. LH is more, androgen is more, and also if they are not able to come back to you, they stay somewhere, for 6 months there is no monitoring. Otherwise, most of the time as a fertility expert, my choice of drug is gonadotropins. Very rarely on very specific condition, we go for drilling.
But that is before laparoscopy.
Yes, sir. So I think there is a shift. What 10 years before I used to see practice was most of the surgeons used to come and they used to not even know history properly. Very big ovary, it's so glistening, I will drill. That was the practice 10 years before.
Actually, it was always said that big, bulky, bald ovaries. So normally when we drill, if we see signs of ovulation, never to drill that ovary, because it means that she is ovulating. But if the stroma is thick, then it will be like thick, big, bulky, bald ovaries, then we can drill, because now the drilling dose is also according to the ovarian volume.
Exactly. Yeah. So ovary is very caution, you have to handle it. And always a woman is ovulating. Every month she has a regular cycles. Don't even think of drilling that ovary. She is already ovulating. So why do you want to drill? Now, when do we cancel? In a lady with PCOS, what are the conditions when you say, no, I don't want to go ahead? So you have started gonadotropin for this woman, and she has come to you. There are 4 follicles which are 14 mm now. So what do you do now? Do you tell her I will go ahead, or you will tell I'm going to cancel this cycle?
You should cancel the cycle, ma'am.
Yeah.
If there are more than 3 follicles of 16 mm size or more than 5 follicles of 12 mm size and estrogen more than 1500, we have to cancel the cycle.
So these are very important, when to cancel the cycle is also very important. See, if you see the guidelines which is released in ISHRE, they say any follicle more than 2. But 2 and 3 is something which you have to take a call. See, how I do our practice is in a woman with unexplained infertility. If she is non-PCOS, 3 follicle, I go ahead and do IUI. I'll be very vocal about it. Because getting 3 follicles is my pregnancy rates is almost there. In an unexplained. But in a lean PCOS, 3 follicles is dangerous because she has VEGF already there, because of PCOS. This HCG trigger is the criminal which tag alongs with VEGF. But in an unexplained woman, getting 3 follicles is good. So it's very important which woman you are dealing with. So cancellation criteria for PCOS agreed. 3 follicles you see, please cancel, because there are so many other issues associated with that. Yeah, perfect, sir. So again, there is a debate whether go ahead with agonist trigger.
Agonist trigger can prevent OHSS, but it won't prevent multiple
pregnancy. That's the only issue. Triplet chances are more common. See, always PCOS, how much ever, till now it's a challenge even for us. Because these all follicles antral count, when we see all follicles are same 66666 mm, they're all together. Either they come out together or they sit back together. On day 2, if you see any lady scan, normal responder, one will be 6, one will be 4, one will be 7. They're all, different, threshold is different. But for PCOS problem is, most of the follicles, the threshold is same. Either for 75 you get many, or at 50 you don't get at all. So striking balance, of course lifestyle modification, metformin, all those also pre-treatment makes a difference for them. Yeah, next is we'll come into our andrology topic. So this is a software couple. They are married for 2 years. Now husband's sperm count is 20 millions. Motility is 30%. Scrotal Doppler shows varicocele of grade 2 and he's advised surgery already. He has come for a second opinion to our sir here. So what is your advice, sir? What do we say? What do we do for this man who wants to get a varicocele operation done?
The thing is, if they have tried for 1 year and not conceived, so I think I go for an IUI initially. If the IUI is failing, then go for varicocele correction. Okay. This is how it should go. That's what I feel.
Okay. So now this is a man where the sperm parameters are normal. Grade 2 varicocele. So when it comes to varicocele, we should understand there are 2 types of classification.
There are many types, madam. Out of them, basically, clinical classification is there, ultrasound classification is there. In clinical also, there is so much of debate between the surgical andrologists and non-surgical andrologists. In the West, most of the andrologists are physicians. Here we are surgeons. So we slightly lean towards surgery and we say that it is evidence based and they say that it is evidence based. Whatever it is, when the vein diameter is more than 3 mm, there is no doubt we have to go ahead and operate. But when the vein diameter falls between 2.5 and 3 mm with Valsalva, is a question of debate. I personally go and operate with much good results, but there are some people who wait and treat with antioxidants. They are also getting somewhat
So
good
as
results.
sir rightly pointed out, perfect. So any, clinical varicocele, which is palpable in clinically, and also in supporting with, he is infertile, it can be an unexplained infertility, or there can be decrease in sperm parameter. So there is something, this varicocele correction will help us, achieving in pregnancy. So all this studies says the strong recommendation is infertility is important, that they are not able to conceive, and there is a decrease in the sperm parameter, along with there is a clinical palpable varicocele or a grade 2 varicocele in scan. So these are the only places where I think sir also has perfectly elaborately explained about it, where there is a view of varicocelectomy, because end of the day, as I told, for today practice, this is what we follow. Tomorrow we don't know when new guidelines may come. So we have to keep understanding, we have to update ourselves and also see what is correct for the couple.
And one more point I would like to mention at this juncture. Previously, we used to see varicocele as secondary infertility, because they get one child, and later when they try for second kid, it's not happening. But now they are coming with primary infertility. Why? Because the age of marriage is going up. Previously, 25-year-old one male gets married and 20-year-old one woman gets married. Now it's not there. So 30, the girl is still thinking, I am still a kid. Why do I go for a pregnancy? But that is the changing in scenario. Everyone knows. So let us correct the varicoceles at the earliest, so that they get their own child. Madam, varicocele is commonly present in 15 to 20% of all the individuals. When we randomly take 100 males, out of them 15 to 20% it is there. But in some of them it is progressive, and it is going to stage 2 to stage 3, stage 4, like that. So in the elderly it becomes progressive and we can see it.
So exactly. So in this person, there is a role of antioxidants also, as morning Nagori sir has elaborately explained, role. So I won't be touching upon it. Now, as we have decided for this couple, we are not going with surgery. We are planned for a IUI. Now, after all the said and done, with so much doubt, this couple have come. We are here started stimulation. And then on the day of IUI, trigger is already given. Husband is there, but he is having difficulty in giving sample.
This is a common occurrence, madam, because it is a strange atmosphere. Man cannot just give semen like urine, so he can collect at his home, or sometimes we send the partner into the room so that they can collect. And I always give 50 mg of sildenafil citrate, so that they can, actually volume also will become better, semen volume. And vibrator, yes, with all these measures fail, I use this, have the similar kind of vibrator. It yields good results in 20 to 25% of cases. And this non-spermicidal condom I have never used, but frozen sample, yes, we can consider, madam.
Yeah. So very valid. So all this stress, we should not forget about, this part as well. So about home collection of sample, now law has become so strict, right? Home collection of sample, not ideally advisable, but still if there is, because the way they get the sample, the time duration, all these matters, and we don't know exactly what exactly the sample is from.
When they get the home collected sample, they have to fill a declaration that it is his own sample,
what
which
are
is
the,
to be countersigned by the wife.
So it's very important. We have a responsibility in the center when they come home collection, as Dr. Suma has told. That was my next question. A declaration has to be signed, because tomorrow again after 4 years they come back because some DNA test they do and they say you have mixed up the sample. We should be ready with an answer. So a declaration is most important.
And one more thing, they have to keep the container in their
pockets,
not on the opposite to the AC vent.
Yeah, exactly, exactly. So now we'll move on to the case 5. So in 5 minutes we'll wind up. I think it's already 4:45, just 5 minutes. So this is a couple who was married for 4 years. Normal reserve. Tubes are patent. Husband is diagnosed to have azoospermia. They're not affordable for ICSI. So now donor insemination has been planned. So that is one important take home. If somebody comes and sits in front of you and asks like, how much probability is that I can become a genetic father? One quick test is Y chromosome.
And one more quicker test is there. In males also we can do FSH.
Yeah.
If
FSH
the
and
FSH
testosterone is the
less,
first actually. First test, yeah. So FSH is the one test which we also have to have. See, whenever FSH is very high, like a woman, FSH more than 20, male more than 20, chances of getting sperm is almost nil.
Testicular volume.
Volume. FSH in women is around, I remember it very easily, 3 to 8 in women. Similarly in men 3 to 8, it's obstruction. So it's easy to get the sperm, in the regular process. Okay, thank you for that. And then next, I think by all these have been difficult entry we have already covered, so I won't go about this case. So about only fibroid, we'll end it with fibroid because this is one topic which we did not cover. So this is a woman, we'll just get straight into the topic. She has come, she's 35 years old, 2 years, and she has spasmodic dysmenorrhea, symptomatic she is. Borderline ovarian reserve, 2 fibroids are there, one is 3 centimeters, one is 2.5. Now, fibroid and ART outcome. What do you do, Dr. Shravya? How do you manage this case?
In this case where it was mentioned 3 centimeters fibroid and another 2.5 centimeters, both FIGO4 was mentioned. So if it is intramural myomas, I would look whether it is cavity distorting or not. That is it close to the junctional zone? If it is more than 5 mm away from the junctional zone, we would not operate on the patient unless it is a patient with previous pregnancy losses or implantation failures. But ideally in this condition, we would not consider myomectomy.
Okay. So ideally just ending up the session, in fibroids, most importantly is submucosal fibroid, infertility. You have to, operate. There is no second thought about it. Intramyometrial, subserosal, whatever the size is, no need of operating. Submucosal, intramyometrial, most important, everybody is confused here. What about it? So most of there are 2 different opinions. In some guidelines they say intramyometrial, if it's not distorting the cavity, number 4 or 5 or 6 or 7, placement doesn't matter at all. It doesn't cause infertility. But there is another paper which was, this paper which came into conclusion with the size of the myoma, 4 centimeters. That's why we are always with 4 centimeters. They say more than 4 centimeter closer to the junctional zone, and if there is infertility and if there is recurrent implantation failure, go ahead and go and operate. So this is, I think, about fibroid very quickly covered. Thank you so much for all your patient hearing. It was a fantastic session. I really enjoyed Vizag crowd. Thanks for being here and making this program a grand success. And I also learned from Dr. Sunita Tandulwarkar. She is contesting for Foxy election. So I am supporting her because she is too much into academics. So it's again left to you. At least vote whomever you want. It's your choice. Thank you. Yeah, thank you so much. Any questions, or I think it's already late. We will all close it for the session. Thank you.
Hi, I'm Dr. Saujanya from Maharaja Institute of Medical Sciences in Vijayanagaram. I'm doing my final year post-graduation, and I used to attend many kinds of CME on infertility because I was interested in IVF more. So on attending many IVF CMEs, as Ferty9 was performing this CME, which is very wonderful, and I felt overwhelmed by all these medical techniques on in vitro fertilization and IUI, ICSI, and we got to know many other techniques, and also the techniques which are CC resistant, and also even super extended IVF techniques, and there are many other that I have learnt so far today, which are mostly according to the art of law. That is even more interesting, and so that we can know the people who wanted to become IVF specialists can understand that how far this subject is, and how difficult and how challenging this IVF is, and I'm so happy to attend this IVF CME on Ferty9, and thank you Ferty9.
Excellent conference, very informative. Learned lot of information from attending this conference. Thank you.
Hi, I'm Dr. Mahati. I'm a laparoscopic specialist from Vizag. This is a very interactive session by Ferty9. I thank everyone for conducting such a wonderful, interactive and a very good session on basic and advanced infertility. Thank you so much.
Yeah, it was good. It was useful for those who are not practicing regularly infertility also can gain much knowledge and start practicing infertility. It was very good.
Raju, President of Obstetrical and Gynecological Society of Visakhapatnam. Ferty9, they conducted CME program. It is very informative, nice, felt very happy. They go give.
This is the CME, one-day CME conducted by Ferty9 in association with OGSV Visakhapatnam. It's a very really informative and excellent CME, and we all thoroughly enjoyed and updated in the field of IVF, and it's for common gynecologists like general practitioners. It is very useful.